My name is Hemant Sharma and I am Lead Partnerships and Development at Khushi Baby and your co-MC for the event. I've had the fortune of connecting with many of you in these last few days and weeks, and it's great to now meet you in person. On behalf of the Khushi Baby team, I would like to extend my warm welcome to all the participants in our second annual Stakeholder Summit. This year we have 30 partners, some bravely facing a few kilometers of Delhi traffic, and others making the journey from Seattle. We are truly humbled and honored to have you here. Before we get started, I would like to cover some basic housekeeping. Please take a moment to look around and identify the nearest exit in case of an emergency. There are restrooms located outside to the hall and pre-conference area. Please silence your cell phones, it's a request, but please feel free to live tweet the event or take notes. QR codes are available on each table with summit material and will be updated after the event as well. The virtual folder also have a Google form that can be used to submit questions that we will collect for our Q&A sessions. Everyone has color-coded lanyards representing their respective primary domain, be it government, technology, research, or funding. If you have any questions or concerns, please approach any members of the Khushi Baby Organizing Committee who can be identified by their lanyards. Great. So without further ado, let's get started. It is my distinct pleasure to start by introducing Dr. Ruchit Nagar, Khushi Baby's CEO and co-founder, to share our summit agenda. Dr. Nagar is a senior resident physician at Yale New Haven Hospital, training in combined internal medicine and pediatrics. He co-founded Khushi Baby as an undergraduate student at Yale in 2014, where he could go on to complete his master's in public health, training in epidemiology of microbial disease and global health. Dr. Nagar continued his training at Harvard Medical School, where he graduated magna cum laude. He served as a special advisor to ex-ACS Health of Rajasthan during the first wave of the COVID pandemic. He has been recognized as a Forbes 30 Under 30 leader in healthcare twice, and as a distinguished young alumnus of the Yale School of Public Health. Ladies and gentlemen, please welcome Dr. Ruchit Nagar.
All right, can everybody hear me? Great. So thanks, Hemant, for the very nice introduction. On behalf of the entire Khushi Baby team, we are very honored to have you all here. I want to start by a small disclaimer, the same disclaimer that I had given at our last summit, which is that we are here for self-promotion, okay? That's the reason why we are holding this event. It's a selfish goal, and Khushi Baby is looking to promote itself. I want to be very clear about that. But at the same time, the reason why we're trying to promote ourselves is because we believe that we are doing good work and that we have a chance to make impact on the ground, and that we can only make that impact if we work together. There is a famous African proverb that says, to go fast, you go alone, but to go far, you go together, and that's why we are all here meeting today. So I want to just give a brief on what our agenda will be for today. We have a packed session we have a packed day with 5 sessions, in fact. So we'll start off by talking about the pain points experienced by community health workers and what is their lived experience. So essentially empowering the world's largest community health workforce with over 1.4 million community health workers here in India. What do we need to do? What perspectives do we need to incorporate when we're thinking about our solutions? Second, we'll be talking about building India's digital health ecosystem. So you may all be very familiar with the Ayushman Bharat Digital Health Mission. What are its challenges? What are its opportunities? What are the gaps that it needs to cover in the coming years? And how do we fit within that? Then post-lunch, we have 3 sessions. First will be on big data for big data-driven interventions for public health impact. So we'll give some clear examples of how public health data is being used to make an impact within communities at the last mile. And then the 4th session I'm very excited about, where we will show multiple examples of how the health worker's smartphone can really become a tool for making impact as well, by incorporating things like artificial intelligence and upcoming technologies. And finally, we'll discuss the perspectives around funding innovations for emerging global health challenges, whether that's pandemic preparedness or climate and health, or the intersection between these different health domains. How do we fund this work and move it forward? So in order for us to have this conversation, we're so glad to have 130, 140 participants from over 30 partners. It really is a team effort. So you should all give yourselves a round of applause for being here and being part of this conversation. And at the same time, I'd like to recognize the Khushi Baby team as well. So we are a team of 75 people, and we span the domains of public health, policy, design, product, software development, data engineering, data science, field implementation, field communication. It's truly an end-to-end approach that our team tries to put together in order to deliver digital health solutions for the public health context. So everything that you've seen here today and you will see here today is a huge credit to the team that's around you. In fact, I'm going to ask them all to stand up so that they can be recognized. All right. So before we get into our first panel, I want you to also have a little bit of a brief about what is Khushi Baby, what do we do, why are we here? Some of you may be meeting us for the first time. So, the name Khushi Baby, Khushi means happiness in Hindi, right? Happy baby. 9 years ago, we started off with the concept of trying to promote immunizations for babies so that they could be healthy and happy. And 9 years later, we have grown from child health into almost every primary healthcare domain. So now it's more about having a Khushi village or a Khushi community. Our mission is to empower community health systems at the last mile with innovative digital health platforms to drive transformative public health impact. And our vision is a resilient, data-driven health system in which each child, family, and village has the opportunity to be healthy, happy, and Khushi. So that's what we want to do. That's why we wake up in the morning. But how do we actually get there? What does Khushi Baby exactly do? Digital health solutions, maternal and child health. There may be some questions that you may all have, but we have a video now that will hopefully help explain this. And then throughout the day, you'll get a better picture of what Khushi Baby is and how we fit within this ecosystem. So over to you, Tarun.
In the heart of rural India, amidst the sprawling fields, lies a complex challenge. Access to essential healthcare. 900 million people in the world's most populated country live in remote, underserved communities with limited access to essential health services. Despite making progress in reducing maternal mortality by over 75% in the last decade, India's public health system needs to address several urgent priorities. One out of every 10 women have an unmet need for family planning services. Over 2.5 million children are unvaccinated. 1 out of every 3 children are stunted or underweight. 2 out of every 3 cardiovascular deaths are premature. Nearly 400,000 people die of TB, accounting for the largest burden of global deaths. With 200,000 plus cases of dengue annually, India represents the world's largest share of cases. 500 million people are exposed to pandemic jump zones, and approximately 200 million people will become vulnerable to lethal heat waves by the end of this decade due to climate change. Despite the silent struggles, there is hope and optimism for India's public health system. And the reason behind that hope is Khushi Baby.
To address these issues at the last mile, Khushi Baby is working hand in hand with community health workers and officials to build a new digital health ecosystem. Our vision is a resilient, data-driven health system in which every child, family, and village is supported to achieve happiness and well-being. In other words, Khushi.
India has 1.4 million community health workers, the largest such workforce in the world. These community health workers face numerous challenges, from burdensome data entry procedures and unrealistic health targets to delayed remuneration.
We realized that unlocking the potential of community health workers can lead to a large impact in health outcomes. So we identified the gaps, we understood the silos that existed within the digital health system. We have spent more than 200,000 man-hours in the field with frontline health workers to co-design a solution. And that's when the Community Health Integrated Platform or CHIP was born. It is a unified, offline, longitudinal application that is not just a tool but a companion for our frontline health workers.
गावाना सोरन एवं हाल साल यो है कि टाइम आते खाबो खवाड़े और टाइम आते साफ सफाई जुलाड़ वहाँ पड़ो सब टाइम आते करावे तो नहीं अब ठीक है स्वास्थ्य में ठीक रहे बीमार था जाते टाइम आते हॉस्पिटल ले जावे के अंदर टीका कराड़े इलाज करवाड़े अब ठीक है बच्चे
पहले हाई रिस्क गर्भवती जब डिलीवर्ड होने जाती थी जब पता चलता था और अभी है जो हम ऐप में काम करते हैं तो तुरंत हमको सारांश में हाई रिस्क का है भी बता दिया जाता है और उनको हम रेफ़र भी करते हैं और आगे जाके महिलाएं चेकअप भी करवा के वापस आके हमको बताती है.
MO app is very helpful. We are having all the records and we are able to see what ANMs are doing and how they are referring the cases.
पहले तो 2 दिन से तैयारी करते थे कि हमको रिपोर्ट में क्या क्या भरना है, क्या हमारा छूट रहा है, कुछ छूट जाएगा तो रह जाएगा, यूँ करके हम पूरा 2 दिन तक पूरा करते थे. मतलब कि एक दिन थोड़ा क्या फिर घर का काम भी रहता है, थोड़ी देर घर का काम करते फिर आंगनवाड़ी काम सब करके फिर दूसरे दिन हम लेट तक बैठते थे, यूँ करके पूरा करते थे. अब तो बस हम ऐप पे खोलते हैं और खोलते ही हमारा पूरा डेटा निकल जाता है.
Earlier, community health workers were working in silos on a mix of paper and digital systems. This technology, CHIP, provides a unified solution that brings together ASHAs, ANMs and MOICs and allows them to track each patient's health longitudinally. CHIP's tremendous potential is improving and even saving lives.
ईश्वर नाम का लड़का था, ईश्वर सविता फतेहलाल. जो बच्चा जन्म के समय तो नॉर्मल वेट था 2.5 किलो था उसका, लेकिन जैसे जन्म के बाद 3 महीने बाद उसका एकदम से वजन 1 किलो पे आ गया और बच्चा बिल्कुल हड्डियों का ढांचा हो गया, जर्जर ढांचा बन रह गया था. MCHN पे हमारे विजिट करने के दौरान पाया गया कि वो बच्चा बिल्कुल कमज़ोर है, 1 किलो वेट है उसका. तो फिर हम लोगों ने उसको ब्लॉक लेवल तक उसको उस डेटा को शेयर किया, हेडक्वार्टर शेयर किया, फिर उसको RBS की टीम से टेक करवाया, यहाँ से उस जाड़ोल से रेफ़र करके उसको डिस्ट्रिक्ट MTC वार्ड भेजा गया, जहाँ पर एक बार 13 दिन रह के वापस उसको रेफ़र किया, घर लौटा. दूसरे दिन 3-4 दिन बाद घर रह के वापस उसको बुलाया गया, वापस गया तो 12 दिन तक कुछ और भरा वहाँ. उसके बाद उसका धीरे धीरे वापस उसके बॉडी में इम्प्रूवमेंट हुआ, वो एक सामान्य कंडीशन में वापस आ गया. मतलब उस घर पे अगर हम विजिट नहीं करते, अगर 1 या 2 दिन में अगर और देरी होती तो शायद वो ईश्वर आज नहीं बचता.
बहुत जो बीमार हूँ, हालत अच्छा निकलेगी कहीं नहीं हूँ. डॉक्टर सब आइया उदयपुर झाड़ू मोकली झाड़ोल उदयपुर मोकली दवाई ने गोली ने सब की दी. अब बात ठीक है, बच्चों रोटी खाए है ने सब हाउ है, बात है ठीक हुई है बात. नहीं तो नहीं लग जाता डॉक्टर साहब ने कई हालत नहीं है, कहीं बे जाता मोड़े आदमी बीमार हो.
Khushi Baby is also augmenting its approach to field visits with AI. The CHIP system uses AI to both prioritize the highest risk patients as well as turned the smartphone into a new diagnostic tool to detect anemia, undernutrition, TB, and urinary tract infections.
It is not just a technology, it is a tech, team and tradition that allows us to make a difference at the last mile. We have a team of designers, software developers, data analysts, field monitors and policy advocates who work together to ensure the end-to-end deployment of this digital health platform.
How can Ishwar's case be scaled to a population of 900 million people? Empowering health workers is one of the pieces to the puzzle. The other piece is leveraging this granular public health data collected by ASHA workers to inform data-driven decision-making at the local level and at scale. Health officials now have new tools to see village-level data on the multidimensional poverty index, areas where zero-dose children are living, or even driving times to the nearest hospital. They can use the dashboard for personalized and automated communication with health workers and community members to spread awareness and combat misinformation.
इससे एफिशिएंसी बढ़ गई, हमारी प्रोडक्टिविटी बढ़ गई, क्योंकि पहले जो मैनुअल की बात करें, डेस्कटॉप की बात करें, उसके मार्फत से हमें चैनल हुआ करते थे। अभी इसमें कोई इंटरवेंशन नहीं है, हम सीधे ही डायरेक्ट कांटेक्ट में रहते हैं इसके माध्यम से। तो निश्चित तौर पे इससे ग्रामीण के धरातल पे जो सेवाएं हैं मेडिकल हेल्थ की, हम प्रभावी रूप से उनको सुधार पाएंगे।
We are encouraged to see the Ministry of Health invest $15 million in community health workers to digitally enable them on the CHIP platform at scale.
We are already seeing the devastating impacts of climate change on health and their spillover effects on health inequities. Emerging pandemics make it more important than ever to have proactive and intelligent community health systems.
Today, CHIP has already reached 70,000 ASHAs and impacted 45 million beneficiaries in India's largest state of Rajasthan. Every day, Khushi Baby is learning and innovating with their world-class partners to make the platform even more impactful for these remote, underserved communities. Like they say, it takes a village to raise a child. It truly takes one to raise a happy baby. Or as we like to call it, a Khushi Baby.
Thank you. We would now like to introduce the first panel, Empowering the World's Largest Community Health Workforce. India has the world's largest community health workforce with a team of over 1.4 million ASHA workers. Last year, WHO recognized the ASHA workforce as the recipients of the Global Leaders Award. Through this panel, we hope to understand the field reality experienced by community health workers, how digital health is changing the landscape from training to service delivery, and how the voice of the community health workers can be further amplified. We will continue in Hindi for the remainder of this panel. अब हम पहले पैनल विश्व की सबसे बड़ी कम्युनिटी हेल्थ वर्कफोर्स का सशक्तिकरण का परिचय कराना चाहते हैं। भारत में विश्व की सबसे बड़ी कम्युनिटी हेल्थ वर्कफोर्स है, जिसमें 14 लाख से अधिक आशा कार्यकर्ता हैं। पिछले साल WHO ने आशा कार्यकर्ताओं को ग्लोबल लीडर्स पुरस्कार से सम्मानित किया था। इस पैनल के माध्यम से हम कम्युनिटी हेल्थ वर्कर्स द्वारा अनुभव किए गए फील्ड रियलिटी को समझना चाहते हैं। डिजिटल हेल्थ कैसे ट्रेनिंग से लेकर सर्विस डिलीवरी तक के लैंडस्केप को बदल रहा है और कम्युनिटी हेल्थ वर्कर्स की आवाज़ को और कैसे बढ़ाया जा सकता है। कृपया हमारे पैनल मॉडरेटर श्री हामिद अब्दुल्ला का स्वागत करें, जो खुशी बेबी में इम्प्लीमेंटेशन लीड हैं। हामिद 2016 से खुशी बेबी के साथ हैं और उदयपुर डिस्ट्रिक्ट में ज़मीनी स्तर पर काम को आगे बढ़ा रहे हैं। अब हमारी पहली पैनलिस्ट श्रीमती भारती मेनारिया जी हैं, जो कि आशा कार्यकर्ता डिस्ट्रिक्ट उदयपुर हैं। भारती जी आशा के रूप में उदयपुर के सलुम्बर ब्लॉक में कार्यरत हैं। अच्छा जी, मैं अब आमंत्रित करना चाहूँगा श्रीमती ज्योति दामा जी को, जो कि ANM डिस्ट्रिक्ट उदयपुर हैं। ज्योति जी ANM के रूप में उदयपुर के झाड़ोल ब्लॉक में कार्यरत हैं। इसके बाद हमारे साथ डॉक्टर अपर्णा हेगड़े हैं, जो अरमान संस्था की फाउंडर और चेयरपर्सन हैं और एक प्रैक्टिसिंग यूरो गनाकोलॉजी सर्जन हैं। डॉक्टर हेगड़े एक स्कोल पुरस्कार विजेता 2020, वरिष्ठ अशोका फेलो 2021 हैं और उन्हें फॉर्चून पत्रिका की 50 महानतम हस्तियों में 2021 की सूची में 15वें स्थान पर शामिल किया गया था। अंत में हमारे साथ डॉक्टर दीपिका सलूजा हैं, जो वुमेन इन ग्लोबल हेल्थ संस्था की फाउंडर हैं। डॉक्टर सलूजा के पास 1 दशक से अधिक का कंसल्टिंग, रिसर्च और इम्प्लीमेंटेशन एक्सपीरियंस है, जिसमें जेंडर और हेल्थ, फ्रंटलाइन हेल्थ वर्कर्स, SRHR, मेंटल हेल्थ और अकाउंटेबिलिटी शामिल हैं। वह वर्तमान में अफ्रीकी महाद्वीप में इक्विटेबल पार्टनरशिप के निर्माण पर जॉर्ज इंस्टीट्यूट फॉर ग्लोबल हेल्थ के साथ काम कर और इम्यूनिफाई में सर्वाइकल कैंसर पर रिसर्च और एडवोकेसी के प्रयासों का नेतृत्व कर रही हैं। हामिद, माफ़ी चाहते हैं हमारे पैनलिस्ट के छोटे परिचय के लिए, लेकिन उनके डिटेल्ड प्रोफाइल आपको टेबल्स पे उपलब्ध वर्चुअल फोल्डर में उपलब्ध है।
थैंक यू हेमंत जी। तो इससे पहले कि मैं अपने क्वेश्चन से स्टार्ट करूं ये डिस्कशन, मैं भारती मेनारिया जी और ज्योति जी के साथ पिछले 7-8 साल से काम कर रहा हूं, तो मैं चाहता हूं कि आप इन सभी को रिकग्नाइज़ करें, अप्रिशिएट करें। कुछ हेल्थ वर्कर हमारे साथ यहाँ है, लेकिन कुछ हेल्थ वर्कर यहाँ हमारे साथ नहीं है, लेकिन मेरी ये दिली तमन्ना है कि वो भी यहाँ हमारे साथ होती और हम सभी को अप्रिशिएट कर रहे होते। हम उनका हार्ड वर्क जो वो फील्ड पे कर रही हैं उनको अप्रिशिएट करते। तो मैं आपसे रिक्वेस्ट करता हूँ कि आप सभी ज़ोरदार तालियों के साथ इन सभी का स्वागत करें। मैं जिन भी मीटिंग्स में जाता हूँ, या सेक्टर मीटिंग पे, ब्लॉक मीटिंग पे, या डेवलपमेंट पार्टनर्स की कुछ मीटिंग्स पे, तो जब से कोविड हुआ है तो सारी मीटिंग्स में ये डिस्कशन होता है कि कोविड में हेल्थ वर्कर ने, आशा ने फील्ड लेवल पे बहुत ज़्यादा हार्ड वर्क किया। लेकिन मैं इस बात से एग्री नहीं हूँ। ये मेरे दिल में अंदर ही अंदर चलता रहता है कि ऐसा नहीं है कि हेल्थ वर्कर ने सिर्फ कोविड में हार्ड वर्क किया, वो इससे पहले भी हार्ड वर्क कर रही थी और कोविड के बाद भी हार्ड वर्क कर रही हैं। वो स्टार्टिंग से ही हार्ड वर्क कर रही हैं। अब मैं भारती मेनारिया जी आपसे जानना चाहूँगा, क्योंकि हमारे साथ यहाँ ऑडियंस में कुछ डेवलपमेंट पार्टनर्स हैं, कुछ गवर्नमेंट के लोग हैं, कुछ रिसर्चर हैं, तो कुछ लोग आपके कार्य के बारे में जानते होंगे कि आप फील्ड पे क्या काम करती हैं। अगर आप सभी को बताना चाहें कि एज ए आशा आपका डेली का काम फील्ड पे क्या होता है और आप किस तरह से अपने प्लान डेली बनाती हैं, आप माइक यूज़ कर सकते। ये माइक काम नहीं कर रहा।
धन्यवाद सबको। मेरा काम 10 से 15 घर हर रोज़ विजिट करना होता है। उस दौरान मुझे लोगों और समुदाय के बीच में उनसे मिलना, उनकी भावनाओं को जानना, उनके जो कोई हेल्थ से समस्या हो तो उसका समाधान करना और उनको स्वास्थ्य सेवाएं प्रदान करना। अगर वो हॉस्पिटल PSC तक आ सकते हैं तो मैं वहाँ ले जाऊँ, नहीं तो मेरी टीम और मेरे PSC के सदस्य ANM LHV वो वहाँ घर आके भी उनको सुविधा उपलब्ध कराते हैं। और 10 घर विजिटों में ANC जांच, टीकाकरण, परिवार नियोजन साधन, वो सब मैं महिलाओं और के साथ शेयर करती हूँ और वो मेरे को कहती है कि हमें ये चीज़ें चाहिए तो मैं उनको उपलब्ध कराती हूँ। टीकाकरण रहता है तब अगले दिन मैं सबको कह देती हूँ गांव में घूम के कि कल टीकाकरण है, आपके बच्चों को वहाँ लेके आना है। तो फिर वो टीकाकरण के दिन लेके आते और फिर हम उनका टीकाकरण करते हैं। और दूर दराज जैसे ईंट भट्टे हैं, लकड़ी काटने वाले हैं, वो जंगल में घर बना के रहते तो वो छूट जाते हैं, तो फिर हम और दीदी दोनों जाके वहाँ उनका टीकाकरण करते हैं। कल पल्स पोलियो था तो दूर दराज वाले बच्चे और वो समझते नहीं पल्स पोलियो क्या है, 2 बूंद क्या है, पर हमें हमारी जिम्मेदारी है कि हमें उनको पल्स पोलियो के 2 बूंद पिलाने, बच्चा कोई भी छूट नहीं पाए। तो हम हमारे काम के प्रति हम बहुत समर्पित हैं और हम तहे दिल से काम करते हैं। हमने कभी काम से कोई जी नहीं चुराया, और जब भी हमें देर रात को भी उठ के कहते हैं कि डिलीवरी आ गई है, आपको उनके साथ जाना है, तो हम जाते हैं, डिलीवरियाँ भी करवाते हैं। डिस्ट्रिक्ट पे भी जाना पड़ता है, उदयपुर भी जाना पड़ता है, सलूम्बर भी जाना पड़ता है, रात भर 2 रात भी रहना पड़ता है उनके साथ, उनको हमारी सेवाएं देनी पड़ती है और हम देते हैं। कभी किसी काम से आज तक मना नहीं किया है। और पहले हम बहुत सारे रजिस्टर लेके तोप के, मतलब हमारा जो भी काम होता था मीटिंगों में, टीकाकरण में, हम लेके जाते थे। अब ये फ़ोन आने के बाद हमारे बहुत सारे काम बहुत आसान हो गए हैं। और खुशी बेबी एप्लीकेशन में जब हम बच्चे को टीका लगाते तुरंत उसमें उसको ऐड कर देते, फर्स्ट पेंटा लगाया, सेकंड लगाया, थर्ड लगाया, जो भी हम टीका लगाते वहाँ उसमें उसको ऐड कर देते हैं। एनसी है तो उसका भी खाता संख्या, आधार कार्ड संख्या सब हम उसमें पंजीकृत कर देते हैं। इससे हमें इस मोबाइल से हमें बहुत सारी सुविधाएं मिली है। परिवार नियोजन के पहले हम रजिस्टर लेके घूमते थे, अब हम जैसे ही उनको साधन दे देते तो फिर हमें इसमें एप्लीकेशन में तारीख डाल देते, इस दिन हमने उनको साधन घर पे दे दिए हैं। ये फ़ोन आने से हमारे रजिस्टर लेके घूमना वो सब हमारे थोड़ा बहुत ज़्यादा बंद हो गया है। मोबाइल में ही हम सारा काम कर लेते हैं अब।
धन्यवाद भारती जी। मुझे लगता है अब अंडरस्टैंडिंग सभी को हो गई होगी कि आशा वर्कर का कितना हार्ड वर्किंग काम है फील्ड पे। तो ज्योति जी, आप भी भारती जी के साथ काम करती हैं फील्ड पे, तो आपको क्या लगता है, आपको किस तरह की परेशानियाँ होती हैं फील्ड पे काम करने में, और आपका किस तरह का एरिया है, अगर आप कुछ बताना चाहें।
एक्चुअल में हमारा एरिया दुर्गम ग्रस्त है और आशा वर्कर और हम साथ मिल के काम करते हैं। खुशी बेबी प्रोजेक्ट आने के बाद 2016 से मैं 2017 मार्च से मैं काम कर रही हूँ खुशी बेबी प्रोजेक्ट में। लगातार इसी के साथ हम काम कर रहे हैं, तो अनुभव यही रहा हमारा कि मोबाइल, पहले टैबलेट में काम करते थे, अब और हर गुरुवार को जब वैक्सीनेशन के लिए जाते थे तो एक दिन पहले ध्यान रख के टैबलेट चार्ज करना पड़ता था। उसके बाद अभी हमको 2 साल से ये मोबाइल दे दिया है, तो ये तो हैबिट में ही है हमारे। मोबाइल तो वैसे डेली चार्ज करना ही पड़ता है, तो ये टैबलेट को अलग से लेके जाना पड़ता था, अब वो टैबलेट का भी रह गया। सीधा मोबाइल हमारे हाथ में है, छोटा सा है, न वजन है, कुछ भी नहीं है। और जैसे हम RCH रजिस्टर है, वेट मशीन है, BP इंस्ट्रूमेंट है, जब हम MCH सत्र करने जाते हैं तो हमारे पास वज़न ज़्यादा रहता है और RCH रजिस्टर भी भारी है। अभी भी हमको RCH रजिस्टर में भी काम करना पड़ता है, और UV एप्लीकेशन है, PCTS एप्लीकेशन है, खुशी बेबी एप्लीकेशन है, इन सभी एप्लीकेशन में हमको काम करना पड़ रहा है। और मैं यही चाहूँगी कि ये सारी एप्लीकेशंस अगर एक हो जाए तो और भी आसान रहेगा काम।
हाँ, ये बिल्कुल सही बात कही है आपने कि डिजिटल होने से आपका काम हम चाहते थे कम हो जाए, लेकिन वो और 4 गुना बढ़ गया कि उनको मल्टीपल एप्लीकेशन भी यूज़ करनी पड़ रही हैं और रजिस्टर तो है ही अभी भी। आप थोड़ा अपना एक्सपीरियंस बता सकती हैं कि पेपर पे जब आप काम करती थी तो आपको डिसीज़न लेने में, जैसे आपको कोई हाई रिस्क में है, और अब जो आप एप्लीकेशन को फ़ोन पे यूज़ कर रही हैं, तो उसमें कुछ चेंज आया है क्या डिसीज़न मेकिंग में?
हाँ, पेपर वर्क के समय हमको, जैसे कोई गर्भवती महिला आई, उसका पंजीकरण करते थे, उसकी LMP पूछते थे, तो हमको निकालना पड़ता था कि इसकी EDD क्या होगी। और एप्लीकेशन में काम करते हैं तो हम LMP रजिस्ट्रेशन करके और LMP डालते हैं, LMP डालते ही हमको EDD तुरंत मिल जाती है। और BP शुगर वगैरह हम चेक करके मोबाइल में एप्लीकेशन में फिल करते हैं, उसके सारांश में ये निकल के आ जाता है कि इसको HB कम है, इसको उच्च संस्थान पे रेफ़र करना है, और इसको आयरन की गोली है वो डबल देनी है, इसको आराम ज़्यादा करवाना है, और इसको खाने में क्या क्या देना है सब कुछ इस एप्लीकेशन के सारांश में आ जाता है। तो हम महिला को बता देते हैं और सारांश आते ही हमको रेफ़र करना ही है तो हम बता देते हैं कि आप PSC पे जाके एक बार और डॉक्टर साहब से चेकअप करवा लेना है। पेपर वर्क में हम बोलते थे तो बस महिला हमारे तक सीमित रहती थी, वो जाती भी नहीं थी। अभी खुशी बेबी एप्लीकेशन में डालने से फ़ोन भी गर्भवती महिला के पास फ़ोन आ जाता है कि आपको उस संस्था पे रेफ़र किया गया है तो आपको चेकअप करवाने के लिए जाना है। और MCHN सत्र के एक दिन पहले भी जितनों के मोबाइल नंबर हम ऐड किए होते हैं सबके पास कॉल आ जाता है, कल आपको MCHN सत्र पे बच्चे का या गर्भवती महिला की जांच करवाने के लिए जाना है। तो ये हमारे लिए थोड़ा सॉफ्ट हो गया है कि महिलाओं जिसको अगर आशा भी भूल जाए, ANM भी भूल जाए, ऐसी महिला को भी खुशी बेबी की इस एप्लीकेशन से फ़ोन जाता है कि आपको कल MCHN सत्र पे जाना है।
धन्यवाद। डॉक्टर हेगड़े, मैं आपसे मुखातिब होना चाहूँगा। तो एज ए इम्प्लीमेंटेशन लीड जो मैं सबसे ज़्यादा चैलेंज फेस कर रहा हूँ फील्ड पे वो ये है कि हमारी जैसा अभी बताया कि आशा बहुत बड़ी वर्क फोर्स है। अगर हम राजस्थान की बात करें तो 60 से 70 हज़ार आशा वर्कर हैं, तो उनको इन पर्सन ट्रेनिंग देना तो बहुत ही मुश्किल होता है। तो क्या कोई ऐसा सॉल्यूशन जैसा आप मोबाइल एकेडमी पे काम कर रही हैं तो वो हेल्प कर सकता है स्केल पे कि हम उनको ट्रेनिंग ईजिली दे जा सकें? अगर आप मोबाइल एकेडमी के बारे में।
थैंक यू। मैं हिंदी में ना बात करके इंग्लिश में बात कर सकती हूँ। मेरी मुंबई की हिंदी है। It's pretty bad. Sorry.
Yeah.
Yeah, I speak a very South Indian from Mumbai, so yeah. So we run a program called Mobile Academy with collaboration of Government of India. So it was devised basically for this reason. It's very difficult to do face-to-face refresher training. Can you hear me? Yeah. Yeah. So face-to-face refresher training often is very difficult, right? So Mobile Academy is a program which was initially a voice-based program. So because initially, obviously, when it started off, the ASHAs did not have access to smartphones. So it's 4 hours of content, 11 chapters, 4 sections to each chapter, a quiz at the end of each section. So the ASHA workers can call in and log in and log off whenever they want to. And there's a bookmarking system. They log back in where they left off. And we've reached around 325,000 ASHAs in 18 states of India. But the thing that is happening with Mobile Academy now is that we are going on to a 2.0 version. And what is the 2.0 version? Because now most ASHAs have access to smartphones. We're going to be going on to a system where, based upon their access to technology, we'll have stratified programming, right? So we will have more multimedia content, more two-way communication, more long-term hand-holding. During COVID times, what we saw is that because we have this whole database of ASHA workers, a platform on which they're all there, we could set content for the Government of India directly to them on during COVID, on various aspects. So when we have this whole live database of ASHA workers, not only can we use that for upskilling, but also long-term hand-holding. So when they go into the field and they have any query, they'll have a WhatsApp help desk, right, to answer any queries. And again, and this training will be ongoing with refreshers, etc. So if any new, vaccine comes in or new epidemic comes in, etc., that can be a source of constant training for the ASHA workers. So this is where we are going, right? Upskilling and long-term hand-holding. And depending on the technology access that they have, right? So we are going to be having IVR, it's going to be ongoing, but we are also adding WhatsApp because almost everybody is on WhatsApp. And a thin app is something that we are grappling with, but one thing that we are looking forward to doing is to maybe incorporate it with, collaborate with an organization like yours and incorporate the content within your, apps, right? Same thing we have for ANMs, and we can talk about the ANM program later on, maybe.
Yeah, I will.
We are hoping to reach around 850,000 ASHAs all through the country in the next 3 years.
मैं आपके बात से एग्री करूंगा क्योंकि मुझे चांस भी मिला था आपके ऑफिस को विज़िट करने का, और जब हमने लॉन्च किया था अपनी एप्लीकेशन तो इत्तेफाक से वो तब लॉन्च किया जब कोविड आया ही था। तो हमें बड़ी जल्दी ये समझ में आ गया था कि इस तरह के प्लेटफॉर्म जैसे व्हाट्सएप का आपने जिक्र किया या पुश नोटिफिकेशन को हमने यूज़ किया, मैसेजेस को हमने यूज़ किया, ऑटोमेटेड वॉइस कॉल को हमने यूज़ किया। तो इससे एक आइडिया मिल गया था कोविड में कि हम इस तरह से भी आशा एएनएम की ट्रेनिंग कर सकते हैं, जो कि हमने की भी है। तो ये एक अच्छा माध्यम है कि आशा एएनएम को इतनी बड़ी वर्क पर्सन ना होकर वर्चुअली ट्रेंड कर पाएंगे। लेकिन कोई ऐसा सिस्टम जैसा आपने बताया मोबाइल एकेडमी है कि हर वक्त उसके साथ है और वो जब चाहे कुछ क्वेश्चन अगर पूछना चाहे तो उसका आंसर।
सो एएनएम के लिए भी हमारा एक प्रोग्राम है, इंटीग्रेटेड हाई रिस्क प्रेगनेंसी मैनेजमेंट प्रोग्राम, जो 3 स्टेट्स में है अभी एक्चुअली, तेलंगाना, आंध्र प्रदेश एंड उत्तर प्रदेश में भी आ रहा है, वेयर बाय हमने प्रोटोकॉल्स क्रिएट किए हैं। तो क्या होता है इन विद एएनएम्स, क्या इफ यू लुक एट हाई रिस्क प्रेगनेंसी, सो वी डील विद मैटरनल चाइल्ड हेल्थ, सो दिस वेरी फोकस ऑन मैटरनल चाइल्ड हेल्थ। The thing about maternal health is that high risk is where the mortality happens, and problem ये है कि protocols जो है, guidelines जो Indian government की guidelines है, they are overall guidelines which can be understood only by trained obstetricians, and it's very important that we break it down to what each cadre can do. And so what we've actually done, and it's already a 5-year MOU with Telangana, and the same thing has come to Andhra and UP, is that we've actually modified the protocols to suit every level. So we created algorithmic color-coded protocols, literally like last detailed protocols for every level of the cadre, the nurse, the medical officer and specialist, because they then will know what is their part of the role. You pick up hypertension, should you just refer? No, right? There's something that the ANM can do, the counseling that she has to give, when she has to refer, but what particular point, what to do when the woman is referred back to her. So we created these protocols, and in Telangana now they become policy, same in Andhra. And I'm doing face-to-face training of the ANMs, so 9,500 nurses, medical officers, 1,500 medical officers, and 350 specialists getting trained in it. But in addition to face-to-face training through master trainers of the state, we also have created multimedia content. So there's a learning management system on which are the learning multimedia content. So basically live action videos, simulations, interactive quizzes, notifications. So you train face-to-face. When you go back home, you have this whole LMS where you have the content being sent to you at regular intervals. We have 15 days to 1 month on a particular topic that we're dedicating. And then a WhatsApp help desk for hand-holding. And then tracking, right? And like how you track high risk, I mean, if these protocols can be layered on top of the already existing protocols for diagnosis, then it'll be help to really understand what is really happened to each high risk, where the delay has happened, in care. And then dashboards at every level, so you can go and do iterative training.
और ये आशा एएनएम की हेल्प ही करेगी डिसीजन मेकिंग में विलेज लेवल.
And you're going to see an LLM, you're going to see an AI application that we have in this program in the afternoon. I think Amrita from our team is going to show that. Yeah.
थैंक यू. डॉक्टर सलूजा, ये क्वेश्चन आपके लिए है. हमने बात करी कि डिजिटल टेक्नोलॉजीज़ की, रिमोट ट्रेनिंग की और भी चीज़ों की हम बात करते हैं आशा और एएनएम को लेके, लेकिन हम उनका टाइमली पेमेंट, उनकी कैपेसिटी बिल्डिंग और उनका सोशल रिकग्नाइजेशन के बारे में ज़्यादा बात नहीं होती अभी तक. तो अगर आप बताना चाहें कि हम किस तरह से उनका सोशल रिकग्नाइजेशन और एडवोकेसी बड़े लेवल पे कर सकते हैं.
थैंक यू फॉर द अपॉर्चुनिटी. आई वुड एक्चुअली स्टार्ट फ्रॉम जो सबसे पहला पॉइंट आपने उठाया था कि कम्युनिटी हेल्थ वर्कर्स, ये पहली बार नहीं है कि पेंडेमिक में सडनली एवरीबडी हैज़ रियलाइज कि कम्युनिटी हेल्थ वर्कर्स इतना कंट्रीब्यूट कर रहे हैं. वो पहले भी काम करते थे और उतना ही काम करते थे, कोविड में भी किया है, बढ़ चढ़ के किया है, उसके बाद भी कर रहे हैं. बट कोविड ब्रॉट दैट अपॉर्चुनिटी टू रिकग्नाइज एंड ब्रिंग अटेंशन टू देयर कंट्रीब्यूशन, कि वो इतना मेहनत कर रहे थे बट इनविजिबल था, अनरिकग्नाइज था. एंड एज अ रिजल्ट नाउ पीपल नो. अब even people in the urban areas who earlier did not know कि आशा वर्कर कौन होता है, ANM कौन होता है, आंगनवाड़ी वर्कर कौन होता है, उनको भी पता है. Then another important point is that over शुरुआत में जब community health workers were the only ones who were going deep into the community, जब restrictions थे, जब fear of contagion था, people were not coming out and lockdowns were going on, they were the ones who were going deep into the communities, telling them what to do, doing all those surveillance activities. As a result, they were also facing a lot of discrimination, violence, and harassment from the community members, which is also very rarely talked about. जिसकी वजह से and the responsibilities, suddenly COVID की वजह से जो responsibilities इनके ऊपर आई, एडहॉक था, सबके लिए नया था, इनके लिए भी नए रेगुलेशंस आ रहे थे, नए गाइडलाइंस आ रही थी जो इनको इंस्टेंटली अडॉप्ट करनी थी, राइट? So as a result, they are also human beings. They have also household and childcare responsibilities. How often were we talking about the unpaid care work that they were taking care, they were taking responsibilities for, along with जो इनकी healthcare responsibilities थी towards the community, which they were fulfilling with all the commitment. So as a result, their mental health was impacted. They were facing ostracization, discrimination from the community members. बहुत community members ने हमने सुना है शुरू में उन्होंने बोला था कि ये community health workers COVID carriers हैं, right? With time, everybody realized that no, they are risking their own lives. They are risking the lives of their family. अपनी family की members की जान को risk पे रख के और वो हमारी मदद करने आ रहे हैं, तो no, they are doing something for our betterment, our good, right? And that is how the whole conversation shifted from COVID carriers to COVID warriors, right? And then suddenly every organization and even international organizations started recognizing, and we see now, for example, at the World Health Assembly last year, they were recognized as the global heroes. But my question is, how is this, yes, their recognition was long due. बहुत time से pending था, किसी को नहीं पता था, अब लोगों को पता चल गया है. But क्या इस recognition से, can you help them provide the timely payments? Can you help them with seeking access to healthcare when they need it? No. Can this recognition address all the systemic challenges that they are facing with constraints to, for example, PPP equipments नहीं थे, resources नहीं थे, पूरा दिन काम किया, बिना पानी, बिना खाने, बिना toilet breaks के. So my question is that how long can this recognition go in addressing their concerns on the ground? And hence, their voices need to be included into the decision-making spaces. That हम बोलते हैं policies बना रहे हैं, whether it is at the state level or at the national level, please include them. Include them because they are the ones जो community के बीच में हैं. रोज़मर्रा के level पे वो engage कर रहे हैं community members से. Every community member they're dealing with day in and day out. So they know the ground realities. Are we speaking to them enough? ताकि हमें ground realities पता चले, उनके questions, concerns पता चले, so that we can include it into the policies that we are making at the state level, national level, and international level. So that is very important. And I'll leave with one important message that safe working conditions is often disregarded. Prevention from sexual harassment also emerged as one of the very, very important concerns. कि community health workers को harassment, exploitation, violence, different forms within the health sector, outside health sector, community में ये सब उनको face करना पड़ा. तो we need to pay attention to that. That is something we cannot ignore. Thank you.
Thank you. Now we have 4 to 5 minutes for question and answer. अगर आपका किसी का सवाल है ऑडियंस में से, क्योंकि हमारे पास लिमिटेड टाइम है, तो इसलिए क्वेश्चन आंसर का सेशन लिमिटेड रखेंगे. अगर आपका किसी का सवाल है तो आप पूछ सकते हैं.
Can I say one thing to just add to what you said? Yeah. No, very important points you raised. And so, it comes down to the content that we use to train the ASHAs and the ANMs. So the content that was used earlier for training were all very gender sensitive. These are the constraints. How do you work around those constraints? So it's so important to go on to a gender transformative approach, where it's like for the beneficiaries, women directly, and for the health workers, both the ASHAs and ANMs, how do you stand up for your rights? What are your rights? How do you talk to your peers? How do you stand up to your seniors? They kind of face a lot of discrimination within the health system from the higher ups, right? The health worker, the doctors and the health officials, etc. How do you then stand up to that and put your point of view across, right? So the content that ARMMAN is now creating actually going on to a very gender transformative approach. And when we did that, I myself realized how different is the approach, right? The voice, right? And the way we, because I didn't realize till we got into this whole approach, how much lacking our content was, right? Because there's a lot of work. When you talk about technology, you talk only about technology, not how is the content being created, and that really needs equal importance and emphasis, because that really helps the A&M and ASHA do their work better, not just the technology, not the approach.
I'll just take a minute. So last year जॉर्ज इंस्टीट्यूट के साथ हम एक प्रोग्राम कर रहे थे जिसके अंदर हमने 6 डिस्ट्रिक्ट्स में कम्युनिटी हेल्थ वर्कर्स से डिस्कस करके उनकी नीड्स असेस करके उनके लिए उनके साइको सोशल वेलबींग के लिए एक डिजिटल इंटरवेंशन तैयार करना था. सो वाइल वी वर डूइंग दोज नीड्स असेसमेंट यूजिंग पार्टिसिपेटरी मेथड्स, जब हम उनसे पूछ रहे थे, सो कम्युनिटी हेल्थ, वन रेकरिंग थिंग दैट केम अक्रॉस ऑल द वर्कशॉप्स कि इट इज़ देयर रिस्पॉन्सिबिलिटी टू एड्रेस द नीड्स की कम्युनिटी मेम्बर्स को वो रोज़ जाके पूछ रहे हैं, चाहे वो इंस्टीट्यूशनल बर्थ हो, प्री नेटल केयर हो, एंटीनेटल इम्यूनाइजेशन कुछ भी हो. हाँ, फॉर एग्जाम्पल विद रिस्पेक्ट टू द मेंटल हेल्थ, कि वो जाके पूछ रहे हैं कम्युनिटी मेम्बर्स से कि आपको डिप्रेशन तो नहीं है, कोई साइंस ऑफ एंग्जाइटी तो नहीं है, बट व्हेन इट केम टू अपने मेंटल हेल्थ के बारे में बोलने के लिए दे फेल्ट हेजिटेटेड. So when we talk about कि healthcare workers are there for everybody, but the question is who's there for them, right? And another important point that when we, for example, at all these international levels, we hear about pandemic treaties, accords, declaration, commitment. My question is, how many of you have seen these people included in those decision-making spaces? How many of them have actually referred to them and come and ask कि आप बताइए, हम इंटरनेशनल लेवल पे कमिटमेंट डेवलप कर रहे हैं, डिक्लेरेशन डेवलप कर रहे हैं, आपके क्या नीड्स हैं, आपके क्या कंसर्न्स हैं जो हम उसके अंदर इंक्लूड कर सकते हैं? वेरी रेयरली. And that is why I emphasize on including them in the decision-making spaces. Start at the state level, start at the block level, whatever we can do in our capacity, in our spheres of influence, so that at least we start shifting. I think leadership is also seen synonymous कि जिसके पास 25 साल का experience होगा वही leader होगा. These women have exemplified in a wonderful way कि वो community level पे leaders हैं. उन्होंने जितने भी limited resources थे उसके साथ उन्होंने काम किया है COVID में. So we have to kind of disintegrate leaders with only a certain definition of leaders. I think community leaders have given a wonderful example to us. Thank you.
Thank you. वैसे तो मैं मॉडरेटर हूँ और मुझे टाइम का ख्याल रखना चाहिए, लेकिन 1 मिनट मैं भी लेना चाहूँगा, क्योंकि फील्ड पे मैं एज ए इम्प्लीमेंटेशन लीड बड़ी जिम्मेदारी के साथ ये बोल सकता हूँ जो मैं फील्ड पे देख रहा हूँ कि 5 साल पहले हमारी प्रॉब्लम ये थी कि आशा वर्कर पेपर पे काम कर रही है, एएनएम पेपर पे काम कर रही है और उन्हें डुप्लीकेसी ऑफ वर्क करना पड़ रहा है. और अब सिचुएशन ये है कि हमने वो प्रॉब्लम तो रिजॉल्व कर दी उनकी कि हमारे पास डिजिटल सॉल्यूशन है, लेकिन अब हम सब ने एक डिजिटल सॉल्यूशन बना दिया, तो उनके लिए और बड़ी प्रॉब्लम हो गई. पहले वो सिर्फ पेपर पे कर रही थी, अभी वो पेपर पे भी कर रही हैं और 4 डिजिटल सॉल्यूशन पे भी कर रही हैं. तो मेरा मानना यह है कि हमें अब ये प्रॉब्लम है कि उन 4 को किस तरह से हमें एक करना चाहिए, एक ही प्लेटफॉर्म हो, जैसे ज्योति जी ने मेंशन भी किया है स्टार्टिंग में. थैंक यू वेरी मच. आई थिंक दिस वाज अ वेरी नाइस डिस्कशन. नाउ ओवर टू यू हेमंत जी.
Thank you, Hamid and esteemed panelists, for an insightful discussion. I would now request Hamid to facilitate our panelists. We have a small memento from Khushi Baby that we would like to present. सबसे पहले श्रीमती भारती मेनेरिया जी को.
हाँ जी बोलिए.
मैं ये कहना चाहती हूँ, मेरी ज्वाइनिंग 2012 में हुई थी, तब मेरा मानदेय 1100 रुपये था. ठीक है, आज 4098 रुपये है. तो मेरे जो बड़े अधिकारी है, मेरा पिता तुल्य है, बड़े भाई हो आप सब, तो मेरी ये रिक्वेस्ट है आप सबको कि हमें अस्थायीकरण दे दिया जाए. अगर आप कभी आगे किसी सर से मिलो, बड़े सर से और आगे आपसे, तो उनसे हमारा निवेदन करना कि हमें पीएससी में तो हमें कर दिया है, पहले आईसीडी से अब हम पीएससी में आ गए हैं, चिकित्सा विभाग में आ गए, तो हमें अस्थायीकरण दे दिया जाए और एक मुश्त मानदेय कर दिया जाए, ताकि हमें ऐसा रहे कि हमारा इतना मानदेय आने वाला है. और हमें इंसेंटिव मिलती है, पर वो क्या है, जैसे काम किया इंसेंटिव, जैसे 15 रुपये स्लाइड ली 15 रुपये मिलते हैं, ऐसे मतलब फॉर्मेट भर के दो तो फिर वो उस पर अधिकारी है लैब वाले साइन करेंगे, फिर वो फॉर्मेट क्लेम में लगाएंगे, तब पैसा आएगा यूँ। तो मतलब हर चीज़ के टूटक टूटक हमें पैसे मिलते हैं टुकड़ों में। तो मेरा आपसे हाथ जोड़ से निवेदन है कि आप हमें हमारा एक परमानेंट मानदेय कर देना, बस इतना ही निवेदन है। और मैं खुशी बेबी वालों को बहुत बहुत धन्यवाद करूँगी कि मुझे दूसरी बार और यहाँ आने का मौका दिया। मैं तहे दिल से आपको बहुत धन्यवाद करती हूँ।
श्रीमती ज्योति दामा जी। श्रीमती भारती मेनारिया जी। उनकी सहकर्मी श्रीमती पार्वती कुमारी मीणा, ANM सलुम्बर ब्लॉक। श्रीमती निर्मा मेघवाल, आशा सलुम्बर ब्लॉक। डॉक्टर अपर्णा हेगड़े। डॉक्टर दीपिका सलूजा। Thank you so much, panelists.
एक मिनट और लेना चाहूँगा, अभी 1 मिनट है हमारे पास। हमारी टीम जो फील्ड पे काम कर रही है आशा ANM के साथ, वो भी यहाँ है। मैं उनको भी अप्रिशिएट करना चाहूँगा, रिकग्नाइज़ करना चाहूँगा कि वो 24/7, आप जहाँ पे भी हैं वहाँ खड़े हो जाइए। 24/7 पिछले 5 से 7 साल से वो लोग फील्ड पे सिर्फ एक कॉल दूर हैं आशा ANM से। आशा ANM जहाँ भी होती है वो उन्हें कॉल करती है और वो विदिन 15 मिनट और 20 मिनट वहाँ पहुँच जाते हैं उसकी प्रॉब्लम सुनने के लिए और उसका काम करने के लिए। और दूसरी टीम है हमारी कम्युनिकेशन टीम। आप भी प्लीज़ जहाँ भी आप हैं वो खड़े हो जाइए। पिछले 1 साल में हमारी कम्युनिकेशन टीम ने, जिसमें 4 से 5 मेंबर हैं, लगभग 2 लाख कॉल रिसीव किए हैं फील्ड से। तो मतलब हम राजस्थान की हर आशा से एटलीस्ट 3 से 4 बार तो कम्युनिकेट कर चुके हैं हमारी कम्युनिकेशन टीम। और ये भी 24/7 कभी भी कॉल आ सकती है और कभी भी इनको जवाब देना होता है। तो थैंक यू वेरी मच फॉर योर हार्ड वर्क। थैंक यू।
Ladies and gentlemen, now it's an honor for me to invite Shri Rohit Kumar Singh, Secretary to the Government of India, Ministry of Consumer Affairs, Food and Public Distribution, who shall be joining us via video conferencing. Sir is the former Additional Chief Secretary of the Department of Medical Health and Family Welfare in Rajasthan. Ladies and gentlemen, please welcome Shri Rohit Kumar Singh.
Hi, sir, can you hear me? Am I audible?
Yes, I can hear you. Yes.
Okay, we just need to increase your volume. 1 second. Where should I look?
Should I speak louder or it's your audio system?
Yeah, now I think we're good. Can you hear me?
Yes, I can hear you.
Perfect. I'm going to be looking this way. Good. Okay. So thank you, Rohit, sir, for being here. I know you have a very busy schedule and Parliament session. We would have wished for you to be here in person, but now over virtual is almost as good. We just finished our first panel, in fact, in which we had one A&M, one ASHA come and explain their pain points on the ground. We had some other partners who were speaking about training of ASHAs and advocating for ASHAs and A&Ms at scale. I mean, so you are the former Additional Chief Secretary of Health, and you are responsible for the health of 80 million, 8 crore people across Rajasthan, over 100,000 staff, in the middle of a pandemic. And I want to first start by asking you, what were your levers of change? How did you approach this from the top seat of the government?
So we just had to, first do an analysis of how we improve the efficacy of our systems. And so we break down it into 4 parts, that what are the critical components that need to be addressed. First and foremost, of course, is the infrastructure, and you can only do that much because you have a legacy of existing infrastructure. You can surely augment it, but it takes time. The second is, of course, human resources. And I think that's the most critical component in the delivery of healthcare in public health systems. And the set of doctors, nurses, ASHA workers, A&Ms, the technicians, and everyone else who works at our facilities. Not just their capacities, but their level of motivation, the kind of incentives they are required to be provided to expect optimal level of performance. I mean, that's the key challenge, especially in public systems. And I'm very glad that we worked with organizations like Khushi Baby, where we're able to generate this sense of optimism and the aspiration amongst our healthcare and ASHA workers, so that they were committed. And of course, you have to make a case that by adopting technology, their work efficiency will be better, their clients' health will also be taken care of in a better way. So it's how you pitch it to your workers, and I think we succeeded a bit in that. Third, of course, is finances, which I don't think is ever a problem in the government. Many states, they are not able to spend their budgets of National Health Mission and other programs that they have. So the problem is not with the availability of resources. I think the problem is in the procurement procedures. So governments need to very aggressively work on the procedures of procurement so that it is facilitated. And last but the most important is, of course, the use of technology, which can make deliveries faster. You can have databases, you can have other systems to access. So I think unless you have a synergy amongst all these 4 critical factors, we will not be able to deliver healthcare. Rajasthan has special challenges in terms of the cost of delivery of services in remote and rural areas. So that's a special challenge which may not be existing in many other states. So it needs a different adaptation, a different approach to the conventional strategies. So that is my take on the systems in Rajasthan. Of course, when I was there, we were struck by the first wave of COVID-19, and it was a huge challenge. But I think with your team, Ruchit, and everyone else who were part of the system, we did manage to contain, whether it was the Bhilwara model, we used a tough term called ruthless containment, but I think it worked in the end. Yeah. So that's my initial remark.
And in fact, that model was praised across the world in terms of the early containment of COVID. Sir, you've had experience in your 30+ years as an IAS officer across multiple domains, be it IT, highways, rural development, health, home, now consumer affairs. Was there anything about your experience as health secretary that stands out, or any common patterns that you've seen across these years in order to make big time solutions and big time change?
I think we should constantly look for good partnerships with organizations and institutions outside the government. Sometimes we, especially in this service, we are under the misconception that we know everything, and sometimes we are not very charitable to the other side of the table, and so I think that mindset needs to change. We are not regulators or masters. We should act as facilitators. And if you see talent or a good idea on the other side of the table, I think the best thing for an administrator to do is to think of positive modalities of exchange. And
So just bear with us for a second, a little bit of tech glitch. I think this is a lesson learned for all of us. We're in the digital health space, right? IT doesn't work perfectly, right? It certainly doesn't work perfectly for our application. We have, anywhere from 100 to 500 calls that our help desk is getting on a daily basis, hundreds of versions of our application. It's an ongoing process, and I think we've been humbled many times when we've tried to we see IT as a lever for change. We see it as this big thing that we need to rely on to make change at the ground level. But at the same time, as you saw in the video earlier, as Shahnawaz mentioned, it really is the technology plus the team that have to work together. So we're experiencing a version of that right now. I'm not sure, will we be able to get Rohit sir back? We are, okay, we're working on it. I'm wondering if anyone has any reflections on what they've heard about so far, either from the first panel or from what Rohit sir was talking about a little bit earlier, that they would like to share while we're waiting. Okay, I guess we're connecting. Any comments, thoughts? Yeah.
So what you talked about, we're also trying a similar thing in UP and working with the ASHA workers and ANMs as well. And it's been the challenge that you're talking about, getting calls because the basic application is not working or there are hardware issues. So we're facing similar challenges. While that is there, one important point that came in the panel was interesting about using, online capacity building. So I wanted to ask if it's been tried and how is it working? Because in UP, we've had sort of a mixed model where we've built capacities offline through our CHOs, but also online. But because ASHAs have never used smartphones, so it's been a challenge as well. Right, ma'am? Aparna ma'am knows.
So our experience with ANM is very encouraging in Telangana, and you can come to the field and see it. I mean, I was in a training program just last week. ASHAs, I completely agree, but we're doing pilot studies now in small in Haryana and Jharkhand, and it's encouraging. I mean, and that's where I'm going to be, because we need larger studies to really see how training only through online can work for them. So I think in a year's time we'll have the evidence to really prove.
Yeah,
but
that will be great.
Yeah, we will have evidence because we are actually working on pilots. So all of that, we showed you a grid, right? So for upskilling and handholding, we have different modalities of how we'll upskill. So we're looking at content, obviously pilots, and technology pilots, what will work and what will not work, and mixed methods, both quantitative and qualitative. That's great. So year's time, of course, in the next meeting, hopefully we'll be able to
And
share.
I'd like to talk to you maybe separately about the gender transformative content as well. That's
That is an extreme. What we realize is that we focus a lot on the technology. I think it's what will hold them that is actually equally important as the content and how are you training them.
Sure. Thank you.
So, sir, we were just talking about how we have to be flexible with IT and how important it is to adapt. And this was a good example of that. But you were talking about, I'll just follow up with another question. You were talking about your experience across the different domains, the need for partnership, approaching new people, young people like us even, bringing them to the table. And certainly we have benefited from your guidance there. I'm curious, during your tenure, if there's anything that surprised you or stood out to you from the public health standpoint that you wanted to share with our audience. So we do have an audience here of some 30 different partners representing government. We have members from Rajasthan government, from NHA, government of Karnataka, government of Maharashtra representatives. We have various different development partners that are working on all of the cool technology for AI at the last mile. We have researchers, we have implementers. So, and we have ASHA workers and A&M workers who are also here with us. So any words of wisdom or anything that you would like to share for us to take forward in today's summit?
I think what surprised me most was the inappropriate matching of resources with requirements. And I know everybody wants to be posted at the district headquarters or on big cities, but you also need healthcare in rural and far-flung areas. So the mismatch between the availability of human resources, to be deployed in certain areas where they require the most. I mean, we talking of all the governments here, I'm yet to see a structure which is successful in doing that, and we need to do that. For example, we had situations in Rajasthan where you have equipment for dentistry, but they are not dentists, they're posted elsewhere, and of course there are political compulsions. So any system which is able to match this in an efficient manner, that will succeed. And I was surprised that sometimes, despite the best of intentions, we were not able to do that. It's a big challenge in that kind of area, but that is why I was focusing when we got disconnected on partnerships. If you have partnerships which are, sometimes they're local in nature, and you can leverage that to the advantage of the system, that will be successful. And you should never, underestimate any stakeholder in the system. You should constantly engage with all of them. I see it in all my assignments, all my postings. And this thing that you are the controller or the regulator, that notion needs to be dispelled. We are just facilitators. I face it every day in my current job, where I have to match the ease of doing business, that is the industrial facilitation, with the rights of the consumers. So you have to strike a balance, and you can't just weigh one against the other in a specific way. So I mean, there's a need to strike a balance and constantly engage with all the stakeholders. I mean, that is my lesson. And lateral thinking does work. I remember when I was moved from Government of India, where I did 6 years of national highways, to Health Secretary of Rajasthan. The Cabinet Secretary once told me, Rohit, this is a different sector, but use your thinking, lateral thinking, and what some of the concepts in the highway sector, maybe you can use it. And I realized to my advantage that how you structure PPP, public-private partnership, highway sector, we could use that knowledge, those principles in health sector as well. So no knowledge or no skill goes waste. You should constantly think as to how to use this in this work domain that you are addressing in the current context.
Thank you so much for taking your time and for sharing your wisdom. Personally, you've been a guide for me and definitely a role model for the entire Khushi Baby team. So again, we'd like to thank you again for taking your time and for being here and for inspiring all of us. Thank you so much.
Thank you so much. I always love to be part of any event that Khushi Baby organizes. In fact, I keep telling everyone about the good work that you guys are doing. Only yesterday, I had an interaction with the in charge of Google in India, Sanjay Gupta, and I was telling him about your project where you're trying to, get the hemoglobin levels by taking a picture of conjunctiva, and I was actually talking to him in the context of the lightweight AI as to how artificial intelligence is not just about large language models where billions of dollars are required to be spent, but we can have lightweight AI, and applications like what you're doing could be a great example as to how to proliferate use of AI in India. And by the way, there's a big AI event happening in India tomorrow, starting this evening till day after, where Prime Minister is inaugurating, and all the countries are participating, and we are going to pitch for lightweight AI and give the example of what you're doing. And thank you very much. I would have loved to be there in person, but sometimes our schedules can be bad. Thank you very much again.
Although we are running slightly late, we can still have a short tea break. I would request all the panel participants to please join us for tea or coffee outside the hall. We will reassemble in the next 10 minutes, please. Thank you. Welcome back, delegates. We will now begin our second panel, Building India's Digital Health Ecosystem. This discussion will highlight the challenges and opportunities in realizing the vision of the Ayushman Bharat Digital Mission from the perspectives of policy, technical development, and on-the-ground implementation. Please join me in warmly welcoming our panel moderator, Ms. Maitri Porecha, Senior Assistant Editor at The Hindu. Ms. Porecha is a seasoned journalist serving as Senior Assistant Editor at The Hindu. Formerly with the Ken and The Hindu business line, she specializes in the confluence of health policy, technology, and business with a keen eye on public infrastructure and education. Her extensive work spans tuberculosis, maternal mortality, and tribal health. Recognized globally, she has taken fellowships from the National Press Foundation, Eureka Alert Science Fellowship, and accolades such as the Next Generation of Science Journalist Prize. A Chevening Fellow and Thakur Foundation Fellow, she won the top position in the ICRC and Press Institute of India's Award for Investigative Reporting on TB in 2020. And now for our panelists, please welcome Dr. Akshay Jain, Joint Director at the National Health Authority. Dr. Jain is a key figure overseeing the Ayushman Bharat Digital Mission, ABDM, and heading the Health Policy and Quality Assurance Division of Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, PMJAY. In his current role, he spearheads government adoption, integration of ABDM, and leads a team in developing health benefit packages, conducting health financing and technology assessment, and providing quality-related training. Mr. Prakash Singh, Leader Healthcare Consulting at EY. In his current capacity, Mr. Singh is advising NHA, Ministry of Health and Family Welfare, Government of India, Government of UP, Bihar, Rajasthan, MP, Haryana, and Himachal. A graduate from IIT Delhi and postgraduate from IIM Bangalore, he has more than 2 decades of work experience across Asia and Europe and a deep understanding of the healthcare ecosystem. Ms. Tanu Gupta, Senior Program Officer, PATH, Digital Health. Ms. Gupta is working on accelerating the adoption of India's digital health mission. She holds a master's in public health from the acclaimed TISS, Mumbai, and has previously worked in the public health space on health system strengthening and nutrition in several states. Prior to PATH, she was at the NHA, where she has extensively worked on scaling ABDM across the nation and initiatives to take digital to the last mile through collaborative efforts. Mr. Arul Srinivaasan, CTO at Khushi Baby. Srini brings over 4 years of dynamic experience to the role. Graduating in computer science engineering, Srini's journey at Khushi Baby spans from Android intern to Android developer, progressing to a back-end developer, culminating in becoming the CTO. Over to you, Maitri.
Am I audible? A very good morning to all of you, and it is a great pleasure to host this panel, and especially it is coming from a stakeholder's perspective. So we see lots of people working on the ground, ASHAs, ANMs, and you've heard from them in the morning. And we are here to take this discussion forward. We are here to ask our esteemed panelists about how Ayushman Bharat Digital Health Mission is progressing. And my first question would be to Dr. Akshay Jain. So we would like to know from you, we would like to understand the journey of ABDM. ABDM's inception, I mean, the thought that the nation's health journey should be digitized was beginning, I remember, sometime in 2016 or 2018 later when the blueprints started emerging. Now, these emerged pre-pandemic. We did not know that COVID was going to hit us for the next 2 years. That slowed down the journey a bit. However, what were the lessons that ABDM took from the pandemic? And after that, obviously, there was a lot of digital uptake from patients. But how do you use it in order for the mission to be valuable? Because ABDM has a lot of moving cogs. There are the patient side, you have to look at the doctor side, you have to also look at the rural and the urban divide when you are addressing ABDM. So lots of officials came and went, So I remember that it started with a one-room project in the health ministry, and it moved on to the LIC building in CP, where they had a sprawling office. It gave a vibe of a startup. However, there was also a change of leadership that occurred, where Dr. Indu Bhushan was, sort of his term was not extended. Dr. R.S. Sharma came in. Now he, has retired. So also I feel like there might be a slight vacuum in the leadership level. So, how do you address all these moving cogs, when you sit in the ABDM office? How do you look at the project?
Thank you. ABDM is has a long journey. I know that nationally this mission is only 2 years old now. So, but we started, or India started making ABDM or Ayushman Bharat Digital Mission. Earlier it was named as National Digital Health Mission. In 2016 and 17, when we started health policy, 18 a blueprint came up, 19 we developed a stack, and in 2020 it was piloted in 6 Union territories, and then in 2021 September we nationally launched it in all 36 states and UTs. For only 2 years, ABDM has started to function, and ABDM, as you know, is a voluntary mission, and it doesn't have a mandate on any of these stakeholders. We all know that there are so many stakeholders, various cogs moving in the health landscape. We have patients, we have doctors, we have hospitals, small, large, corporates, we have rural, we have urban divide, we have different digital solution companies. And this all ABDM starts to, and in a voluntary mission has to nudge everybody to come and get themselves onboarded on ABDM. Absolutely, COVID, we started before COVID making this blueprint, but COVID really helped us in moving everybody to the digital way of handling their businesses or their lives. We have started handling our lives or banking systems or vendor payments or how we interact with socially, we interact with other people. We have really changed how we interact in our daily lives. And this changing in healthcare delivery was obviously in the making, that we have to revolutionize this also. And we at NHA are more or less certain that this revolution is going to come, and is going to come in very, very near future. If you see the kind of gains that we have made in the just 2 years of national launch, we have covered around crores of, I think we have 38 crores Abhas now, and more than 45 crore Abhas, and 32 crore linked records are also linked to Abhas. So these 32 crore records are digital records, which have been created in rural areas, urban areas, in government hospital, government programs, private clinics, private small clinics, single doctor clinic, nursing homes. So different digital records are created in different digital health solution companies or different healthcare solutions, LMIS, HMISs, government program solutions. Khushi Baby is one of them. So various players are creating these digital records. These digital records are now actually available to the people who actually own them. So earlier, if I go to a hospital, my record, they might create non-digitally, or they may keep it in their medical records room. If they create it digitally, they might store it in their own servers or their own clouds. And I might have to request them that you please give me that record if I require for a second encounter. But now, once that solution is digitized and enabled with Ayushman Bharat Digital Mission, I become the actual owner of that data. So this is a very futuristic thing that we are doing in ABDM, and yes, we run it like a startup. We have a very short team. Earlier it was a very small team. Now we are increasing the number of teams also, and we change our strategies. Our organization is very, very agile, and leadership has always been there. I think yesterday our new CEO has been appointed in National Health Authority, and additional CEO has always been there, and he's the mission director for Ayushman Bharat Digital Mission. Digital Mission really aims to make things interoperable or seamless exchange of information or services or health claims, etc. So if you want to take one word for Digital Mission, I'll only say that interoperability is the one word that digital mission wants to achieve in healthcare services or healthcare delivery. You can access or avail and book your services, you can pay for your services, you can get your records, but those exchanges has to be interoperable and seamless, like we do in UPI payments or email exchanges or mobile telephony. These kind of things we have developed on the earlier infrastructure that India was already having. Some of the advantages that India had was the dirt cheap internet, good penetration of smartphones, mobile phones, mobile connectivity, Aadhaar digital identity, which people can authenticate themselves anywhere, and through various means, through a mobile OTP or their face authentication or their iris authentication. So these kind of technologies over those digital goods, we have developed this Ayushman Bharat digital mission, and I'm very proud to say that this is one of the things that India is developing which is not comparable with anywhere in the world. So it has received accolades from various developed nations and the developing nations as well. And the blueprint, various countries are coming to national authority and seeing that yes, this kind of interoperability we want to achieve when we start to make our digital healthcare ecosystems. Ayushman Bharat digital mission is having have to play with various ecosystem players. As has been rightly pointed, we have around 150 of them integrated with us. We are integrating more and more, maybe more than 1,000 people or digital solution companies or solutions are integrating with us on our sandbox currently. And we are trying to filter them out. So people who are not actively doing it, we are trying to filter them out. So actually there might be more than 1,500, 1,800 applications on our sandbox. But we only want to keep our focus on maybe more than 1,000 only, so that who are actually working on integration. So why are they seeing value in it? Because it's a voluntary mission. We are not asking them, we are not mandating them, we are not making them that your business can't run if you don't become ABDM compliant. We are just nudging them. They are also seeing this value. They also see that people are going to demand for it in very near future. People are going to ask for a digital record on their own mobile phones. People are going to say that if I have shown to one doctor, but I want to show to another doctor seamlessly. If I go to Apollo, maybe next time I will not go to Apollo. I might have to go to another hospital. So this kind of demand might come very soon from citizens, and people know that new startups are also gaining traction into this. So if people in the room know about Ayushman Bharat Digital Mission, and one of our products is Unified Health Interface. This Unified Health Interface says that is more or less comparable to Unified Payment Interface. So Unified Health Interface, different startups have come up because they think that the entry-level barriers are now gone. Even a startup company who comes and integrates with ABDM, any query which is put for a healthcare service will be available to them and will also be given to Apollo or Medanta, but will also be given to them. So if you want to book a teleconsultation on UHI, it will go to Practo as well as to maybe Medibuddy. So Medibuddy is a new startup company, or maybe Digilock, this Briefcase. So different companies are coming up. So these startups, this is again, this revolution goes on these things that new companies are coming and onboarding with us. So we know that we work with an ecosystem in a voluntary mission, in a varied and fragmented ecosystem, I'll say. And we need to create this demand also from the public, that they require and they ask for these kind of services whenever they seek healthcare whenever they go to a hospital or a doctor.
Thank you, Dr. Jain, for that perspective. And I would like to direct the next question to Ms. Gupta, the only other lady in the panel. So it is only fit that she speaks now. This is, regarding, the urban side of ABDM, the project at which the Path is working with ABDM. And I want to understand what happened, in the Mumbai pilot. Now, because ABDM has a lot of moving cogs, there is a doctor-facing side where you would want to onboard a lot of doctors. There is a patient-facing side where you want to give incentive to patients in order to show them the benefits of storing their records on their phone. And then there are the startups, there are the established healthcare providers. So if we specifically speak about the challenges and the opportunities that throw up when you are trying to convince doctors to digitize their patients' healthcare journey and their practice. How did that start in the Mumbai pilot?
Thank you, Maitri, for that question. So, before I talk about the challenges and opportunities of the pilot that we did, I'd like to set context on why and how we started the pilot. So, when ABDM was launched in 2021, we saw that the private sector participation in ABDM was fairly low. And as Sir mentioned, that it is a voluntary initiative. It's a voluntary mission. So, you really have to reach out actively to the private sector doctors to onboard them and, convince them to digitize their clinical practices. So that's how the challenge was identified. We had to come up with a model for private sector engagement. And PATH very actively works in implementation of health projects. So we had been working in Mumbai on TB elimination, and one of the projects was Patient Provider Support Agency, in which there is like a field team available, which has an available network of private sector doctors who they are regularly in touch with to increase TB notifications. So we thought that we have a fantastic network with the private sector doctors, and given the high dependence of health service delivery on the private sector, it's nearly 60 to 65%, it's very important to engage them, and we can try it out through this method. So we used that model for ABDM. The field executives, they were trained on what ABDM is. Again, because this is digital, we did not have ready-made trained field officers. There was a lot of capacity building involved for them. And they used this network, their trust with the doctor, to make them aware on what ABDM is, what are the benefits, what is the value proposition, and how it would be beneficial for them. And again, because this is voluntary, the first thing that a doctor asks when you reach out to them is it mandatory? You say no. Then why should I come on board? So, you have to get that value proposition in place. And then again, there are different use cases within ABDM, right? We talk about longitudinal health history as one of the major use cases because of the interoperability framework that it provides. But that may not be useful for every doctor. A general physician may not need your medical history. But for them, a digital solution may just be useful for maintaining your appointments and managing your clinic in a better way. So you had to find out what exactly the doctor needs and pitch the mission, pitch the digital solution in such a way that it would become a job aid for the doctor and not an additional burden for them. And if I have to talk about the challenges, I would categorize them into technical, operational, and behavior change related. And because this is a more implementation focused project, there were a lot of behavior change related issues that came up. Because the doctor is used to using pen and paper, and asking them to use a mobile application overnight is not possible. So you have to extend that kind of support to them. So when I talk about technical challenges, like Ruchit, you also mentioned that technical challenges are bound to occur. But what we need to be prepared with is a proper SOP to resolve them in a timely manner. So if a doctor is using a solution and the screen freezes or the records are not getting linked, you need to have that protocol in place to resolve that quickly. And our field officers acted like a bridge to support the doctors with them. Second would be operational, again, because you are telling them about a new mission, so they won't trust it easily. But we worked with the National Health Authority, we worked with the Public Health Department and the Municipal Corporation in Mumbai. So when the message came from the government, the trust factor increased. And the third, the major one about behavior change related, when you go and tell a doctor, you should start using this digital solution, it's very beneficial. They'll look at you like, no, I don't need it, my clinic is running just fine. But when you give them examples of other sectors where digitization has worked, you tell them about UPI, you tell them about CoWIN, then they say, okay, it's not all that rocket science and maybe I should give it a go. So they understand with these examples in a much better way. So, these are the different strategies that we used. And I have attended a lot of G20 events in the past year. And, one of the things that came up is that digital health suffers from pilotitis. So we do a lot of pilots, but we also need to scale them up to ensure that the impact is delivered. So I'm very happy to share that the pilot that we did in Mumbai got scaled up into the 100 microsite project, which was launched by the NHA. And now 100 such microsites are being established across the country. So,
So thanks, Tanu, for this very insightful answer, and that these projects suffer from pilotitis. So thanks for making us aware of another sort of terminology. And my next question is to Mr. Arul. Khushi Baby works in extremely difficult situations with the community. When we speak of ABDM and when ABDM was conceptualized, they used to say that in order to have the uptake of ABDM, you need to have the technology in hand. You need to have a mobile phone connection. You need to have a mobile phone in the first place for this whole thing to work. Or you also need a lot of tech set up in a particular hospital setting or a PHC setting or a CHC. Now, the tech setups in PHC and CHC settings are particularly challenging. When we speak of ASHAs and ANMs, they use multiple apps. So they are using Nikshay, then they're using the RCH app, the NCD app, in Rajasthan's case, the PCTS, the app, and then there's also Khushi Baby's chip which comes in, right? At a national level, we see a lot of uptake of eSanjeevani, which is a telehealth consultation app. There is eHospital. There is eRakta Kosh for blood donation and gathering. Now, how do we, navigate all these obstacles at the level of the village, at the level of the project? What has been your experience, with integrating your platform with ABDM? Do these two entities talk to each other? We know, for instance, that the TB programs officers are very encouraging in this entire process, but that may not be the case with NCD or RCH. So how do you struggle as a stakeholder to bring all the entities on field and make sure that your project runs smoothly?
Yeah, thank you for the question. So we have worked on ABDM on tested it on two places. One is Rajasthan and Karnataka. So while we see the field reality, first from the public side, so people, even though most of the ABA IDs are created, I see there is a bit gap in the public level where people forget to bring their ABA card or other card or sometimes the mobile phone. So that's been very challenging to make the flow easier on the community level. So that's one thing. And as a integrator, during our first time, there was a bit learning curve while seeing through the ABDM structure. It was really impressive though. But a lot of support from the team. They have created a lot of workshops, and they have documented websites, and the public community helped us to go through the process successfully, and we completed the M1 finally. Now we are still on a journey to make the M2 and M3 production compliance. So while one of the experience I have, we had an integration with eSanjeevani in Karnataka. So the actual way they propose strictly is that we have to communicate via ABDM APIs. Data should be shared via ABDM APIs. They really deny to give external APIs from their own side. It's really good that even various stakeholders, they want to use the ABDM ABDM network. They don't want to spend extra time and resource on creating other things, right? So this is one of my experience, and where we really again put a lot of resources on the our tech team side to get the M2 and M3 done. Speaking about the other stakeholders like NCD, TB Cell, RCH, so some of them are still trying to make it compliant. Our policy team is really hardly working with the government side to understand and getting the possible way out to do this. Yeah.
Okay. a follow-up question for Mr. Prakash, because he's the Ernst & Young lead. They are the tech partners with NHA. And the question essentially is, how do you gear up the state's journeys towards ABDM? Because health is essentially a state subject. And like Mr. Arul pointed out, there are problems with, when you want to integrate it with the NCD or RCH. So while there might be officers at Nikshay who would be very, very open to, the open exchange of data between, say, the states and the center through any private or public health platforms, how do you nudge and push the other departments of the Ministry of Health to do the same?
Thank you, Maitri, for asking this question. First of all, I would like to step back and, think first about health, then then digital health, okay? Now, country like ours, okay, where, in all the conferences you go, human resources shortage and their capacity building, these are the continuous themes. So, from the perspective of our country, and I think that is valid for world as well, health workers, human resources in this area are always in shortage. So when we apply digital in front of it, essentially we are trying to help them. We are trying to augment their capacity and capability. And that's what the perfect example of Khushi Baby, what we are talking about. And I would like to congratulate the entire team for this journey and the success you have achieved so far. So digital health is required for the country, for us, all of us. That is from the perspective of what is missing today. The more important point is this: the future is going to be the digital health. All the AI or all the analytics we are talking about, whether we are talking about the research in this area, whether we are talking about the solution for the rare diseases, it is only possible if we actually bring the digital component to the health. Okay, that is a very important aspect we need to keep in mind. So for our country, digital health is required, and for our future as well, the digital health is going to be the future. Now comes the perspective of ABDM. I would say that I was with Dr. Akshay yesterday at NHA. Already more than 49 crore ABHA IDs have been created. And I think one thing, ABDM gets always compared with success of UPI or success of Aadhaar. In my view, it is a bit unfair comparison. In last 2 years itself, I would say that NHA has done phenomenal job. And personally, I have been to many such meetings where they really think about like startup, okay? And everybody is aware that in this entire ecosystem, there are multiple players. And as Dr. Akshay has put, that it is not mandatory, correct? So you have to persuade and convince people to get going in this direction. So from that perspective, I would say that NHA has done a phenomenal job. And as he had mentioned, that it is agile thinking. If something is not working out, they will quickly go back to the drawing board and get going on that. Now coming back to your question on, how can we see that states are adopting ABDM? First of all, I would like to share with all of you that not only we work with the National Health Authority at center, but also right now our teams are working in West Bengal, Bihar, Uttar Pradesh, Haryana, and Rajasthan, Karnataka. So almost more than 50% of country's population, that's where EY has a presence. And so what we are observing, okay? We are observing that more and more decision makers are aware about it, and they are taking up steps towards this. Depending upon, earlier we had opportunity to listen to Rohit Kumar Singh, depending upon the officer's own interest level or the the knowledge level, the pace could be up and down, but definitely it is picking up. And health being state subject, center can a lot of time request, suggest, give funds. ABDM has a dedicated funds for states to hire project management unit to support in this ABDM journey. So depending upon the state's level, but overall I am observing that as a team we are observing that there is a definitely movement towards it. And the last point I would like to mention is this, from the perspective of if we compare UPI versus ABDM, UPI had the benefit of having the core banking infrastructure in place. Okay. In case of ABDM, that is work in progress. Okay. As Dr. Gupta was mentioning, convincing any doctor that why they need it, convincing them that why they need the EMR is altogether different ball game than telling them that your banking systems are already there. So fundamentally right now there is a lot of work which is required to have this digital solution, whether you call it EMR or any other application, in place at the point of generation of the data. Okay, so that's what is very, very fundamental, and it is huge work. And as Dr. Akshay has mentioned, ABDM is a journey and it's a marathon. Okay, and in our view, all the initiatives such as the Khushi Baby is taking or other partners are taking in this space, everybody needs to move in this direction. And I'm quite confident that this is the future and we will achieve that milestone. Thank you.
So taking the question ahead from what Mr. Prakash mentioned, I'd like to pose another question to Dr. Jain, and that would be about how essentially how do you see the state's journeys? Now, software is one thing, but then there's also hardware. Now, you need real computers, mobile phones, internet connections in order to get things going from the healthcare providers, from the health facilities point of view as well. And during the course of the many stories that I have done on ABDM, I've spoken to a lot of states, and they've said that, we have to budget out for our hardware. Now, I don't think that ABDM at this point in their budget is making that provision for states, right? And a couple of officials had also told me that, okay, not wholly, but we might fund them partly in future. But the states at this point, especially Himachal Pradesh is one example, they were finding it extremely difficult to cater to, that kind of hardware infrastructure. So what use is the software without the hardware, and how do you think about that in NHA?
Absolutely correct. But before I come to a question, maybe I'd like to add, when my distinguished panelists are comparing Aadhaar and UPI to UHI and Aabha, see, Aadhaar was only giving one identity. What Aadhaar was doing, Aadhaar was capturing your demographic profile and giving you one 12-digit number. This was the simple task. Mentally, it is very, very simple people to understand what Aadhaar is doing. And they took much, much more years than to come to 50 crore number, which you are about to approach in just 2 years. ABDM, as compared to Aadhaar, is a complex mission to understand mentally. So it requires some mental effort to understand why should I get a Aabha number? How it is going to help me out? How it is going to actually help me in the immediate benefit? So in a difficult, complex mission, we are achieving what Aadhaar achieved in, say, long time than what we have achieved. For UPI, absolutely, UPI was done in a systematic way. They had a regulator with them. They had RBI, and they had more than 20 scheduled commercial banks, which are already having core banking systems. And it was a very, very set out format in which UPI was implemented, with the help of a regulator, with the help of a stick also. But in ABDM, we have a fragmented ecosystem that has been already compared. But then UPI also had a fillip from demonetization, another fillip from COVID, I am not asking for a COVID to come again, but I am saying that we are not having, with a voluntary mission, we are having this steep battle, and we have achieved huge gains in the last 2 years. Now coming to your question, hardware, yeah, absolutely, hardware is urgent requirement. As Dr. Prakash has already mentioned, that state health is a state subject. So ABDM was first conceptualized with 1600 crore rupees for 5 years, and out of that only 500 crores have been provided or earmarked for the states. Those 5 years are also spread out, 500 crores are also spread out for 5 years till March 26. So we have not conceptualized that we are going to provide any hardware support in ABDM. What we can do, and we have already done, is I think we have developed some guidelines, and we have provided to the states as a reference guidelines that if you want to have a digital infrastructure or digital delivery in your healthcare hospitals, whether they are at district hospital or medical colleges or primary healthcare center or community health centers, different level of healthcare, we have provided them guidelines that how much hardware you would require. So suppose if you have these many registration counters, you will require these many computers, you will require so many face recognition cameras, or for face authentication cameras, or some scanners for scanning the barcodes or QR codes. If you have so many doctors or so many departments, or so many labs, you will require so many computers and printers, etc. there also. So we have divided these guidelines and given out to the states. We are also incentivizing some of the healthcare facilities with our digital health incentive scheme, and these are untied funds which these health facilities are getting. Some of them are getting in few lakh rupees, some of them are also approaching crores. So these incentive schemes for every digital record that they create, we are also incentivizing them and directly providing those benefits to their Rogi Kalyan Samiti accounts, which can be used by the healthcare facilities in their own manner. We are also coming up with some guidelines to show that how these funds can be used for your own infrastructure, developing your hardware infrastructure, or incentivizing some of your employees who are creating data health records. And secondly, we have also approached National Health Mission, which is a huge mission. I think more than 30,000 crore is their outlay. We have approached them and told them that you should ask, or you should have some earmark funds for the HMISS to be procured statewide and to be implemented in all public healthcare facilities in the states. And as you all, I think most of you would be knowing that Ayushman Bharat is one of the pillar, and one of the pillar in Ayushman Bharat umbrella scheme is Ayushman Bharat Health and Wellness Center, where 66,000 crore has been outlaid for the infrastructure, in PM Abhim, not Health and Wellness Center, in Pradhan Mantri Ayushman Bharat Health Infrastructure Mission, which is a 66,000 crore mission, which has started in this August 2023, and in which we are providing money to the to the states for procuring not only the civil infrastructure but also the IT infrastructure as well as the manpower resources. So center is doing what it can for deploying the health infrastructure also in the states, but we know that most of the states have health as a state subject, and we know that states are also in a spectrum. So some of the states are very much ahead of us, some of the states are still lagging behind in the health infrastructure that they have developed in their own in this state. Thank you.
We have just time for a question or two from the audience, if anybody wants, because we do not want to lose this opportunity to question Dr. Jain. Yes.
Hi, this is Hemant. I come from ICMR, National Institute of Epidemiology. So I'll take 1 minute to give a background and then I'll ask my question. So from the public health side, we have the population health registry where the ANMs and ASHA workers, have a annual health survey, and they update the details of households that are living in my area. And on top of that, you try to link your various I'm talking of an ideal scenario. On top of that, you try to link your various applications. Could be an NCD application, could be a, it could be a TB, ideally a TB program application also should be linked to this, so that you have the denominator and numerator information. And each disease control or health program does not have to do an annual health survey again and again and fill it. Now this is one side. Now comes Ayushman Bharat Digital Mission, where the focus is more about having a digital, should I say medical, you have your health record as the base, which is your PHR. On top of that, you will be able to seamlessly talk to various healthcare providers, diagnostics or medical service providers. How do you see these two getting linked to each other? Because at the end of the day, here we are talking about medical services. From a public health angle, we are more interested in knowing what's a denominator, which disease condition has been detected, and linking that to the denominator, so that an ASHA worker or ANM doesn't have to go and do the survey again. She knows that I have a TB patient detected in my area. So I know I'm talking about ideal, but all of us are trying to get there. So in this context, how are these two talking to each other? Ayushman Bharat Digital Mission, and from a public health angle, what we are doing or what CHIP is doing. Over to any one of the panelists. Thank you very much.
Maybe I'll take it. I'll start answering, maybe other panelists can also add up. In one of the examples that what Andhra Pradesh did. Andhra Pradesh was doing one health survey, and while initiating that health survey, they thought that this health survey would be done on a healthcare application, which all the frontline workers are going to carry them. And that application was first made ABDM enabled. Okay. And when they did it, they created, they enumerated, this enumeration drive was for non-communicable diseases. And this enumeration drive that they created, they approached door to door, and more than 3 crore Abhas were created. And though the records or the enumeration that was done for all people, for all 3 crore people, was also linked to those Abha numbers. So in a single population survey, we created some digital health records. We created, those digital health records are digital and interoperable, and also linked to the Abha numbers, which are now accessible to the patient, which they can use for themselves when they go to a doctor. Suppose I was detected with tuberculosis in that survey, and that record is with me in my mobile phone application if I use one, or it is still available in that application. So when I go to another ABDM compliant healthcare service provider, that healthcare service provider can make use of that digital health records either through me or through my mobile phone application or through that digital solution which was created by Government of Andhra Pradesh. So we in NHA have also requested all the state governments, whenever they do this kind of population health surveys, to make use of the example which Andhra Pradesh has already done and get this population survey on a digital device which is ABDM compliant. And we have also approached different census which are done at central level also, that all such surveys should be done on a compliant solution, which adds to the longitudinal record of that individual, and that individual can make use of that record whenever in later.
I have a small question. So while you are designing the ABDM system, where there is already other exist in the community level, where each individual is having a unique number, how it makes a difference to create another unique identifier for each, the member in the community. If it's a matter of security, how Aadhaar and ABDM is different from that perspective?
Absolutely. We have heard this question many a times, that why are you creating another unique identity which we have already created Aadhaar, why are you duplicating it again? And most of our Abha numbers are also direct one-to-one mapped with the Aadhaar number. So more than 99% of Abhas are directly connected to Aadhaar numbers. So if I want to create my Abha, if I put in my Aadhaar number, in 15-20 seconds I get my Abha. So the process is so simple. I just have to authenticate that I am the person whose Aadhaar number I have put in. Why have we created Abha again? Because one or two guidelines from Supreme Court that Aadhaar cannot be used, or Aadhaar cannot be shared, cannot be stored. So we thought that we are going to create another, and specifically for health, Abha. And earlier it was called as National Health ID. But then we renamed it as, it is not an ID. We are more going to compare it to a bank account and call it as a health account, not as a health ID. We are not going to provide any health ID again to add to more IDs that people have to carry. And we intentionally have named it as an health account, where you keep your, in bank account you keep your financial transaction, in health accounts maybe you'll keep your health transactions. And there are several things in Aadhaar number, Aadhaar addresses is also mentioned, like UPI also has a UPI number and UPI address. We have Aadhaar number, Aadhaar addresses, the relationship one to many. You can have one Aadhaar number, multiple Aadhaar addresses. In multiple Aadhaar addresses, you can store your different health records. I can store my orthopedic records in one address, my other mental history in another, my sexual history in another address. So I might be having one Aadhaar number by multiple Aadhaar addresses. I can store them properly, segregate them, share them accordingly with my future healthcare providers. So yes, it's a thing that we did, and maybe it was duplication, but then it was required by the regulatory environment which was available that time.
We have to unfortunately close this. Maybe you can take it camera. And I really thank all panelists for being so sporty and engaging with a very difficult audience and taking these questions. In an ideal world, everybody would have an Aadhaar ID, and those would also help, to understand how many people got screened for various diseases, how many got treated, what is the impact. But we are living in a far from ideal world where even the personal data protection bill is not still in place. So, there is a little bit of a lack of trust there as to, what will happen with my data, my records of, say, diabetes going to a startup, at the back end, they have an entire visualization of the longitudinal health records, but, some companies getting a heads up on this, etc. So there are a lot of debates. These debates are not going to stop. It's not going to stop with this panel. So we look forward to having many more invigorating and engaging discussions about ABDM with the NHA. मतलब सवालों और जवाबों का सिलसिला जारी रहेगा, बट अभी के लिए हम इसको यहीं पे ख़त्म करते हैं. थैंक यू सो मच.
Thank you, panel, for your key insights. I would now request Khushi Baby's product lead, Mr. Pawan Singh, to kindly come on stage and facilitate the panelists. Dr. Akshay Jain. Ms. Tanu Gupta. Mr. Prakash Singh. Ms. Maitri. And Khushi Baby's very own Srini. I would request the panelists to please stay on the stage for a photograph. It was great to hear about the challenges and opportunities in building and implementing the digital health ecosystem here in India. To add to this conversation, I would next like to call to the stage Dr. Shruti Gadgil, Clinical Specialist Health, AI Research and Innovation at Google Health. Dr. Shruti is a distinct physician and healthcare IT professional, boasting about 21 years of expertise excelling in clinical practice, digital solutions, interoperability, medical devices and quality of care. She is currently focused on Google Health's Open Health Stack, Health AI, R&D and deployments. Her wealth of experience stems from roles at Misys, Allscripts, Siemens and GE Healthcare, where she managed global clinical products in digital and devices portfolios. Google Health is playing an important role in India's emerging digital health ecosystem through tools like the Open Health Stack. Please join me in welcoming Dr. Shruti.
To adjust it to my height. You can, yes. First of all, I would like to thank Ruchit and whole Khushi Baby team for giving us this opportunity to talk through Google Health and Khushi Baby collaboration. We just began this journey this year, and I personally have visited Khushi Baby's Rajasthan site along with Google leadership team. And the amazing work that has been done on the ground, or they are continuing to do. We are highly impressed with the work that Khushi Baby and the kind of impact that they are creating. So I'll be very short, and because I know everybody is waiting for lunch, so I'll have just a few minutes to talk through this collaboration. And as Ruchit mentioned this morning, we all are here to showcase or kind of like sell or present what we are doing and what products that we are bringing it to the market. So Google Health and Khushi Baby, the collaboration primary areas are three that I would like to highlight. The first one is Open Health Stack, and I'll get to it in a minute. The second one, we heard about it from the former secretary this morning as well, about the lightweight health AI models. And we do have MobiSense as a primary research and innovation and development areas within Google. Coming to like anemia model, cough model, and similar lot more these kind of mobile sensing technologies where Google has built foundational models, and we are in the various phases of this, either in the data collection, clinical validation, or deployment for the social impact. So the primary area where we are collaborating is more on the social impact as well as the clinical validation or A/B testing. The third area is about the large language models, something that can be useful in analytics, dashboards, as well as the community healthcare worker training or in the capacity building. Next. So talking about Open Health Stack. So Open Health Stack essentially is a suite of technical components. These are not applications. This is not an application that you can just take and use it. These are the building blocks or infrastructure blocks that enables all the developers to build any digital application in the health space in the timely manner or in the faster way. And these are scalable, interoperable, offline capable, which is highly relevant to country or the remote areas where there is connectivity is an issue. These components, so this is like a suite of products. There are three primary components: Android Fire SDK, which helps you to build the actual mobile application. FireAuth proxy, so this is the info gateway, which helps you basically to take care of your organization level access control to the important information and design to suit your need for the organization. The third one, which is Fire Analytics, this helps you to build basically the data from Fire or SQL on Fire to get to the dashboards for the analytics purpose. So we don't just build these, we have not just built these components. There are additional app demos, web admins, dashboards, sample codes, or the sample applications that can also be incorporated or used in your development. And the future capabilities, and I would proudly say that when the slide was prepared, it was like future capabilities today. Lot of these are already incorporated into the OHS world as well, which are like third-party or the first-party sensors and MobiSense that I talked about, and the AI/ML model capabilities. Go to the next. You'll have to. Okay, so this is kind of like an ecosystem look. The purple blocks that you see are the OHS components, but the developers, the blue pieces that can be built on top of or using these components, and these are something that the developers can build to suit to their need. It's so essentially, if you're starting from scratch, it helps you to build the Fire native applications, which is very, very relevant to ABDM context in India, because the library, the screeners, and the ABDM profiles are all R4 specifications of the Fire, and OHS definitely supports all Fire profiles. And you can go to the next. So it's not only the new systems, but the legacy systems also can leverage the OHS components through existing non-Fire tools, third-party mapping tools, so they can also get onboarded to this OHS ecosystem. Go to the next. You can move to the next. We are very proud to announce that OHS is also a digital public good. So this is like open source and recognized as DPG. We are also recognized as a global good for health and digital square for global good for health. And we are collaborating also, or we are also working with NHA, CDAC, NRCES, and few other prominent NGOs within country as well for their adoption and leveraging the ecosystem of OHS components. We do run the weekly developer calls, so if anyone is interested in from this room to join those developer calls, please feel free to collect card from me. We do have the ohs.dev as our website. All the material is also on the website, as well as you can write to us hello-ohs at google.com, and then so that's pretty much about the product, and I have best utilize this 2 or 3 minutes to showcase our product as well, and we are very happy to collaborate with Khushi Baby and looking forward to more collaboration in 2024 going forward as well. And I wish all the very best to Khushi Baby, and thank you, Ruchit and team.
Thank you, Dr. Shruti, for your insightful comments. Open Health Stack certainly has a lot of promise to broaden the digital health system and ecosystem and help us connect various solutions through the ABDM framework. At this time, I would like to welcome 3 members from the Khushi Baby team to the stage. Mr. Pawan Singh, product lead at Khushi Baby. Mr. Singh has 10 plus years experience in research and public health, and he is leading the product design team for Khushi Baby's chip platform and is involved in field scoping and research as per the national health programs. He will tell us more about the chip platform and how it aims to solve some of the challenges faced by community health workers in the context of this new digital health ecosystem. Dr. Vijendra Banshiwal, program lead at Khushi Baby. Dr. Vijendra is leading the customization and development of the base application platform, and he will tell us about efforts to integrate chip across the ecosystem. And let's welcome back Srini, CTO at Khushi Baby. He will tell us about Khushi Baby's future product map with chip.
So, thank you, Hemant ji, introducing me and my team. So, सभी को धन्यवाद बोलते हुए मैं चिप के बारे में बात हो रही है, ABDM की बात हो रही है, हम थोड़ा शुरू करेंगे। बहुत सारे हम सभी को पता है कि बहुत सारे एप्लीकेशंस पब्लिक हेल्थ प्रोग्राम के तहत ANM और आशा के द्वारा चलाए जा रहे हैं, और जिसमें आयुष्मान भारत डिजिटल मिशन एक महत्वपूर्ण कदम है, जो कि एक दूसरे प्लेटफॉर्म से बात कर सकते हैं, डेटा को शेयर कर सकते हैं, लाइक दिस। नेक्स्ट, चिप हमारा फोकस RMNCHA, नॉन कम्युनिकेशन डिजीज़, यहाँ तक कि हम ANM और आशा और कम्युनिटी लेवल पे जो भी प्रोग्राम्स गवर्नमेंट के द्वारा चलाए जा रहे हैं उनको हम कवर करने की कोशिश कर रहे हैं। नेक्स्ट, चिप के माध्यम से हम देख सकते हैं कि डिजिटल हेल्थ सेंसर्स लॉन्गिट्यूड फॉलोअप, कम्युनिटी सर्विलेंस, जो कि कम्युनिटी और फैसिलिटी लेवल पर पॉसिबल है। हम बात करते हैं कि हम लोग सभी बात कर रहे हैं फीचर इंटीग्रेशन CI की, लेकिन हम सिर्फ अपने प्रोडक्ट की बात करेंगे, छोटे छोटे कुछ इम्पोर्टेंट फीचर्स। हम सभी चाहते हैं कि कोई भी डिजिटल प्लेटफॉर्म हो वो फास्ट हो, पेपर से भी ज़्यादा फास्ट हो, लेकिन वो कैसे? देख सकते हैं हम वीडियोस, क्विकली कुछ वीडियोस डेमो। करेक्ट डेटा कैप्चर, रिड्यूस टाइम एंड न्यू एंट्री, नो मैनुअल टाइपिंग। हम OCR और QR कोड स्कैन करके जो मैनुअल एंट्री है उसको रिड्यूस कर सकते हैं। डेटा अकाउंटेबिलिटी के बारे में हम बात करेंगे। यूनिक आइडेंटिफिकेशंस, हम डुप्लीकेट को कैसे रोक सकते हैं, रिकॉर्ड को हम कैसे एंड बैक प्लीज़ रन अगेन, हम कैसे डेटा अकाउंटेबिलिटी को सेट कर सकते हैं, यूनिक आइडेंटिफिकेशंस, और सही व्यक्ति को हम सही सर्विस कैसे दें जिससे हम उनका हेल्थ हिस्ट्री राइट पर्सन के साथ लिंक कर सकें। हम बात करेंगे इंटीग्रेशन वर्क प्लान। अब आशा को सोचना नहीं पड़ता है कि कौन से 10 घरों में हमें जाना है। बेस ऑफ द प्रायोरिटी हम 10 घर को आइडेंटिफाई करते हैं कि जहाँ पे वो आशा विजिट कर सके और सही व्यक्ति को सही टाइम पे सर्विस दे सके। लाइक दिस सारे प्रोग्राम्स एक जगह हैं, सारी ड्यू लिस्ट ऑटोमेटिक्स क्रिएट होती। डिसीजन सपोर्ट, अभी बात हो रही थी, हम लोग अगर बेनिफिशियरी की केयर की बात करें कि कब कौन सी INM और आशा को बेस ऑफ द सर्विसेज किस टाइप के डिसीजंस लेने हैं हेल्थ केयर के बारे में, तो आप देख सकते हैं कि अगर BP की वैल्यू कम ज़्यादा होती है तो हम लोग डिसीजन लेने में सपोर्ट करते हैं और NM सोच सकती है कि उनको अगला कदम क्या होगा। आप देख सकते हैं DBT। अब देख रहे हैं कि आजकल के ज़माने में जब हम UPI पेमेंट की बात कर रहे हैं और हम सभी चाहते हैं कि आशा को टाइम से पेमेंट मिले, तो आशा को क्यों नहीं हम टाइम से पेमेंट दे सकते हैं। हम बहुत सारी टेक्नोलॉजी तैयार हैं, हमारी तरफ से भी बहुत सारी टेक्नोलॉजी तैयार हैं। अब कुछ पॉलिसी मेकर्स को, गवर्नमेंट को निर्णय लेने हैं कि आगे किस तरीके से हम बेहतर कदम उठाएं। थैंक यू। अब हम अपने कलीग डॉक्टर बिजन जी को बोलेंगे कि चिप इंटीग्रेशंस के बारे में आगे बताएं।
थैंक यू पवन जी। सो बेसिकली हमने क्या क्या अभी इस समय हमारी एप्लीकेशन में इंटीग्रेट किया है जो कम्युनिटी पे सर्व कर रहे हैं। हमने IoT डिवाइसेस का इंटीग्रेशन किया है। इन डिवाइसेस के इंटीग्रेशन से हम डाटा जो कि हमारे पास कलेक्ट हो रहा है उसको अकाउंटेबल बना सकते हैं। पहले हमारे पास BP की रीडिंग्स आ रही थी 120/80, यहाँ IoT डिवाइसेस से जो एक्चुअल रीडिंग है वो मोबाइल एप्लीकेशन में आ जाती है एंड डाटा कैन बी अकाउंटेबल एंड वी कैन टेक प्रॉपर डिसीजंस एट द टाइम। नेक्स्ट स्लाइड प्लीज़। Yeah. So in terms of telehealth, in our new chip 2.0, we have developed we have integrated with eSanjeevani। वहाँ हम इंश्योर करते हैं कि CHO अपने हेल्थ एंड वेलनेस सेंटर पे सभी बेनिफिशरीज़ को जिनको ज़रूरत है स्पेशलिस्ट केयर की या फिर उनको ज़रूरत है किसी डॉक्टर की, तो वो टेली कंसल्टेशन के थ्रू अपने कम्युनिटी हेल्थ सेंटर पे ट्रीटमेंट ले सकते हैं। नेक्स्ट स्लाइड प्लीज़। फैसिलिटी। बेसिकली हमारा चिप का डाटा जो कि कम्युनिटी से कलेक्ट होता है बाद में प्रसव वॉच एप्लीकेशन के अंदर ट्रांसफ़र किया जाता है वाइल डिलीवरी आउटकम जब फिल हो रहा है उनका, तो वहाँ से बेसिकली डाटा जो है उनका ANC का क्रिटिकल जो भी अगर डाटा था उसको देखा जा सकता है इन द प्रसव वॉच एप्लीकेशन। डॉक्टर्स कैन टेक फर्दर डिसीजन, उन डिसीजंस के आधार पे आइडेंटिफाई किया जा सकता है कि अगर इस महिला को हाई रिस्क है तो दे कैन प्रोवाइड द क्रिटिकल केयर। इस चीज़ का कम्युनिटी से फैसिलिटी पे डाटा का जाना बहुत ज़रूरी है एंड देन हम अगेन फैच बैक करते हैं डाटा को जो कि फैसिलिटी से वापस से ANM एंड आशा के एप्लीकेशंस में जाता है ताकि वो अपना PNC जो हैं उन चीज़ों को फिल कर पाएँ। तो ये कंप्लीट इंटीग्रेशन है कम्युनिटी का डाटा इन फैसिलिटी एंड फैसिलिटी से वापस से कम्युनिटी में। नेक्स्ट स्लाइड प्लीज़। अभी हमारा सेकंड पैनल था, इट इज़ ऑल अबाउट लाइक द ABDM एंड ऑल द स्टफ्स। यहाँ हमने जो M1 के साथ में M1 को हमने इंटीग्रेट किया है, हम उसका एक एग्जांपल यहाँ आपको दिखा रहे हैं। ये दोनों सेटिंग्स में काम करता है, ऑफलाइन काम कर सकता है, ऑनलाइन काम कर सकता है। इसमें बायोमेट्रिक्स भी इन्वॉल्व किए जा सकते हैं इन फ्यूचर। करंटली हम बायोमेट्रिक का इन्वॉल्वमेंट नहीं कर रहे हैं, लेकिन now M1 we are already M1 compliant, and we are hopefully like in a month or so we'll be completing our M2 and M3. Currently we are in the testing phase for that. I guess that's it. Thank you so much. Now I would like to call Arul Srinivaasan for the product innovation. Thank you.
Thank you, Dr. Vijender sir. So we have seen some features and capabilities on the previous slides of our chip application. Now, seeing the advanced technologies like Open Health Stack and the ABDM, so how we are envisioning our product over the year and what are the new features are going to coming up. So I'll give some brief detail about it. So no-code platform. So it's one of the challenges our product team faces, our developer faces. Whenever we get a new stakeholder, so we understand their requirement, it probably bit different from what we have already built. And the design team and the product team has to understand it clearly, going through bit of changes on the design, then go to the development sprints, test it out, and go for the pilot. So that's always been challenging and time consuming and as well as resource, right? So we thought of why not we have a no-code platform. We know the standards on the health industries, right? So let's build a no-code platform where we can simply drag and drop the components, and you can easily, without any coding knowledge, you can able to build any modules or apps in a matter of time. The skill to market advancement will help you to ensure that your innovation reaches the audience in the matter of time. Yeah. So, no. Yeah. So what else we have? Plugins. So existing plugins, advanced like OCR, biometrics, voice to text, and existing templates. We will be having a predefined templates in the platform where you can simply click and extend your fields or questionnaires, whatever you want. And the integration tools. So this is one of the important part where we are speaking about ABDM, how the interoperability works, right? So it was always been challenging understanding the tech stack, then integrate two technologies. So why not we have a visual tool which will help us to understand the base of our structure as well as any external third party who want to integrate with us, let's say ABDM or any GUI portals, NCD, something like that, where one can, developer having a minimal knowledge, understanding the things, can able to integrate it very quickly without need to spend a lot of hours on the coding. This is one thing. And Data Explorer, our various stakeholders in the government requires various indicators and stats on their day-to-day job to get take action, right? So we're also thinking of having a Data Explorer where they can generate their custom reports, create their own visualization, and schedule it to probably on the mail. They probably get the notification every day, something like that. So that's how one thing we are trying to envision. And AI models. Likewise, in Open Health Stack, they are having a future concept of bringing some ML models on the FHR bundles, probably giving some insights around it, right? So similar to that, it will open a really good path for this product vision to be collaborated with the Open Health Stack. Whatever integrators we are going to develop in this platform can be possibly integrated with the open health stack, where there is no need to do extra work for FHR conversion or the ML models, which Google is obviously going to done in the future. So one other thing is offline capability. So this is very much important in the rural area. Let's imagine a setup where a health facility having multiple healthcare professionals without internet working with data sharing options, right? So like the main thought of this future is to let the healthcare professionals easily send and receive data in offline network without just using their mobile devices, without need of any Wi-Fi router or something else. They can easily share data and take immediate actions. So this is one of the things we have piloted in SWC Karnataka project. In offline setup, we can still able to communicate across different devices. So that's one of the important future that will really help in the rural area setups. Now, I just want to take you through a small trailer video of how we actually see this. It's just 1 minute. So you can simply create a project, going through the description, and invite your team member who want to collaborate, and going through the hierarchy of the health system you want, choosing a templates, predefined templates in the system. Then the template is like, as you choose the templates, it's already coming up on the module. So now you can create a new screens if you want. Just simply drag and drop the components. So there's a toolbar where you can easily give a heading. So on the menu, on the left side, we have the attributes for each indicators. You can simply click and connect. So here we have connected the OCR scan plugin. So basically you added a button and you choose the plugin module. So now it will go through, now it will be integrated very much easily. So another field, how the text field is being created. So another use case, if you have a drop-down, so we will be having multiple drop-down, single select. So drop-downs do require a data source to be connected. So you can easily connect with any existing data source or upload a data source into the system. And that's how it's being visioned to be done. Yeah, go on. So once done, so we can, in the flow page, you can able to connect one screen with the other screen that help you to navigate once the particular job on the page is completed. And it's as simple as easier to develop, but it is not as easier for us to bring it in very short time. So it's like a very long roadmap we are having, and obviously support from OHS health stack and the ABDM team probably help us to achieve it faster. So thank you so much. I also like to give credits to our team members from product team, design, and Android team. I would like them to stand up from their seat, and let's give them a loud applause. Thank you so much.
Thank you, Pavanji, Vijendra, and Srini for sharing a glimpse of the CHIP platform. For those curious to learn more, please come by the booth in the lunch hour. लंच से पहले मैं जॉइंट डायरेक्टर मेडिकल एंड हेल्थ डिपार्टमेंट गवर्नमेंट ऑफ राजस्थान डॉक्टर एस.एन. धौलपुरिया जी का स्वागत करना चाहता हूं। डॉक्टर धौलपुरिया जी पब्लिक हेल्थ में 25 वर्षों से अधिक एक्सपीरियंस रखते हैं और डिस्ट्रिक्ट एंड स्टेट लेवल पर चीफ मेडिकल एंड हेल्थ ऑफिसर और जॉइंट डायरेक्टर जैसे पोजीशंस पर रहे हैं। इनके मार्गदर्शन में राजस्थान राज्य ने टोबैको फ्री यूथ कैंपेन 2023 के इम्प्लीमेंटेशन में देश भर में प्रथम स्थान प्राप्त किया। इसके अलावा 2023 में ही राजस्थान ने अब तक का सबसे बड़ा ऑर्गन डोनेशन अवेयरनेस ड्राइव चलाया, जो कि अपने आप में एक रिकॉर्ड है, जिसमें कुल 1.43 करोड़ व्यक्तियों ने ऑर्गन डोनेशन का संकल्प लिया। आई वुड ऑल्सो लाइक टू इन्वाइट स्टेट प्रोग्राम लीड डॉक्टर राजीव डॉकर टू द स्टेज। प्लीज जॉइन मी इन अ वार्म वेलकम।
आज इस सक्सेसफुल समिट के लिए सबसे पहले मैं खुशी बेबी संस्थान का आभार व्यक्त करता हूँ। मैं आगे कुछ बोलूं उससे पहले हमारे जो मन संचालन करता थे उन्होंने जो तारीफ़ें की है उस तारीफ़ों के लिए मैं आपको ज़रूर बताना चाहूँगा। जब इन्होंने इतनी तारीफ़ की है तो उसके बारे में बताना भी ज़रूरी रहता है। हर सरकारें काम करती है, राजस्थान सरकार भी उनमें से एक है। जब भारत का कोई प्रोग्राम चलता है कंट्री की सभी स्टेट्स काम करते हैं। काम करना और काम को मार्केटिंग करना, काम का इम्प्लीमेंटेशन करना, ये अलग चीज़ है। काम सभी स्टेट्स करते हैं, हम लोगों ने भी काम किया। जब हम तंबाकू यूथ कैंपेन की बात करें, पूरे भारत सरकार ने पूरे इंडिया में चलाया। एनसीडी में जो डेथ हो रही है उसमें इस ऑब्जेक्ट के साथ चलाया, जो नई जनरेशन आ रही है तंबाकू का, उसका सेवन कम से कम लोग करें, उसके बारे में अवेयरनेस करें और उसके बारे में अगर कोई सेवन कर रहा है तो उनकी काउंसलिंग से उनको छुड़ाने का काम करें। आज राजस्थान को सम्मानित जब किया गया था, उसका टॉपिक यहाँ चला है तो मैं उसके बारे में बताना चाहूँगा। उसमें बड़ा योगदान खुशी बेबी संस्थान का भी है। कुछ बिल्डिंगें बनती है पर उसमें नीम के पत्थर होते हैं, दिखते नहीं है, परंतु सच्चाई ये है कि वो बिल्डिंग नीम के पत्थरों पे टिकी रहती है। हमारी यहाँ आशाएं बैठी है, हमारी यहाँ एनम्स भी बैठी है, राजस्थान को रिप्रेजेंट कर रही है। हमारे सीएमओ साहब भी कई आए हुए हैं। बड़ा आलिशान कार्यक्रम किया भारत सरकार ने, हम लोगों को सम्मानित किया। स्टेट गवर्नमेंट को जो प्रमाण पत्र सम्मानित का था स्टेट गवर्नमेंट के माध्यम से मैं लेने आया भी था और हम लोगों को दिया। परंतु जब हमारी टीम ने काम किया उसकी रिपोर्टिंग का जिम्मा खुशी बेबी संस्थान को हमारे एसीएस मैडम ने, हमारे मिश्र निदेशक महोदय ने बड़ी जिम्मेदारी के साथ दिया। और खुशी बेबी संस्थान ने अपना गूगल फॉर्मेट बना के, खुशी बेबी की संस्थान की टीम ने डिस्ट्रिक्ट से बात करके, हमारे सीएमओ से कोऑर्डिनेट करके और हमारे डायरेक्टरेट में बैठ के जो रिपोर्टिंग का कार्य किया, इतना सराहनीय कार्य किया कि राजस्थान के आसपास कोई दूसरा स्टेट टिक नहीं पा रहा था। जब रिपोर्ट प्रेजेंट कर रही थी गवर्नमेंट ऑफ इंडिया, हम लोग दिल्ली में थे, तो राजस्थान के आसपास से नहीं था। काम तो उन लोगों ने भी किया था, मैं ये नहीं कह रहा वो स्टेट ने काम नहीं किया, काम उन्होंने भी किया, परंतु रिपोर्टिंग में बहुत ज़्यादा पिछड़ गए थे। उन्होंने खुशी बेबी संस्थान को नहीं पकड़ा। अगर वो पकड़ लेते तो हमारा कंपटीशन रहता उनसे। फिर हमने पकड़ लिया इन लोगों को और इन लोगों ने हमारे साथ, हमारी टीम के साथ, स्टेट की टीम के साथ, हमारे निदेशालय में बैठ के जो कार्य किया उसकी सराहना पूरी इंडिया में रही और उसी का ही योगदान रहा कि हम भारतवर्ष में फर्स्ट रहे। जब WHO के कंट्री हेड राजस्थान गए ये देखने के लिए राजस्थान में ऐसे कैसे इवेंट्स होते हैं, इतने बढ़िया कैसे इवेंट्स होते हैं। हमने हमारे राजस्थान के लिए उन्होंने कहा कि ये रिपोर्टिंग पार्ट हम विजिट करना चाहते हैं। मैं टाइम ज़रूर लूँगा, अपने एक फिजिकल जो एक्चुअली रिपोर्ट के बारे में आप लोगों को बताऊँगा कि आपकी जो रिपोर्टिंग आती है सिस्टम क्या है। हमने बताया हमारे पास तो लिमिट संसाधन है। हमारे IT के हेड जो हमारे IT देखते हैं वो भी आज यहाँ विराजमान है। मैं उनसे भी चाहूँगा वो भी आज बात चले तो वो भी आए। आइए आप 2 मिनट। तो इनका भी बड़ा योगदान रहता है पूरे राजस्थान की, चाहे PSC CSC की रिपोर्टिंग का पार्ट है। आप देखते हैं इन्होंने खुशी बेबी को साथ लेके हमारी रिपोर्टिंग को इतनी सजलता से चलाया। WHO के कंट्री ने कहा मैं विजिट करना चाहता हूँ, कौन से डिस्ट्रिक्ट की कौन सी जगह विजिट करूँ। हमने कहा आपकी मर्जी, हमारे राजस्थान में विजिट कीजिए। जो खुशी बेबी के माध्यम से उन्हें रिपोर्टिंग की है वो 100% सही है। उन्होंने कहा मैं विलेज हेल्थ सेंटर्स एंड न्यूट्रिशन कमेटी जो ग्रास रूट पे काम करती है पूरे इंडिया के अंदर, उनकी विजिट करूँगा। हमने फ्री हैंड कर रखा था। उन्होंने जयपुर की 3 VHSC की विजिट की और जो खुशी बेबी के पार्टनर्स के द्वारा, हमारे डेवलपमेंट पार्टनर के द्वारा विजिट की गई 100% सही थी, उसमें कहीं को किस नहीं था। उन्होंने उसकी तारीफ की WHO के कंट्री हेड ने। तो मैं ये बात इसलिए मेरे को इस प्लेटफॉर्म पे बताना पड़ा। आप लोगों ने जब राजस्थान सरकार के बारे में, जो हमारे ANM, हमारी आशा, हमारे डॉक्टर्स, हमारे CMOs की एक टीम ने जो काम किया उसकी तारीफ की है। नाम मेरा लिया, बाकी तारीफ तो पूरे राजस्थान सरकार की आपने। तो उसमें हमारे IT के हमारे बड़े योगदान, हमारे छोटे भाई का भी रहा है और खुशी बेबी का बड़ा योगदान रहा है। अभी जो कम्युनिटी हेल्थ इंटीग्रेटेड प्लेटफॉर्म विकसित किया गया उसमें सभी प्रोग्राम्स, चाहे TB की बात करें, चाहे टोबैको की बात करें, चाहे NCD की बात करें, चाहे CD की बात करें, सब एक साथ प्लेटफॉर्म पे रिपोर्टिंग हो रही है। बड़ा अच्छा ऑब्जेक्ट को पूरा करने में इसका योगदान रहता है। मेडिकल डिपार्टमेंट्स, भारत सरकार या राजस्थान सरकार या अन्य स्टेट, इस टॉपिक पे चलते हैं कि हमें उस व्यक्ति तक पहुंचना है जिस व्यक्ति तक चिकित्सा सुविधाएं नहीं पहुंची हो या चिकित्सा सुविधाओं से वो वंचित रहे। ऐसे व्यक्ति तक हम लोगों को पहुंचना है और उस पहुंचने में टारगेट होना बहुत आवश्यक है। अगर आपके पास टारगेट नहीं है तो हमारे राजस्थानी कहावत है, अंधेरे में जेड़ी चलाना। मतलब आप चल रहे हो, कोई आपका टारगेट नहीं है, आप अंधे होकर चल रहे हो, कहीं एक्सीडेंट हो जाओगे, रुक जाओगे। पर आपके पास टारगेट है तो आप उस गोल को पूरा कर लोगे। जो मेडिकल हेल्थ डिपार्टमेंट की थीम पे चलता है, मैं पब्लिक हेल्थ का आदमी इसलिए पब्लिक हेल्थ की भी बात करता हूँ, तो उसके अंदर आपका उस व्यक्ति तक पहुँचना और उस व्यक्ति जो ग्रुप चिकित्सा सुविधाओं से वंचित है वहाँ तक पहुँचना, ये राजस्थान सरकार ने गंभीरता से लिया। और आपको शायद यहाँ सभी स्टेट से आए हैं लोग, और स्टेट का मैं नहीं कह रहा, हमारे स्टेट में इस चीज़ को ध्यान में रखते हुए हमने पिछली साल, जो पिछले 2 साल की पीआईपी, अब 2 साल की बन रही है, पहले 1-1 साल की बनती थी, उसमें हमने इस प्रोग्राम को लिया और हमने खुशी बेबी संस्थान को साथ जोड़ते हुए पीआईपी में बजट मेरे हिसाब से 2 करोड़ के आसपास का था, 107 करोड़ का हमने पीआईपी में भारत सरकार से पास कराया। भारत सरकार को कह के कि हमारे साथ ये ऑर्गेनाइजेशन काम करेगा। इस दफ़ा भी हमने पीआईपी में डाला है। ये बड़ी चैलेंजिंग टॉपिक है और आपको मैं बताना ये भी चाहूँगा कि राजस्थान में हमारे एएनएम, आशा, मेडिकल ऑफिसर 72,000 के आसपास लोगों ने इस प्लेटफॉर्म का यूज़ लिया और 4 करोड़ के ऊपर इसके अंदर लाभार्थियों को चयनित किया गया और 85 लाख लोगों के आसपास का लोगों का सर्वे राजस्थान में खुशी बेबी की संस्था के माध्यम से किया। वहाँ हमारे साथ खुशी बेबी संस्था हमारे डेवलपमेंट पार्टनर की हैसियत से हमारे साथ, हमारी टीम के साथ काम करती है और बड़ा अच्छा लगता है इन लोगों के साथ काम करते हुए। ये भी हमारी तरह जब हमारी टीम बैठ के स्टेट में काम करती है तो संडे सैटरडे नहीं देखते, तो ये लोग भी नहीं देखते। हमारे धाकर साहब इनकी टीम है, जब हम लोग काम करते हैं, हमारे आईटी साहब के, हमारे स्टेट के इंचार्ज, आप देखते हैं पूरे राजस्थान की मेडिकल हेल्थ डिपार्टमेंट के आईटी डिपार्टमेंट को, तो इनको भी जब जरूरत पड़ती है तो ये काम उसमें देखते हैं। अभी भी परसों भी टॉपिक चला था फूड डिपार्टमेंट्स का, फूड और लेब का, कुछ गवर्नमेंट ऑफ इंडिया का पोर्टल उसमें आपस में इंटीग्रेट नहीं हो रहा, तो हमारे इनकी काम को देखते हुए मैडम ने कहा, तो एडिशनल चीफ सेक्रेटरी मैडम ने कहा खुशी बेबी वालों को बुला लो, काम कर देंगे। मतलब इन पे विश्वास, ये विश्वास की बात कर रहा हूँ मैं, कि उनको बुला लो, काम कर देंगे। पोर्टल गवर्नमेंट ऑफ इंडिया का चल रहा है, राजस्थान काम कर रहा है, पूरी इंडिया काम कर रही है, पर इनको आपस में इसमें कुछ आपस में रिलेशन नहीं बैठ रहा, तो उनको बुला लो। तो मैं डॉक्टर साहब को कहा, डॉक्टर साहब एक दिन आपकी टीम के साथ बैठो हमारे यहाँ फूड वालों के साथ, और फूड के अंदर भी देखो इसमें क्या दिक्कत आ रही है, लेब के अंदर, और हमारे जो फोस्कोस पोर्टल चलता है उसमें क्या दिक्कत आ रही है। ये विश्वास की बात बता रहा हूँ और विश्वास के साथ हम आगे बढ़े हैं। खुशी बेबी हमारे डेवलपमेंट पार्टनर के साथ काम कर रहा है और राजस्थान रिपोर्टिंग के मामले में कहीं पिछड़ता नहीं है। जो काम किया उसका 100%, चाहे हमारे सब सेंटर में किसी कोने की एएनएम जो यहाँ बैठी है वो रिपोर्टिंग कर रही हो, चाहे हमारी आशा रिपोर्टिंग कर रही हो, हमारे आईटी के हमारे हेड यहाँ खड़े हैं, उनके साथ हमारी पूरी टीम लगी रहती है और खुशी बेबी हमारी रिपोर्टिंग करने में बड़ी हेल्प करती है। और राजस्थान पूरे भारत में टॉप रहता है और रहेगा जब तक हम लोग खुशी बेबी के साथ रहेंगे, हमारी रिपोर्टिंग वंचित नहीं रहेगी। इसके लिए धन्यवाद।
मैं रिक्वेस्ट करूंगा राजीव जी को कि डॉक्टर धौलपुरिया जी को मोमेंटो देके सम्मानित करें। Thank you, Dr. Dholpuria and Dr. Rajiv ji. We look forward to the continued collaboration with the Rajasthan government. We can now head to the lunch in the hall outside, and we invite members to come by our booths and the media corner. And we shall meet back again in the next 40 minutes. Thank you. We would be convening by 2:15.
Workers are not salaried, skilled, supervised, or supplied, including right here in India. 100% are women, and it's a dual-sided human rights issue. Community health workers are both exploited and less effective for patients, meaning 1 billion people worldwide will go their entire lives without ever seeing a health worker. My name is Dr. Madeleine Ballard, CEO of Community Health Impact Coalition, a global movement of which Khushi Baby is part, making professional community health workers the norm by changing guidelines, funding, and policy. The result is professional community health workers who are salaried, skilled, supervised, and supplied, and quality of care for all, including those who provide it. Earlier this year, ASHA and Anganwadi workers released a list of demands, including official recognition as public health workers, entitlement to fair wages and benefits, and inclusion in decision-making processes that impact their work. We know that female labor force participation has propelled economic growth in countries around the world. But India has one of the world's lowest rates of formal employment for women, and the percentage of women doing paid work has declined precipitously in recent years. And yet, India also has the world's largest decentralized community health workforce, and it's 100% female. It has the emerging digital solutions, including Community Health Toolkit, Calm Care, and Khushi Baby's own Community Health Integrated Platform, or CHIP, which is currently scaling across Rajasthan. A few years ago, a Precision Public Health group attempted to use AI to enhance CHW household targeting. The algorithm concluded that every household in the rural area was poor, had women of childbearing age, and had children, rendering the targeting ineffective. I'm excited about what's possible when we take seriously the mission of using technology to close the underlying health infrastructure and data gaps that hold back health from too many of the world's populations. That's what's possible with CHIP. Tracking integrated population health, recognizing and compensating CHW work, and ensuring that we are precise in what we already know drives impact: salaries, skills, supervision, and supplies. Thank you, Khushi Baby, for hosting this event and demonstrating the huge gains that are possible when India's digital health mission includes CHWs.
Hi everyone, my name's Fran Baker and I'm Director of Sustainability and Social Impact at ARM, a leading semiconductor design company headquartered in the UK with offices globally. And our impact approach at ARM focuses on how technology can help address inequalities and close the digital divide. We aim to extend the benefits of technology to the people and areas that don't currently benefit. And so our journey with Khushi Baby began in 2015 when Khushi Baby won the Wearables for Good Challenge that ARM hosted with Frog and UNICEF. And in that challenge, we were looking to develop or surface innovative, affordable wearable technologies that could solve some of the fundamental needs for the world's underserved populations. Since then, we've continued to support Khushi Baby's innovative work, using technologies to address inequalities and reaching an amazing 44 million beneficiaries. Some of our collaborations have included connecting with other social impact partners such as Simprints, where Khushi Baby and Simprints collaborated on a pilot to test facial biometric technologies and authentication for community health worker verification of COVID-19 receipt in the Udaipur district of Rajasthan. And so from the beginning of our partnership with Khushi Baby, they've demonstrated their ability to be able to think innovatively, to create scalable solutions, and to use technology in a way that means that they truly are innovating even for the hardest to reach. As such, we're really proud of our ongoing partnership with Khushi Baby and the incredible impact that they're enabling through their community health integrated platform as they go.
I'm so thrilled to join you today. So let me first thank Khushi Baby for the invitation. As I'm leading the Infuse initiative at Gavi, I've had the pleasure to share a long and fruitful journey with Khushi Baby, who was actually part of our initial batch of Infuse winners back in 2016. Infuse was launched that same year with the aim to identify proven solutions which, when brought to scale like Khushi Baby, have the most significant potential to modernize global health and specifically immunization delivery. Pioneering solutions, such as the Community Health Integrated Platform, are instrumental in making this vision a reality, especially for remote areas. From its early days as a pacesetter that is an Infuse winner, Khushi Baby has shown the capacity to adapt to the country needs, to transform the vaccine delivery system while growing the team and widening its expertise. Today, the CHIP platform has completed health surveys for 35 million beneficiaries, and that is including 2.5 million children under 5. It's noteworthy that 23,000 children have been identified as zero dose by ASHA workers, and that offers invaluable insight at village level. In 2017, our collaboration also took a scientific leap, validating CHIP through a randomized control trial. A 12 percentage points increase in infant immunization rates among 3,000 mothers over 2 years was found. In 2023, we renewed our partnerships to deepen our impact in multiple transformative ways. First, focusing on zero-dose children, the CHIP solution will help reach 10,000 additional zero-dose children in Rajasthan. Second, in terms of health efficiency, 50,000 ASHA workers will transition to a paperless workflow via the CHIP. Third is capacity building, as Khushi Baby is working directly with health officials for training on the CHIP platform. Fourth is the interoperability with the existing system, and that is the integration of the CHIP with central government systems like RCH 2.0 and UWIN, which are a crucial step. In conclusion, I would like to extend my profound gratitude to Khushi Baby for your unwavering commitments. Your work and dedication to achieving impact align with the Infuse program principle and philosophy. To that end, I'm excited to announce that the next round of Infuse application will be launched next month in January 2024. So stay tuned and you will see we'll be seeking for innovative solutions uniquely positioned to enhance health system, particularly to equip them with resilient and climate-adaptive responses to today's climate threats. Together, we're set to impact India significantly, turning digital health gains into concrete transformative public health outcomes. Thank you.
Hello, I'm Dame Sally Davies and the founder of our Trinity Challenge. Khushi Baby was one of the winning solutions
We are starting in the next 60 seconds. Welcome to our third session, Big Data Driven Decisions for Public Health Impact. I would like to invite back to the stage Dr. Ruchit Nagar, CEO and co-founder, and now welcome Mohammad Sarfaraz Lambia, MTech Chief Data Scientist at Khushi Baby. Sarfaraz also serves as academic mentor of Great Learning. He has 8+ years of experience in applying principles from machine learning and biostatistics to public health problems for the Indian context.
Okay. Can everyone hear me? All right, so we're going to get started with our second half, which is, a packed second half of the day. Okay, let's get this fixed. Okay. All right. Okay. So I'm really excited to talk to you about our third session, which is all about big data-driven interventions for public health impact. And, we kept that in the title of our summit, converting gains in digital health into transformative public health impact. Because for all of our discussion on ABDM, digital health, ultimately it needs to impact the public. It ultimately needs to reach the community. And how are we going to do that? So I want to start by telling you a little bit about Khushi Baby's own approach. What is our theory of change? So first, let me clarify, we are a nonprofit organization, and we work as a digital health solutions provider to departments of health, like the government of Rajasthan. We have a new partnership working with the government of Karnataka as well. But how do we actually make the change that we wish to see? So fundamentally, we have two things. We have our tech, and we have our team, okay? So this is our theory of change. It's very complicated, but we'll go through it quickly. So on the left-hand side, you can see we have the CHIP platform and the Khushi Baby team. The CHIP platform allows health workers to use the app at the village level, sub-center level, primary health center level. It has a dashboard. It has automated reports, messaging. We're integrating AI. We have APIs through which we can send data to other parties, and data sets that we hope to make available to researchers and development partners who are working on the ground. And what about the Khushi Baby team? The team is actually giving services in terms of support from a policy, technology, implementation, and monitoring and evaluation standpoint. So how does the CHIP platform actually lead to this impact on the ground, or how do we envision that? Well, so you have the application, which is basically working as a single point of entry. We learned about how it can be used for a digital health census, for longitudinal tracking across different programs, for surveillance of new infectious disease. It can be used for all of these things. But additionally, it can be used for care coordination between the ASHA, A&M, and medical officer. Additionally, it can be used to help capture data quality. Data quality is very important before we can move to the next step of analytics. And it can allow for continuous learning for those who are using the platform. So the platform is not just about data capture, data reporting. It is supposed to be an assistive tool and a tool for continuing medical education for those that use it. What are the other components? For example, we have the dashboard. The dashboard allows for real-time performance monitoring. It allows us to see where the health disparities lie. And it also allows us to understand where we need to prioritize our resources. What else do we have? Well, we have the automated messaging systems. The kind of role model that we are following under is really Dr. Hegde's team at ARMMAN, who have scaled this up to the India level when it comes to sending personalized messages to each pregnant woman across the country. And similarly, we are trying to have a system in which we can have personalized engagements with community members as well with the health workers themselves. APIs, how are APIs relevant? APIs are relevant for harmonizing the data. We talked about the challenges of different systems. Currently, there is no common set of health indicators that can be shared between different programs at the central ministry level, even though there is ABDM in a common language. So through APIs, we can help share data seamlessly across these different silos. And finally, data sets. Data sets, it's all about making, again, accessible for new public health research to inform public health policies. This is all theoretical. We're going to go through a lot of examples, so I'm just going to kind of move forward. If you're interested in looking at our theory of change, it'll be available in the virtual folder. But generally speaking, what we're trying to do is we're trying to empower the community health workers, number one. Number two, we are looking to empower the health officials. And number three, we are looking to empower the community members themselves. And there's one fourth group, which is the researchers. We're hoping to bring the researchers into this group in order to overall uplift the system, have a better understanding of where diseases are, who is not getting treatment, and then across different health programs, start to see impact. It is okay. In fact, it is encouraged if we see that we are detecting more disease. For me, that is a positive sign. That means that our health system is reaching the areas that it needs to reach. And that's the first step that we can actually take towards ultimately getting towards treatment and getting people disease-free and healthy. Of course, in order for us to be successful in this effort of health system strengthening, we need government ownership, we need partnership support, we need research collaboration, and we have to overcome things like legacy platforms, data culture, which may be aligned more towards reporting and needs to upgrade itself to be more aligned towards impact, and the siloization or the verticalization of programs, which is still a barrier that we're trying to overcome. So, now to make this actually practical for you, we want to start by showing how the data can be visualized at the village level and how new insights can be unlocked. And for that, I'll invite Sarfraz to the stage.
So hello everyone. So we have developed a data visualization tool, which is so-called as advanced analysis. The major objective of building this visualization tool was two primary factors. The first one is, can we identify the vulnerable population and act accordingly? The second thing is that, can we start an intervention and assess the impact like whatever we do? So let's start, dig deeper into it. So let's start with a single layer, which is, so we have developed a multidimensional poverty index, which is the social determinants of health at the most granular level. And this was developed based on the principle of three factors: health, education, and the nutrition, as you can see over here. So let's look at, there are green to red gradients. If you look at the red levels, are the villages which are of higher poverty levels, and the green zones are those which are of above poverty line. Now let's look at, let me look, click at one of these clusters. If you see, we get information regarding the different forms of health, the nutrition, cooking fuel, sanitation, and the electricity. So we actually come to know why they are poor, in which section of these factors. So how about now looking at 2 indicators at a time? We know that data quality is a fundamental public health problem, and we need to act accordingly. So this is a combination of the MPI along with the data quality. So the blue zones actually identifies those health workers who are the good performers. Basically, they are doing the data retention, completeness, all the 3 forms of WHO. So, and the red zones are more towards the poor performer. We can say that the improving performer. So intervention can be planned accordingly for these 2 set of health workers and making sure that one gets motivated and other gets improved over time. So let's look at the combination of another 2 layers, which is the MPI versus the suspected 0 dose. So we know that child immunization is primarily the most important model, if you'd say, because the children doesn't get vaccination most often in most of the villages. So the blue zones over here, as you can see, are those clusters where the suspected 0 dose infants have been reported. Not necessarily they may be 0 dose infants. As I said, data quality is a problem. So we have to work on this indicator, because if you improve the behavior, definitely over time, health outcome will also get improved. Similarly, let's look at 2 more indicators, which is the NCD-related deaths and the driving time. Let me give an example. Suppose somebody has a sudden heart attack, and if the nearest hospital is much more far away, so you can say that 2 to 3 hours, then definitely the chances of having an NCD death is too high, isn't it? So here the healthcare service delivery has to be improved. It's all depends, ultimately, as I said, like at the end of the day, it's all about analysis and recommendation. So if you are finished with the analysis, then we do recommend to the health officials, and then it's up to them then whether they make any policy implication changes from their side. So let's look at 2 more indicators, which is, we know that now there is a strong topic going on around the world is between the intersection of climate and health. So here is one indicator. We know that Rajasthan is considering the high heat region. Now, if you look at the child malnutrition, the blue zones, the blue clusters where have been reported, along with if there are very high temperature zones within that village, basically it means that those are the areas where we have to intervene first, because those are the areas where children are suffering from different forms of malnutrition due to the heat axis. Now, let's look at 2 more indicators, which is the rainfall and the larva. We know that if the larva found in containers, then there is a high chances that there might be a possibility of dengue cases, the malaria. So how can we stop that? And rainfall plays a very important role over there. So in this intersection, if we see, if there is a blue zones, as you can see over here, so these are those areas where the health officials can take action upon. Finally, we'll look at one more example, which is the combination of air pollution along with the lung disease. So we know that lung disease is one of the most important factor when causal related with the air pollution. So here there are few clusters, as you can see in the map, the blue zones, which indicates these are the villages where we need to focus upon, and it's up to officials like how they act upon it. So now we discuss about how these features have been developed. Now suppose a health official wants to intervene upon it. So we have developed a tool called as A/B test, because that's a gold standard approach to assess our impact. So let us look at one of the indicator. Let's look at the most important one, suspected 0 dose. So let me begin with, so I would say the intervention name as update the 0 dose status. It's a WhatsApp communication, it can be push app notification, or it can be a bot call. So recipient name, let's say that ASHA has to update the status, because there are many ASHAs who doesn't used to do the service most often. They used to remain active for around 2 to 3 weeks, then they get inactive for around 3 weeks more. And then we consider the data quality score as the most important factor, because we have to cluster based on that factor, because there's a possibility that the poor performer health worker may not do understand all these indicators at a time, but if we intervene the good performer at the beginning, there are chances that these 0 dose status get updated. Next, it can be a pending survey. So basically, we are telling the health workers to update the status of all the infants across their village. So start date could be today, and the end date could be after 2 weeks. So, and success criteria, let's say 10%, and let's select as A/B test, basically control versus arm, and activate impact. So the message has been sent via WhatsApp. Now if you look at the intervention report, basically this is something to monitor over the course of 2 weeks, whether the message that has been sent to these health workers, are they updating the zero-dose status over time? And at the end of 2 weeks, the dashboard will be updated with something called as the success.
Yeah. That's not scroll. That's fine.
Yeah.
Success, yeah.
Yeah, succeed, yes or no. Basically, it means that the intervention was significant or it was insignificant. Suppose the intervention was significant, then we can have an AA test rather than AB test. Basically, it means that the intervention was successful, and now it can be applied for all the health workers. Basically, as I said, if we cannot measure what we are doing, then that's a big question mark to us, like, are we actually in a right direction or not? So thank you, and I would like to acknowledge my team members, because without them, this wouldn't have been successful. So they can stand up wherever they are. So firstly, I would say the data engineering team, Isha, Abul, Vaishnavi, from the dashboard, Sahil and Jayant, and finally the data science team, Afreen. So now I will say Ruchit to take over. Thank you.
Thank you, Sarfraz. So, I mean, this is an example of how we can now take decisions at the village level. There's a saying that every few kilometers, the taste of the water changes, right? And we can see that on the map itself. Every few kilometers, you have a new village polygon, you have a new concern or a new combination of issues that are seen on the map. So one is to understand what's happening at the local level. Before, these maps will just be this whole Udaipur district will be one color. Jaipur's district will be one color. You'll have 33 different colors on the map. Now we have 42,000 polygons that we can study, and we can make local interventions. And then the second key point that Sarfraz highlighted, that's very important. Now we can show hotspots, that's fine. But after you start an intervention, was that intervention successful or not? That question, that ability to measure your interventions and to be able to even gamify this dashboard for the health officials is really what the future will lie with these types of technology. So it's very early stages right now. It's kind of something that the Khushi Baby team is doing as a technical support partner, but definitely in the next stages, this is going to be released to all of our champion dashboard users, and then gradually to all 4,000 health officials who are across our platform right now using the dashboard. So a big kudos to the team for their hard work in putting this together. It really can be used for hundreds of indicators across all programs, and we hope to actually make this data accessible to researchers, collaborators, development partners who want to study different things on the ground and to see what their impact looks like. So now we'll move to our next session. So if we can just get these slides back. So a little bit of a brief in terms of how we envision what impact looks like. It's a stage-wise process. For us, it starts with developing a stable digital health platform. Right now, we have about 90% crash-free users, which is good, across up to 70,000 users at once. Then ensuring that this platform is actually adopted amongst our ASHAs and ANMs, that they like the platform, they use the platform. This is something that they would recommend to somebody else. Then getting a denominator. Once the ASHAs and ANMs have become comfortable with the application, they have to find their denominator for their village, right? And we have to have an accurate denominator for an accurate target. Once we have that, we can start to improve the diseases that are detected, and we can start to see which areas are needing more support and which areas are doing well. Then we can start to improve the service delivery by supporting those areas that need the support, and we can improve the delivery of services, the knowledge, attitudes, and practices of those health workers and community members. Then only we should talk about health outcomes. We're not here yet. We're probably stage 4 or stage 5 at best, but this is where we're going. And then we want to replicate those interventions which are working, which are evidence-based, and we want to have a way to always measure what thing is working and what thing is not working. And that's the final stage for a continuous improvement cycle for the public health system. So now we're going to talk about 3 examples of how community-level data is being studied and used to think about public health impact. The first topic is on tuberculosis. And for this, I'd like to invite Dr. Hemant Shivade up to the stage, Scientist E, Divisions of Health Systems Research at ICMR National Institute of Epidemiology. I don't have the time to give the full bio. He's a very esteemed guest, but please see our virtual folder for the full details. Over to you, Dr. Hemant. Thank you. There's a clicker. Yes.
Thank you very much, Ruchit. Yes, so the topic for the discussion is a bit long, so I've written it down. Use of public health big data to unlock impact at the last mile. So in this example, what I'm going to share is that all of you know in TB program, Nikshay is the TB IMS, or should we say TB Information Management System for the National TB Elimination Program, right? So we used the big data from Nikshay to assess quality of one of the key activities of the NTP program, that is active case finding for TB. So before I discuss or share what we found, let me give a bit of background about tuberculosis and ACF. All of us know that India has the highest burden of TB globally. We have around 2.8 million annual incident TB cases. This is estimated numbers, and an annual estimated deaths of 331,000 per year. And since 2017, to support the existing passive case finding, where the person who thinks he or she may have TB, they visit the health facility. This is called as passive case finding. Since 2017, NTEP decided that we will implement active case finding in all the districts of the country. Active case finding helps by closing the gap between estimated TB cases and the notified TB cases, basically detecting the missing cases. And hopefully we detect those cases early. And if we detect them early, put them on treatment early, the outcomes would be better. As a result of that, TB transmission in the community would come down, and eventually the economic costs on the communities also would be coming down. Now, all of us know in 2020, as a result of COVID, the TB notifications dropped. So in 2019, if we were reporting around 2.4 million TB cases, before that, in 2020, there was a drop by 25%. Right? So already there was a gap of missing TB cases, and then there was a drop in notification. So as a mitigation strategy, Central TB Division told we will push for ACF. Yes, ACF is already happening. We will further push active case finding so that we will detect these missing TB cases, and at least let us first reach the pre-COVID levels, and then let us further push to detect those missing TB cases as well. So to guide evidence-based strategic planning, the TB ACF evaluation project was commissioned by the India's Central TB Division, and ICMR National Institute of Epidemiology is leading this evaluation project. Next slide, please. So I'll not go into the details, but what we are presenting here are the findings of phase 1 of the project. In phase 1, we looked at Nikshay data to assess the quality of active case finding in India. Quality of active case finding, there are certain set indicators against which we measured what we observed. I'll give you one example of quality indicators, is that a certain proportion of the district population should be screened in one ACF cycle. Of those screened, a certain percent should be presumptive, that is suspected of TB, and certain percentage of them should be tested. If we don't meet these cutoffs, then we are not meeting the ACF quality. And if you're not meeting the ACF quality, or the ACF is not of high quality, we will not have the yield we are expecting, and we will not detect those number of TB cases. So what's the point of investing so much?
So what we did is for the year 2021, we extracted the ACF data from Nikshay. Now in Nikshay, the data entry happens like this. For every day of ACF activity, aggregate numbers are entered. Okay? So how many screened, how many presumptive, how many tested, and how many diagnosed. So we aggregated all this information at district level and compiled the indicators at district, state, and national level. So what did we get in the year 2021? First, the number of ACF cycles. We came to know that we are implementing one ACF cycle in a year. This means the districts are covering or intending to cover the high-risk populations once a year. Now, ACF has to be done in high-risk populations. Populations where TB could be higher than general population. There's no point implementing it in general population. This is a WHO recommendation. Most of the states or districts, did not meet, the population cutoffs. So there are two indicators that we're showing here. If you can look at the map on the left, the first indicator is percentage screened among the state population. It should be at least 10%. And on the right-hand side, we have number needed to screen. That is, at least if you screen 1538 people, you will get 1 TB patient. So none of the states and none of the districts met both these indicators, indicating that the ACF quality was poor. So to summarize, using this big data, they're huge numbers, but we have district-wise results as well. What we got is that the quality of active case finding was poor, and we implemented one cycle. Now this has implications and future directions as well. I'll take 30 more seconds. Now beyond the need to improve the quality of active case finding, and you can do that by planning in advance, having your micro plans, budgeting them very well, putting them in your PIPs, right? Not doing, stat ACFs, do planned ACFs, have incentives, have certain quality control indicators before the incentives are released. These things are there. Additionally, because we are talking about public health big data, these results also suggested that there is a need to improve ACF quality, data quality, not just ACF quality, data quality. The source of this data that is fed into Nikshay, that is aggregate numbers, how many screened, how many presumptive, how many tested, how many diagnosed, ideally should be a paper-based or a web app tool that is used in the field. Okay, you're so-and-so, name X, age, gender, do you have presumptive TB? 95% will say no, 5% yes, you track. Unfortunately, the use of this paper-based tool on the field was not consistently seen, right? So this is where we worked with the Khushi Baby team in the state of Rajasthan, and we said, okay, ideally, you can have a paper-based tool to, do ACF in the field. From there, aggregate numbers can be picked up. If you don't have any baseline in the field, well, how can you cross-check what is being fed into Nikshay? They went one step ahead and they said, we have an existing chip, and within that chip, we can add this module on ACF. So the module was added on the existing, population denominator they had, and when you do the home visits in the high-risk population, are you having presumptive TB? If yes, whether sputum collected? If yes, whether tested? If tested, what is the diagnosis? Now, the aggregate numbers can be generated from chip and added in Nikshay. Right? So this is the value of big data. Here, I'm not talking about impact at the impact to the last mile, but we're hopeful that as a result of this ACF quality assessment at large scale, it will feed into the existing ACF guidance, which would eventually, result in the change that we're looking at last mile. Thank you very much. Over to you, Ruchit.
Thanks, Dr. Hemant. I want to take 1 second to just build upon what you're saying. If we can go to the next slide, please. Yeah, and I want to just briefly talk about Rajasthan's experience with tuberculosis and active case finding. So as you kind of pointed out and highlighted, active case finding needs to be planned ahead of time. And we want to focus on those groups of people that are more vulnerable, more likely to have tuberculosis when they are seen by the ASHA, seen by the ANM. So in fact, the way that we structured the application, the due list inside the TB module, at first it only showed people that were vulnerable. diabetes, family contact of a TB member, HIV, et cetera, 20 different conditions that are there. And we kind of forced that to be the way that they would screen, okay? Then after some time, the government's policy was adapted, and they wanted a more general screening to take place. So we had to, also change the application. But for the first week and a half of this ACF screening process, we were just screening vulnerable people. We screened 2.5 or 25 lakh vulnerable people. Not we, ASHAs and ANMs did it together. And that was out of about 56 lakh total that we had identified. From our initial 4.5 crore database, 45 million database, we had 5.6 million people who were already known to be vulnerable. We reached 2.5 million of those. And we were able to identify 206 cases, okay? Now, where we need to improve is in identification of people who are symptomatic. So whether that's training, whether that's support, whether that's making sure that ASHAs are being paid on time so that they can do these extra activities, so that they can actually go door to door and find people who are symptomatic. But I do want to highlight that those who were screened amongst the vulnerable group were 4 times more likely than the non-vulnerable group to actually end up becoming TB positive, which is why it's so important to use this data to target how you are approaching your public health service delivery. And in fact, had we been able to reach all 56 lakh, an additional 250 cases could have been found through this last ACF cycle. So we're going to take these learnings forward to our next ACF process, and we're looking forward to using data in more comprehensive ways. So with this, now I'd like to actually invite Dr. Chintan Parikh to tell us a little bit more about tuberculosis and tell us a little bit more about how AI is being used across the cascade of care. He's coming from Wadhwani AI. Welcome. You can use this and the screen is there. Okay. Yeah.
Very good afternoon to everyone. I work on the programs team at Wadhwani AI. We are a not-for-profit organization that develops AI tools and solutions for impact at scale. I believe most of the people in the audience here are fairly aware of the scale at which TB affects communities in India. In 2021, 33% of the estimated TB incidence was unreported in India. And if we speak about mortality and loss to follow-up, that is the adverse outcomes, more than 7% of the cases were reported, had reported adverse outcomes in Nikshay. Because of the large populations involved, we have data which is available at scale. India's Nikshay tracking system registers and monitors TB cases longitudinally right from diagnosis until treatment outcome. And apart from Nikshay, we have other data sources as well, some of which are available in the government and others that we've collected as part of our project work. And all of these data sets provide a unique opportunity to seed improvements in the TB care cascade. So this is a brief overview of the TB care cascade. Given the limitations in time, I'll briefly speak about the AI solutions that Wadhwani AI has developed under the Trace TB project, which is funded by the USAID and supported by the Central TB Division. So for case finding, we have developed the vulnerability mapping for TB solution. Again, this is very much work in progress. We are mapping vulnerability at a tile level, which is at a resolution of 500 by 500 meters square. So the AI model essentially learns correlations between the case counts and the features at the tile level, and these include demographic features, healthcare accessibility, pollution, and so on. And the AI outputs a risk score for every tile that we want to infer for or give a prediction for. And these individual risk scores are then aggregated to give a village-specific prediction, and the final output is a ranking of villages that we'd like to provide to the district TB officer for case finding. The second solution is for screening, which is the Cough Against TB solution. It is made available in the form of an application that runs on an Android device. It basically utilizes solicited cough sounds as well as patient self-reported symptoms to give a prediction on whether the individual is likely to have TB or not. So the idea here is to empower the frontline health workers in the community settings for TB screening. if when evaluated against the current NTP protocols and screening criteria, it performs better. However, there's significant scope for improvement. The data that was used for building this model was primarily collected from high-burden TB settings. Ideally, we'd like more community data coming from individuals that are partially symptomatic and asymptomatic in order to develop the model further. The cough against TB solution is currently implemented in 4 districts of Nagaland at health and wellness centers with the support of CHOs, as well as in specific vulnerable settings in Mumbai through an ACF mode. The third solution that I want to speak about is the automated LPA for DRTB diagnosis. Again, the idea here is to provide a fast and accurate diagnosis for DRTB with little human intervention. So we have the line probe assay strips on which the output of the test is made available. The AI model essentially learns to recognize the bands, and it detects the drug resistance pattern of the TB positive cases. The first line LPA band accuracy, identification accuracy is 98%, and the second line band identification accuracy is about 97%. The model has already been validated by ICMR, and we are currently awaiting the final report. The subsequent steps that involve the larger integration with Nikshay and training of lab technicians will be conducted soon after. And finally, the last solution that I want to speak about is the treatment adherence. This is a solution that predicts loss to follow-up and mortality to prevent adverse outcomes. The data for training this model was again collected from Nikshay, covering all TB patients notified between the years of 2019 and 2021. The AI model gives or assigns a risk score to every TB case, which is then used to guide interventions in order to optimize the efforts of the healthcare workers. So the output is a list of, is a ranking of individuals based on their risk scores, which can then be further given to the healthcare providers, the frontline health workers, as well as the treatment supporters to provide targeted interventions and also counseling right from the initiation of the treatment. This model, so at a 35% targeting, the model has a sensitivity of 70%, and it's currently being implemented in the states of Madhya Pradesh, Haryana, Punjab, and a couple of northeastern states as well. So before ending the presentation, I would like to acknowledge and appreciate the support that we've received from the Central TB Division in providing us access and deployment pathways for a couple of our AI solutions. It wouldn't have been possible without their support, as well as the support that we've received from partner organizations, namely PATH, Piramal Swastha, and Japaigo. Thank you.
Thanks, Dr. Chintan, for showing us a glimpse of how AI can be used across the care cascade. In fact, Khushi Baby is excited to announce that we've also recently signed an MOU with Wadhwani AI, and one of our focus areas will be to expand upon this cough detection tool. In Rajasthan as well, in our last ECF campaign, cough samples were being collected, and we hope to work together in development of those models. So now we will move to our next topic area, which is climate and health, another area where big data is required. And for this, it's my distinct honor to welcome Dr. Prabhakaran to the stage. He's Executive Director of the Center, the CCDC, which is a branch out of the PHFI. He's a distinguished professor of public health at PHFI with appointments at Emory University as well. A globally recognized researcher. It is truly an honor for us to have him here today to tell us about some work on cardiovascular disease specifically and how it interacts with climate and health. Please join me in welcoming Dr. Prabhakaran to the stage. This is a clicker for you.
Yeah, okay. Thank you, Ruchit, for that very kind introduction. So everyone is confused as to what I do and where I am. Just to put things in the right perspective, I'm currently Executive Director of the Center for Chronic Disease Control and a distinguished professor at the Public Health Foundation of India. Of all the things which I gave Ruchit, he chose air pollution, probably because it was topical. but one of my main areas of work is actually developing electronic decision support, which is an ignored area in terms of AI and machine learning. We are using AI and machine learning for diagnosis and management of several chronic disease, and that's for another day. Today's topic is how are we using data in terms of air pollution. So we are trying to link air pollution to heart disease, and people have been talking about air pollution for quite some time, and everybody believes that air pollution causes lung disease, causes childhood pneumonia, and if you ask even doctors, they would say these are the two things, and many people are not aware that it causes heart disease. And these are several of the heart or cardiovascular diseases that are caused, which includes heart attack, stroke, gangrene, heart failure, hypertension, diabetes, and several others. Oh, sorry, how do I? Okay, now the question that we need to look at is, how do we relate air pollution to heart disease? The marker for air pollution, which all of us know, is what is called as particulate matter, or particulate matter 2.5. Now what is this particulate matter 2.5? It's a very tiny particle, 1/70th the size of your hair. If you take out a hair follicle and divide it into very, very small microscopic pieces, it's almost 1/70th of the hair follicle. Now, what does it really do? Before that, I should say this is a big problem, and everybody knows about this. 7 million deaths worldwide, around 1.25 million deaths in India. But the thing is, people argue saying that these are all model data. We need real evidence. In fact, there was a parliament question in 2015 or 2014, I've forgotten the year, as to what is the government doing about air pollution, particularly given that it has ill effects on health. So the answer given in parliament was that there is no clear-cut evidence that it causes any health problem. So we need to generate that evidence. And how do we generate that evidence? We need to first understand the mechanism. It's a tiny particle. It enters, you breathe it, it enters into the lungs. In the lung, the smallest unit of the lung is called an alveolus, which divides the blood from the exterior. It's called the alveolar lung or the alveolar blood barrier. Because it's so tiny, it enters blood. And once it enters blood, it stiffens the arteries, that is the tubes which supply blood to various parts of the body, increasing the blood pressure. It has direct effects on the heart, damaging some of the heart cells and causing irregularities of the heartbeat. It goes and deposits in the fat cells around the abdomen, increasing the risk for diabetes. So it causes multiple effects once it enters the blood. Now, one thing is to link, we call this the exposure. And we have to link this to an outcome like high blood pressure, diabetes, or heart disease. In terms of studying these risk factors, it's very easy if it is inherently present in a person. Suppose you want to link smoking to heart disease. You know the person is a smoker, so you collect a bunch of people, follow them up for several years, look at smokers and non-smokers and say, oh, smoking increases the risk 10 times or 3 times or 5 times. But how do you actually attribute an exposure to an outcome? So you need to get robust ways of measuring, because you cannot go and measure it in a person. You can't take blood and measure PM 2.5, you have to measure it in the air. So for that, what we did was we developed a machine learning AI-based model. So I'm giving you here an example of what we did in Delhi. The other thing is, in Delhi we have monitors. You can get PM 2.5 levels from the monitors. But a monitor in, say, Chanakyapuri will not actually tell what is happening in East Delhi. The distance is too far. You have to get finer grids. You have to get a 1 kilometer into 1 kilometer grid to see what are the effects of air pollution on a given individual. So we have a cohort in Delhi and Chennai, which we have been following up from the year 2009 onwards. We have multiple follow-ups. So we know when people develop hypertension, when they develop diabetes, when they develop heart attack or stroke. So what we need to do was to have a robust way of estimating the PM 2.5 levels. And this is what we did. We obtained PM 2.5 levels from multiple sources. First is we obtained it from the monitoring stations which are present in Delhi. There are around 25 monitoring stations. The second is there are polluting industries around the city of Delhi. They have what are called as emission inventories. They measure PM 2.5 in and around their industry, and so we get those values. The third is a satellite goes around the country and it goes around Delhi And we get the data as to what is called as aerosol optical depth from the satellites, and from that we can actually calculate what is the PM 2.5 levels. Now, we have these three values, we put it into a machine learning model, but more importantly, we need to, because this is dynamic, it's not static, it is influenced by the weather patterns, it's influenced by humidity, it's influenced by rainfall, temperature, several other factors. So we need to get the meteorological variables, and we also need to get the land use pattern. And so we obtained the data for over 1,557 days over a 6-year period, and actually estimated for every day of those 6 years between 2010 to 2016 what the PM 2.5 level was. This is because we know when people develop these conditions, heart disease, diabetes, stroke, etc. Now, once we got this, so this is the data which shows that it is increasing. The worst months, actually this is not getting animated, the worst months were in 2016, air pollution substantially increased between 2010 to 2016, and subsequently also it actually declined except for this year, which has been pretty bad. And then we also got how traffic density increases blood pressure in people. But what we found was that for every 25 microgram per cubic meter increase in PM 2.5, the blood pressure increased by 3 to 5 millimeters in every individual who developed hypertension. Now you might argue, how does it matter? Blood pressure below 140 is normal. My blood pressure is 120 and it has gone to 123 or 125. How does it matter? It matters at a population level, because if you draw the distribution of blood pressure in a population, if your mean is high, a lot more people will have hypertension. You shift the curve a little bit to the left by reducing the blood pressure of the population by 3 millimeters or so, you would reduce hypertension in the community. This is the power of intervening. This is the power of AI and machine learning, which gives you data on social determinants, unlike where you're talking about direct effect on AI in health. So this is the first finding that we had. Now, subsequent to that, we have shown that similar to hypertension, diabetes rates are also high, and we are working on several other areas. Many of them will be published this year. But we did one thing, that we found this in adults, but cardiovascular diseases, chronic diseases are prevalent across the lifespan. Actually, the risk starts during birth itself, and as somebody said, it's a disease which starts in the womb and ends in the tomb. So we now want to relate PM 2.5 to various aspects which can affect the heart. So we start off with pregnant women. They give birth to their children. So the pregnant women, what are the birth outcomes? What are the adverse outcomes during pregnancy? Then we look at children in terms of their cognitive effects, because we now know that if poor schooling can actually increase the risk of heart disease as they grow into adults. Then we looked at the adult risk factors. And finally, we are looking at the elderly in terms of Alzheimer's disease, dementia, and Parkinsonism. So this is the power of using machine learning and AI and looking at across the lifespan, what are the effects of air pollution. I think this is my last slide. Oh, okay. Now we also have moved on and developed an air pollution model for all across the country, and these are being published, and we are relating to several other diseases like reproductive and child health and so on. Thank you very much.
Thank you so much, Dr. Prabhakaran, for your insightful presentation. Certainly, we have a lot to learn from your experience in mapping air pollution and its various public health impacts at such a fine resolution here in Delhi. Of course, we all can feel it as soon as we step outside. And now the question is, how do we take that across India, to Rajasthan, where we already have a big data set, and to new geographies that we're also expanding. So next, I'd like to talk a little bit on the climate and health theme by introducing, if we can go to the next slide, please, our next speaker, who is Sanya Sareen, Research Manager at JPAL South Asia, to tell us a little bit about a new partnership looking at climate and health. Please join me in warmly welcoming her to the stage.
Hi everyone, it's great to be here. As Ruchit mentioned, I am Sanya Sareen. I'm a research manager at JPAL South Asia. And JPAL, for those of you who don't know, is a global research center working to reduce poverty by using scientific evidence. At JPAL, I'm currently managing our newest initiative called the India Data Capacity Accelerator. This is a really unique initiative that was launched by JPAL earlier this year in collaboration with partners including Data.org, Ashoka University, BITS Pilani, and IIIT Delhi. And the goal of the accelerator, I mean, it's manifold, but the goal of the accelerator overall is to better leverage the use of data to study issues at the intersection of climate change and health. This is a nexus that has increasing global importance. I mean, it was brought up multiple times at COP this year, but remains extremely understudied and has wide-ranging implications that we don't even yet fully understand, as highlighted by Dr. Prabhakaran's work in the presentation that we just saw. So through the accelerator, we actually have budding data scientists who are interested in applying their skills to the social sector, and JPAL places them on in non-profits and government agencies that are doing really innovative work at the intersection of climate and health. And so we're excited to be partnering with Khushi Baby through this initiative and leveraging the incredible work that is being done by them through the CHIP platform. Rajasthan is extremely vulnerable to the impacts of climate change across multiple dimensions, with extreme heat, erratic changes in rainfall, having implications that we're starting now to understand. Through our collaboration with Khushi Baby, we'll be working to unpack and measure the burden of these factors on health outcomes in the region. Some of the key topics that we plan to explore through our collaboration, which we'll be launching next year, is how environmental factors affect rates of malnutrition and anemia, especially among women and children, rates of non-communicable diseases, including heart disease and lung disease, and also how environmental factors are impacting the spread of vector-borne diseases like the dengue and malaria, chikungunya. But we're excited to be working with Khushi Baby and yeah, looking forward to all the things to come.
Thank you, Sanya. We are equally excited. And I think, like I said, this is all about working together, researching together, and trying to find out how we can disentangle the interactions between climate and health. So the next, we actually have a video that is next, which will talk about how the CHIP platform is not only an intervention itself, but it can also be used as a measurement tool. So not only is, to say that not only are we using the CHIP platform to help ASHAs and A&Ms do their jobs, but it can actually help us study different public health policies. And one important public health policy that came out last year was the policy announcing the community health officer, which is a new cadre of health workers, a mid-level provider. And Dr. Patrick from JPAL, who now is also at Yale University, will tell us about how he used the CHIP data to actually see how the CHO impacted health in these communities.
My name is Patrick Akshay. I'm a postdoc in economics at Yale University. Today, I'm excited to cover a research collaboration with Khushi Baby to study the effects of community health officers or CHOs on health utilization and health outcomes. Let me start by summarizing some of our preliminary results using Rajasthan's PCS data. As you can see in the right figure, we document that CHOs led to a large increase in patient visits to subcenters. While subcenters that did and did not receive a CHO in March 2022 looked similar in terms of patient visits before the reform, we find that once CHOs were posted with treated subcenters, patient visits rose by more than 60%. We further document a decline in elderly deaths by 12% within the first year, showing how better public primary healthcare lead to substantial improvements in health outcomes. However, we find no effects on various maternal and child health indicators, suggesting that additional support and additional policies are needed to achieve improvements along these margins. However, one concern with using HMS and or PCS data is that such administrative data often only contains accurate information for public facilities and the relevant catchment areas. We use our partnership with Khushi Baby to to use Linus information from the chip data to examine substitution patterns for individual patients, identify which patient groups benefited the most from the CHO reform. We have two preliminary results. First, we find that CHOs decreased the share of patients who did not seek care when sick from 38% to 81%. At the same time, share of patients who visited a subcenter when sick rose from 29% to 51%. We further find the CHO reform especially benefited scheduled caste households, increasing the public health utilization, leading to an overall increase in health equity. In summary, we show that the CHO reform did not only lead to large benefits for patients, but we also document how the chip data can be used to provide additional details of how government policies affect beneficiaries. Thank you again for the opportunity to present today, and all the best for the rest of the summit. Thanks again.
Next slide, please. Oh, wait, 1 second. Okay, so I want to talk about one last example, and then we'll get into our session on AI for last mile health. And this has to do with immunization, specifically child immunization, where we started our project 9 years ago. With the support of Rajasthan government, we were able to use the CHIP platform to screen 2.5 million children under the age of 5 and identify 42,000 children who are suspected as zero dose, meaning ek bhi tika nahi lag gaya hai, right? So they're missing their pentavalent vaccine. But they're suspects. It's possible that it was misreported or underreported. And our goal is to identify and catch up these children with vaccines. Here is a map that we kind of saw earlier, that where are the villages where we are seeing higher rates of under-immunization. So what is our approach to actually getting each child vaccinated and caught up? We first started by looking at this list of 42,000 and doing a randomized call to see what were the actual zero-dose rates and which were the rates that people were incorrectly reporting the zero-dose status. So we found that 16% of those people we had called were actually zero-dose. The people who picked up, those family members reported that, yeah, the child was actually zero-dose. Then we did a follow-up field study in Udaipur, where we found that only 1/4 of those people who said that, yeah, I'm zero-dose, was actually missing a vaccination. It may have been the case that the spouse had picked up the phone, they didn't know about vaccinations, they had said, ha, mera bacha ka koi tika nahi lag gaya hai, and then they hung up, but actually the mother had taken the child to the vaccination camp. So that was encouraging. That means that the number of actual zero-dose children is much less than the 42,000 number. Maybe the expected number now is down to 2,000, but still, who are those 2,000? How do we find them? We have to call all 42,000 people and find out, is your child zero-dose? Are you connected with the ASHA A&M? Do you know about the VHND session, the MCHN camp? So how are we trying to address this problem? We're trying to use machine learning models. So our data science team is working hard on this, and using the machine learning models, we're able to make slight improvements in our ability to predict who is likely to actually be zero-dose, improving our prediction from 16% to about 25% likelihood. And now we can rank this 42,000 person list in the order of priority of who we need to call first, who is more likely to actually be zero-dose. We can have a prioritized list for outreach, and then based off the locations where the zero-dose children are found, we can use our dashboard that you saw earlier for A/B testing to basically see which experiments can help catch up these children. Now, this is all fancy, and we're trying to do all these statistical things, but at the end of the day, you have to take it back to the field. This 2.5 million that you screened, 42,000 zero-dose, has to go back to the field. And this is what the reality looks like when we are trying to actually go and find that child who is missing the vaccination. This is our team members crossing a river that has kind of been overflowed after the monsoon. on that next part, there's actually a small house where you'll actually find, you have to traverse tough terrain, right? And then you actually come to that mother who may have been disconnected from care. So this is what motivates us. This is what we are trying to get to for all 2,000 plus suspected zero-dose children across Rajasthan. And of course, it's going to be a team effort. We'll be using data, we'll be using the support of our ASHAs and ANMs, of the health officials, so that way we can make sure that no child gets left behind. So with that, we're going to wrap up our third session on big data for public health impact. And because we're short on time, we actually need to quickly transition to our next session, which is all about using AI for last mile health. And for this, we'll start with a presentation from ARMMAN. We have Amrita Mahale, who is here, our Director of Product and Innovation at ARMMAN, who will tell us about work on using chatbots to train ASHAs and ANMs at scale. So please join me in warmly welcoming Amrita to the stage. Thank you so much. Yeah, I put it next. This is your computer. Can we get the next slide, please? Yeah. And then it's the video as well.
Yeah. Okay. Hi, everybody. I am Amrita Mahale from ARMMAN. ARMMAN is a nonprofit that works in maternal and child health with a focus on preventive care. We run two kinds of programs. One, programs that empower women with preventive care information through pregnancy and infancy. And the idea is to encourage them to seek care early. And two, programs that train and support health workers to provide better care with a focus on identifying high-risk factors early and managing them more effectively. So one of our programs is called IHRPTM, Integrated High-Risk Pregnancy Tracking and Management. Through this program in Telangana, we have trained over 10,000 health workers in the diagnosis and management of 18 high-risk pregnancy factors. So we've developed detailed protocols for what needs to be done at every level of the health system, from the ANM to the medical officer to the specialist. So we have detailed protocols for how to diagnose various factors, how to manage them at every level, when to refer up, when to refer down. And as I said, this program is currently live in Telangana as well as Andhra Pradesh, and is going to more states, including Uttar Pradesh, in 2024. So in Telangana, we've trained over 10,000 health workers. So the training happens in two phases. In the first phase, we have live training, so face-to-face training with health workers. And in the second phase, we give them digital learning materials for self-paced learning. And as you can imagine, this is a lot of learning material. So as ANMs go through this, they often have questions. And we provide a WhatsApp helpline, which they can use to send their doubts, queries, or questions that they may have when they apply the protocols in the field. So at the moment, this WhatsApp helpline is operated by human experts, so by medical officers who respond to questions. We are now building an LLM-based chatbot to answer ANM queries. And the idea is that the LLM will be able to answer most of the questions that come up using the training materials that we've created. And questions where the LLM is not very confident will go to a human expert. So we do have a human in the loop. It's a two-tier system. And I want to do a short demo. Can you play the video? So this is a demo interface that we've built. As I said, we are still in proof of concept mode. So the Q&A service works in two modes. One is FAQ match, where we match the user query with a list of canned responses. And we can match the query with either one question or multiple questions. And doing FAQ match actually allows us to be very conservative in answering questions, where the model is not generating answers, it's only picking from a canned list. So the first two questions you saw were fairly straightforward. But the model also does some simple logical reasoning. So it could break up pregnancy into second and third trimester and first trimester and answer accordingly. And most importantly, the LLM also knows when to refrain from answering questions. So we do not, the high-risk pregnancy program does not cover 50-year-old men, so the LLM refrains from answering. Now this is the second mode, the generation mode, where we let the LLM compose the answer as well. But it's not composing answers without any guardrails. We use retrieval augmented generation to force it to answer questions from the knowledge corpus that we've created. So you'll see that it also works with more and more complex questions where you have various symptoms and factors interacting. And we've tried this with fairly complex questions as well, which cover materials across multiple modules. As I've mentioned, we've created 18 different modules or 18 different protocols. So it answers questions that span different knowledge areas. It also understands multilingual queries. This is what is mild anemia, and it did answer the question. So I also want to talk about what's coming next. So while we were developing the LLM model, we also conducted user research to understand how a bot like this will be used, perceived, interpreted on the ground by ANMs. And it was actually very useful to do this in parallel with the technical work because it taught us a lot about user behavior. So for example, we know that ANMs tend to see the bot as an authority figure, which means they tend to trust the answers that come from the bot, which means we need to approach this with a greater sense of responsibility, with proper safety guardrails built in. We also learned that ANMs are likely to use a mix of languages, so they'll use English and Telugu, and they expect multilingual answers as well. So while they are trained in English, they're more comfortable reading Telugu. So not only will they use multilingual questions, they want to receive answers in Telugu with numbers as well as all technical terms, medical jargon in Telugu. So that's the next step for us. The other thing we learned was that they don't want long answers. They don't want human-like responses. They want crisp bullet point answers. So for us, in the coming weeks, or rather in the coming months, our focus is to, one, work on multilingual answers, two, work on crisper answers, bullet point answers, and three, highlight the most important information first. So if you saw the demo, there were places where I highlighted refer to medical officer immediately. So ideally, the chatbot should surface that information first before going into the other information about the condition. So we are now testing the responses with a batch of human experts. And next month, we are going to take this to the field and test it with ANMs. ArtPark is our AI partner for this project, and I'll be here happy to answer any questions any of you may have. Thank you.
So Silicon Valley needs to start taking notice of the advanced technologies that are being used for our community health workers. It's not just something that's happening out there in the universe. It's something that we can use and study here as well. And to build off this demo, we have a video conference now with our next presenter, who's coming from Microsoft Research. I'm pleased to introduce Mohit Jain, who's principal researcher at Microsoft Research India to show us a demo of LLMs once again, as well as tell us a little about work on detecting anemia using the smartphone.
सिस्टर, ये एक आशा बोट है। आपके मन में अगर कोई क्वेश्चन आता है जो आप फील्ड लेवल पे जानना चाहती हैं, तो वो आप तो ये एक चैटबॉट हमने डेवलप की है जिसमें आशा फील्ड लेवल पे अगर उसकी कोई क्वायरी है वो उससे पूछ सकती है और वो किस तरह से काम करती है वो आई विल शो यू। अरुल, कैन यू present it? Yeah. So, हाँ, तो जैसा मैंने बताया, आशा वर्कर इस बोर्ड को यूज़ करेंगी और अगर उनके दिमाग में कोई सवाल आता है, वो कुछ जानना चाह रही हैं, कुछ जानकारी लेना चाह रही हैं जो उनको नहीं पता, तो वो इसके थ्रू ले सकती हैं। मैं अभी एक एग्जांपल के तौर पे दिखाता हूँ। जैसे अगर आपके मन में कोई सवाल आता है जो आप पूछना चाहती हैं, तो यहाँ आप सिर्फ रिकॉर्ड करना है और आप वो पूछ सकती हैं। एक मिनट। हाँ, बोलिए।
अगर किसी महिला का हीमोग्लोबिन 4 ग्राम से कम होता है तो हमें क्या करना चाहिए?
तो ये सवाल इन्होंने पूछा है, ये कुछ सेकंड लेता है इसके रिप्लाई में, और जो उसका आंसर आता है वो मैं आपको दिखाता हूँ अभी। कुछ टाइम लगता है इसको आंसर करने में। So answer is here. Yeah, wait a minute.
यदि किसी महिला का हीमोग्लोबिन 4 से कम है तो यह गंभीर एनीमिया का संकेत देता है। आपको गंभीर एनीमिया वाली महिलाओं को आगे के उपचार के लिए तुरंत निकटतम PHC/CHC/DH में भेजना चाहिए। ऐसी महिलाओं को इंजेक्शन या रक्त आधान की आवश्यकता हो सकती है।
और अगर कोई क्वेश्चन पूछना चाहती हैं, इसको यहाँ हो।
अगर किसी जन्मते बच्चे का वजन 2.5 किलो से कम हो तो फिर क्या करना चाहिए?
So while we're waiting for this, I'll just explain what's happening in the background. There is a database of all the ASHA's PDFs, their training guides. They have 6 chapters that they have to learn from. That data has been, all the text has been taken. It has been put into this, what they call a vector store. And then, you know, you may have used ChatGPT. ChatGPT is then looking through that database only in order to give its answer. It's then feeding that answer back through WhatsApp and with a speech-to-text API so that we can now get the answer that you want to play with.
यदि जन्म के समय बच्चे का वजन 2.5 किलोग्राम से कम होता है तो उसे कम वजन माना जाता है। यदि वजन 2.5 किलोग्राम से कम लेकिन 1.8 किलोग्राम से ऊपर है तो बच्चा हल्के से कम वजन का है और उसे अतिरिक्त देखभाल के साथ घर पर प्रबंधित किया जा सकता है। यदि वजन 1.8 किलोग्राम से कम है तो बच्चा बहुत छोटा है और उसे स्वास्थ्य केंद्र में भेजा जाना चाहिए। इन शिशुओं के लिए अतिरिक्त देखभाल में अतिरिक्त गर्मी प्रदान करना, यह सुनिश्चित करना कि बच्चे को पतली चादरों और कंबल के साथ अच्छी तरह से लपेटा गया है, गर्मी के नुकसान को रोकने के लिए सिर को कवर करना और बच्चे को मां के पेट और छाती के बहुत करीब रखना शामिल है।
This is all. ASHA can use this. Thank you.
So this was done with the help of Mohit's team, to be honest. They've been working on this, I think, for a couple of months. We helped more with getting the content put together, but credit is where it's due, is really Mohit's team. So, Mohit, I don't know if you can hear us, but everyone was quite impressed by the WhatsApp, ChatGPT, ASHA bot demo. So. Just make sure that you're unmuted. One second, we're just fixing the audio. So as you know, a lot of tech problems, as you've clearly seen. We're trying to get through it again, but thank you for your patience. Technology is not perfect. It takes time. It takes us, we have to laugh together when we make mistakes. Okay, how about now? So while we're trying to get the audio fixed, any questions regarding this? Of course, this is not something that is prime time. It's not something that's on the field right now. It's very early testing. Like Amrita was mentioning, it requires guardrails. It requires close quality control to make sure that the types of responses are coming from the actual content that ASHAs are trained on, that A&Ms are trained on, their actual curriculum, not on Google search, not on something else on the internet that can provide erroneous answers. Should I try just calling him and putting him on the mic? Let's try that. Mohit, I'm going to try calling you on WhatsApp and then put you on the mic.
Hey, Ruchit.
Can you unmute yourself on the Zoom call? Do you want to mute it or unmute it? On what? WhatsApp or Zoom? Can you try speaking on your phone? I have you on the...
Okay, can you hear me here?
Yeah, great. Okay, we figured it out. Sorry. It's okay. This is Jugad. So I was saying that...
Thanks a lot for the demo.
Everybody was quite happy with the ASHA bot demo. If you wanted to tell us a little bit about what went into making it, and then we can also talk a little bit about the smartphone anemia piece.
Yeah, sure, I can do that. Okay. This is strange because if I'm getting my own echo.
I'm sorry.
In my other ear. Yeah, so I'll try to speak through it, but yeah, it will be tricky. Okay, I can't. Okay, so what I was saying is, so thanks a lot for the demo. And so what went in it, I think there are a few key components in creating that ASHA bot. I think, so I would just quickly go through those components. Ruchit, would it be possible for you to switch on the slides?
Yeah, 1 second. Slides.
Yeah, that would be great.
Yeah, so we have your, you want to go 1 slide back?
Maybe 2 slides forward actually, because ASHA bot came first now. So maybe like, yeah, next slide. Yeah, after this.
Okay, here. There you go.
There you go. Perfect. So I think some part of the slide is getting chopped off, but I think, yeah, you'll understand. Yeah, so I think the key problem that we are trying to solve is access to information. And as we all know, access to timely, trustworthy, detailed, and accurate information is very crucial. And in the demo that you just saw, and these are the key features that we tried to establish. One was that like all the answers were coming from the knowledge base that was trained on ASHA manual. So this is the government provided ASHA manual, and we restricted GPT-4 in giving answers only from this knowledge base. If you ask any other question like how is the weather in Bangalore, or can I eat, or where is the best place to get biryani, it will just say that I don't know. Okay. So that's one of the key features. Apart from that, we support like 5 different languages. So right now you saw the demo in Hindi, but it also very well works with Tamil, Telugu, and Kannada, along with English. And it also supports both the modalities. You can type your question in text as well as in speech, as you just saw in the demo. Apart from that, it also provides citation. So any answer from where it is extracting that answer, like from which chapter of which paragraph of which ASHA text manual, it can give you that in detail. So that helps you to go back and see that like, from where it is getting the answer. And if you need to fix the knowledge base, because many a time the knowledge base might be out of date. So you can also do that. And then we can just run, and once you update the knowledge base, the system automatically works. Okay. And apart from these things, the system also supports small talk. So not only conversation that you're having of asking question answer, but you can also do like simple things like, how is your day, and how are you feeling? So all those things it can also perform well. On the right hand side, you can see a demo or like a screenshot of the ASHA bot, where the question is how many times do I need to take a newborn for checkup? It gives the right answer. One other interesting thing that we've added here is something called as related question. So you can see that if you click the related question, it's not shown in the slide here. It gives you like 3 questions as related to this question. So one of the questions was actually, what does this LBW stand for? And I just clicked that as a question and just gave me the right answer. That LBW stands for low weight baby, low birth weight baby. Okay. So I think these are the key features, and yeah, we'll keep on developing it and probably deploy it soon in the field. Okay. Yeah. Now, Ruchit, you can go 2 slides back. 1 more slide back. Okay, perfect. So I think as a lot of you are doctors and practice medicine, and you know that like in India and in many of the low resource countries, you can easily figure out whether the person is anemic or not by just looking at this eye region, which is the conjunctival and the palpebral region. So you can see that like in this image, the left eye is actually a normal eye, while the right eye is an anemic eye, because the redness of the palpebral region is very evident. Go to the next slide. So in this work, the work that we are calling as Mahila. So Khushi Baby, along with Microsoft Research, what we are trying to do, we are trying to develop and evaluate machine learning models, like state-of-the-art machine learning model, to accurately classify moderate maternal anemia cases, which has a hemoglobin level of 7 to 10. And not only that, we are trying to accurately estimate the hemoglobin level from the smartphone captured images. And in this, the way we are capturing this images is in a very interesting way. So we are capturing like 3 different things in the images. One is the eye that you can see here. The another is the fingernail that is also visible in the image, because that's the fingernail we are using to pull the eyelid down. And the third is actually even the tongue image that is not visible here. Apart from that, we are also keeping a white paper there to check for color calibration. So the few novelties. So this, you must have heard about like many prior projects which have tried to do this anemia detection or anemia classification or hemoglobin level estimation from eye image. But there are a few novelty in this work. I think the 4 key facts that we want to mention here is that like it works we are trying to make it work in unconstrained setting. So the smartphone does not have any kind of attachment. There is no control of lighting in the environment that you're capturing the image. Okay. The second part is that we are trying to make it work for moderate anemic cases, particularly in women, which is one of the hardest cases because we are trying to find cases between 7 to 10 hemoglobin range. Okay. The third is that like we are trying to capture multiple region of interest. Not only Ruchit, can you click one more time? So not only like just from the eye, fingernail, and the tongue, even inside the eye, we are actually trying out like 3 different regions, like the scleral region, the palpebral region, and the pharyngeal region, because each of them contains different amount of information. Lastly, we are building this largest India-specific data set for anemia detection using eye, tongue, and fingernail image. Yeah, that's it. Thanks a lot.
Thank you, Mohit. Thanks for working with us. And we can all give him a round of applause. It's good work. Thank you. So yeah, I mean, really this is going to be a tool for the ASHA worker, for the A&M worker. Instead of pricking somebody's finger at that maternal and child health camp, putting the blood on a piece of paper, looking at what color of red is it 6 or is it 8? You can use the phone, take a photo of the eye, fingernail, and tongue, and using that offline AI, you can understand, is this person moderately anemic or not? And should they be referred to get iron transfusion and increased iron supplementation right there on the spot? So that's an incredibly powerful tool that can improve upon the current standard of practice that we need to research and we need to build out together. So we'll move on to our next presentation along with this, the same theme of maternal and child health that we are on right now. If we can get the next slide. Sorry. And it's my distinct pleasure to invite all the way from Seattle, Ruela Mendonca, AI product lead from Autoré. Autoré is doing some amazing work on rapid diagnostic tests, another way to turn the smartphone into a super tool for these community health workers.
Hi everyone, I'm Ruela Mendonca. I'm the AI product lead at Autoré. Autoré is a digital health nonprofit with a mission to use AI to provide access to equitable care to those who need it the most. I'm here today to talk to you about Health Pulse AI. Health Pulse AI is a set of digital building blocks for the health ecosystem. These building blocks include, firstly, quality digital instructions to ensure that tests are administered correctly. But the big part of Health Pulse AI is to provide AI results for any diagnostic tests. It's designed for any condition and requires only a commodity smartphone, something that's common in more rural areas. The goal is to provide accurate, cost-effective insights with a high accuracy and robustness to different field conditions. This allows it to be used in self, community, and healthcare settings. So what is Health Pulse AI? There are 3 main components of it. The first is real-time image quality assessment to ensure that an image captured on just a low-end smartphone is of good enough quality to interpret. And with just that image, Health Pulse AI can provide an identification of what test it is. It can then provide an interpretation of what the test result is, and also detect anomalies, such as if a test has been misadministered. This, Ms. Jyoti this morning, Jyoti ji, actually mentioned that one of the big problems is being able to run AI and run all of these apps for an A&M. The main goal of how Health Pulse AI is built is that it's made available through a mobile SDK or a web service API, which means that this can integrate into any existing application versus having to install yet another app on the phone. It has multiple different use cases. It could be used for supportive supervision. It could be used for quality assurance, for training scenarios where A&Ms and ASHA workers could be trained. It could be used for public health surveillance and in telehealth scenarios where remote medication may need to be administered. In partnership with Khushi Baby, we are planning to actually include Health Pulse AI into the Khushi Baby application. The first phase of this partnership would be to integrate the Health Pulse AI SDK into the Khushi Baby application for the interpretation of tests for malaria, for HIV, for hepatitis B, and for VDRL, so venereal diseases like syphilis. And in the second phase, we would like to expand this integration to include the interpretation of urine dipstick tests. These tests are incredibly hard to interpret because they're supposed to be compared against a scale, and it varies per urine dipstick test. I'm going to walk you now through a day in the life of Prachi. Prachi is a pregnant woman who's 6 months pregnant and attends a maternal camp in Rajasthan. Over here, she meets with her A&M and needs to connect a urine sample so that a urine dipstick test can be administered by the A&M. All the A&M needs to do now is, once the test is administered, open her phone, open the Khushi Baby app, and take a picture of the urine dipstick test along with the scale. Instantly, she's provided with results on key indicators such as leukocytes, nitrites, glucose levels, and albumin levels, which are key indicators for maternal health. And just with this particular indicator, she can choose to either modify the result because she sees something different or continue on. In this case, she sees that Prachi's glucose levels are higher than expected, and so she recommends that Prachi change her diet and refers her to additional testing so that she can get the right care that's needed. And as was presented earlier today, all of this information would be integrated into the Khushi Baby systems so that any place where an A&M decided to do something different from what the AI actually said could be looked at more closely, and the right interventions and resourcing can actually be put into place.
This is going to be a game changer. I mean, you think about it, urine testing is so important for maternal health. It tells you, is the mother diabetic? It tells you if the mother is going to have preeclampsia, a urinary tract infection, things that affect both the mother's health as well as the health of the future child. And it's already so cumbersome to do the urine dipstick, compare it against 10 different color schemes. Now imagine if you can do that and you can get a result within a minute offline. It's a huge aid to these A&Ms. And with the Autoray platform, they've already done this with a lot of rapid diagnostic tests, HIV, malaria. Now you're bringing it to urine testing as well. It's a big promise, and we're very excited to be working with you in partnership and in collaboration. I'd next like to invite two more researchers to the stage. We have Dr. Makarand Tapasvi and Dr. Sneha Nikam from Vadwani AI to continue along with our theme of maternal and child health to tell us a little bit about their work on newborn anthropometry. Please join me in warmly welcoming them to the stage.
Good afternoon to all the audience. We are really pleased, and thank you so much, Ruchit, for giving us this dais to share one of our AI solutions, which is a newborn anthropometry solution. Before I deep dive into the solution, I'd just like to give a brief about our organization. So as my colleague earlier mentioned to you, Vadwani AI is a not-for-profit organization working for creating AI tools, especially for the government of India, so that we can have some sustainable pathways for deployment. Me and my colleague Makarand, both of us are working in the maternal and the child health division. So here today we are going to actually share with you one of our AI solutions, which is called as the newborn anthropometry solution. So newborn anthropometry. So why newborn? Because the age group that we are catering to through this AI solution is 0 to 42 days. And anthropometry because the AI solution predicts certain anthropometric parameters for the children in this age group. So when I say anthropometric parameters, I mean the basic parameters for the child, like the height of the child, that is called as length in this age group, the weight, the head and the chest circumference, and the MUAC. All of these indicators are very important in terms of measuring the growth development of the child, right? So before I talk much into the solution, first I'd like to give you a demo as to how the solution works, and then we can talk a little bit more on it. So when this AI tool is being used, the first thing that you need to do is prep the baby for capturing a video of the baby. So over here, necessarily, we are taking the unclothed videos of the baby. It's a small 10 to 15 seconds video, which can be taken on any basic smartphone being used by the ASHA workers or the ANMs. Then this is how the video is being captured by the frontline worker. It's an aerial view from left to top, top to right, and then you come back. So basically 120-degree arc view of the child is captured. The video is then used in the backend by the AI model to come up with the predictions regarding the anthropometric measurements. So over here we also had a video of the child being weighed on a digital weighing scale just for us to understand what is the accuracy of the model. So basically, if you try to understand कि इसको use कैसे करना है, how this AI tool is to be used, it's very simple. This AI tool can be provided in any of the mobile applications that the ASHAs or the ANMs are already using in. It can be given as a plugin in the Anmol platform, or it can be given as a plugin in any of the web platform that the ASHA workers are using. The ASHA worker will then have to take a video of the baby, an unclothed baby, in a 120-degree arc from the top angle, left to top, top to right. Once that video gets uploaded, then the AI tool will give the prediction regarding the measurements of the child. And this AI tool is available both in the online as well as offline mode. To talk about the performance of our current model, I'd like to invite my colleague, Dr. Makran, on stage.
Thank you. So yeah, we're using basically some video processing technology, right? Convolutional neural networks that are very good at looking at images and trying to predict information, anthropometric measurements of the baby, essentially using the wooden ruler that you saw below the baby as a reference object. See, if you take a video of an object from a faraway distance, it'll look small, right? If you bring the phone near, it'll look big, but the weight is not changing. So the ruler helps us kind of guide and provide the model a sense of how far away the camera is from the baby. Now coming to the numbers, we have about a mean absolute error, regression problem, therefore mean absolute error of around 120 grams on average. And we did a little study with PGI MER in Chandigarh to figure out what are the current errors that we see typically in the field. And this turned out to be around 180 grams. So we are seeing that the AI model is not only more convenient because you now have 4 measurements in one video, one small video, done on the phone. It's also more accurate potentially, right? And so, and of course, being a digital first technology, you're able to connect it with through platforms and have this information of what the weight is communicated to the medical officers faster than probably it would take to go by paper, the current route. Thank you.
Right, and the biggest benefit of having such AI solutions in place will be the growth tracking mechanism that comes along with it. So along with the automation of the data regarding the anthropometric measurements, eventually this platform can also be utilized for capturing the parameters of a child on a longitudinal basis, because specifically this tool is designed for 0 to 42 days, which is the HbA1c age group. So the problem statement that was identified was the challenge the ASHA workers face to carry these heavy weighing scales and infantometers to the field, right? Like for example, we had Ruchit show us one video where the ASHA workers are providing services in the hard-to-reach terrain. So in those areas, it would be tough to carry these weighing machines. So that could be replaced by an AI tool which gives you predictions, not only gives you the AI anthropometric measurements, but also helps you in getting the growth of the child on a growth chart and thereby understand the predictions regarding the growth faltering of the baby eventually. So that's where we think the future of the AI solution is. And just to give you a brief about the next steps, we are discussing with a few states regarding the deployment of this AI solution, and we'll be happy to share further insights as we get there. Thank you so much.
Thank you, Dr. Sneha and Dr. Makran, for, again, this is going to be a big deal. The ASHA does not need to carry a weighing machine to a far-flung house in order to know that this child is now not gaining weight at the appropriate speed. That is a big deal if she can do it on her phone in an offline setting. If this type of AI algorithm can be incorporated into an application like CHIP, which is already being used by the ASHA workers for her daily visits, it can be a very, very powerful tool. So we are extremely excited to be collaborating with Vadwani AI, recently signed an MOU. This is one of our other focus areas of collaboration, which is looking to validate their newborn anthropometry model, which is very accurate. 180 grams is quite remarkable in the Rajasthan context, and also work with the government and with the regulators to see how this can start to be used eventually for guidance, medical guidance for the ASHA and A&M workers on the ground. So due to the fact that we're running a little bit late, and sorry for that, we'll need to actually move to our final session. After that, we still have a presentation post that final session, but we do have some of our panelists who have to leave. So I'm going to invite our co-hosts of the fifth panel. We have Pranav Savanur and Shweta Shah to come and join us on the stage to introduce our panelists.
Hello.
Hello, hello.
Hello. Hello.
Hi, good afternoon, everyone. We are reaching almost the end of our summit. Hope you all are doing well. Firstly, I'd like to introduce myself. I'm Shweta. I work as a development officer at KB, and I'm one of the co-hosts for this panel. Pranav, would you like to introduce yourself?
Thank you, Shweta. I'm Pranav. I'm the Strategic Partnerships Manager with Khushi Baby. And we're going to introduce our panel and then dive into funding innovations for emerging global health challenges.
Yeah, thank you for joining us. And I would now like to introduce our panel. All of our panelists are very accomplished individuals, and we had to narrow down their bios significantly to stay in the time slot. Firstly, we have Neeraj Jain, Country Director, India for PATH. Apart from leading country operations and coordinating stakeholder engagement in India, Neeraj also leads the South Asia region at PATH, which comprises of India, Myanmar, Bangladesh, Nepal, and Sri Lanka. Neeraj has over 30 years of extensive leadership experience in strengthening organizations. His strengths lie in business development, setting up new ventures, organizational development, ecosystem development, and a lot more. With his leadership, PATH South Asia Hub has tripled its annual portfolio, quadrupled its headcount, and expanded its presence into 4 new countries and 23 Indian states.
Second, we have Archis Gupta, the investment manager at LGT Venture Philanthropy. Archis brings in over 14 years of experience in the development finance space across impact investing, blended finance, and venture philanthropy. He's currently working as the investment manager at LGT, which provides funds to nonprofits from sectors such as the environment, healthcare, and education in India. He has been associated with organizations such as National Skill Development Corporation, IP Global, ICICI Bank, and Barclays Capital. He has been instrumental in creating innovative finance mechanisms for over $300 million for the Samrit Healthcare Blended Finance Facility backed by USAID, and also has been actively involved in designing blended finance mechanisms for organizations working at the intersection of climate and gender in his previous roles. And finally, we have Dr. Raj Shankar Ghosh, the Senior Advisor at the Public Health Foundation of India. Dr. Ghosh is a physician with 3 decades of experience in policy planning and delivery of public health programs. His primary interests are in climate health, primary healthcare, infectious diseases, and vaccine delivery. Dr. Ghosh is a founding member of the Quality, Equity, and Inclusiveness Initiative at the Department of Management Studies, IIT Delhi. Dr. Ghosh has worked in West Bengal State Health Services as a medical officer and as a regional coordinator in the National Polio Surveillance Project. As Shweta said, this is a narrowed down version of their bio, so we're very excited to start this panel discussion. So let me start off with Dr. Ghosh over here. Given that you've worked in all levels of leadership in global health, and today we're joined here during Universal Health Coverage Day, my first question to you is, what strategic areas of investments do you believe are crucial to achieve universal healthcare?
So there are basically, very clear areas that have been identified as emerging areas where there is a global threat as far as human life and health is concerned. For example, the antimicrobial resistance, the issues around climate-related health issues, the issues around the emerging diseases, which are the tuberculosis is re-emerging in various parts of India's, various parts of the world. Various vaccine-preventable diseases are re-emerging. But most importantly, we are also kind of apprehending that there'll be a future pandemic. But given all of this, there is a definite area where an investment needs to be made, which is the health systems. We have seen that without having a strong and robust health systems, when we face a crisis, then we generally have a huge problem. For example, in the health systems, if we look at the three aspects of the supply, the access and inclusion, and the third is around building the demand within the community by bringing the community at the center of public health. I think that is very, very important. Throughout, half the day I've been hearing about how the community has been brought into the center of the work that Khushi Baby is doing. And that is exactly, where we really need to bring in order for our public health systems to move forward.
Thank you.
Yeah, thank you, Dr. Ghosh. Our next question is for Neeraj. PATH is known for recognizing and scaling innovations. How do you move from innovation to scale, and can you provide examples of successful transitions?
Thanks a lot. Mic working? Hi. Firstly, I want to thank you for inviting me. As you know, Khushi Baby is an organization very, very close to my heart. And thank you for doing it in Delhi this year. I remember last year I couldn't make it to Udaipur. So it's really nice to be in person and talking to all of you. It's very interesting because as I unfortunately couldn't be in the morning, but as I was looking at some of the innovations and what's happening, there is a process to scale, right? There's a process of first identifying, is the academic side of it, coming up with an idea, really building it out, testing it. I think where we get stuck many a times is on the clinical validation piece. And I think I was looking at some of the solutions, and I know that they've been at it for a few years, trying to just get the clinical side of it out of the way. Once you have that, and once you have that validated, then there is the policy side of it. Is this going to make it to the policy? There are current, in the health systems, there are algorithms which need to be possibly tweaked, changed. There are procurement policies that need to be completely sort of turned on their head because you're suddenly looking at something which doesn't exist in the line items. So, how do you do that? And for that, of course, impact studies are required, and that's an important part. I think, we did some, I'm sure everybody knows of Cure.ai, for example, now, right? 2016, we did studies in Nagpur on Cure.ai, and they were operational trials. It had already been validated clinically, but for them to actually scale up, they needed those operational trials. So you would then go into that, look at the algorithms and if they need to be changed in the health system. And I'm sorry, I should have started with this that, for PATH, it's mostly around public health because PATH works on health equity. So it's really, the bottom of the pyramid in that sense. Once those operational trials are done, then then it's about hand-holding the whole scale-up process. And here we're talking about one solution at a time. So what I really like about what Khushi Baby is doing actually is trying to bring multiple solutions together. You're kind of becoming like the aggregator, which is brilliant because I think many innovators, don't have access, don't have the understanding of how this could be scaled up. But when we're looking at PATH, in fact, we've been doing one solution at a time in the last so many years. But more and more as we're moving into digital solutions, I think it's the comprehensive methodology that's going to work. Kiran is sitting right here, and we've had a lot of conversations around how do we stitch together the primary healthcare in terms of digital. And I know Kiran is experimenting, as are we. We don't have you found a solution, Kiran? Okay, he says he hasn't found one yet. I can tell you we haven't either, so we're all in the same boat. But yeah, I think it's a trial. You keep thinking about, we keep talking about interoperability. Hey, try doing it, man. It's not easy. You know, I was just listening to Microsoft research, and this whole thing of anemia through the eye and the tongue, etc. It's a long process. You know, you got to do it in the lab, then you got to take it and do some clinical validation. You got to validate at scale, and then possibly it'll start. It's a great solution. If they are able to crack it, you know, I'm going to be lining up for that. But it's a long process. I think what also the policy side of it, just quickly on the policy and regulatory side of it, that's also something we need to navigate. And the regulatory side in India especially has not been easy. It's been a tough journey. I mean, I can tell you that some of the trials, you know, people are actually going out and going into Nepal and Bangladesh and doing those trials just so that they don't need, you know, they don't get entangled by regulatory processes while doing their trials. So it's got to all come together. And I think being able to see that end to end, that start point till the end point, where you're actually scaling, I think is going to be critical. You know, and this would apply to digital solutions, this would apply, I mean, you know, Tanu is sitting in the room from Path, and, you know, we started a small pilot in Mumbai. What was it, a year ago, Tanu? And it was a very interesting one because NHS said, okay, the big guys will come on board and come onto the platform. The Apollos and all will twist their arms and they'll come. The public health system has no option but to come on board. How do we get the small private providers? That was their challenge, right? How do we get them to connect into ABDM? And we started a small program. We didn't know the answers. We just started sort of fooling around, and I think something cracked and it worked. And now it's known as the microsite program of India or something like that. So, you know, it just got scaled up. But, you know, that's one success story. There are many failures behind that. So I'll stay out of that one. Back to you.
Thank you, Neeraj. Thank you for your kind words for also the efforts that Khushi Baby is putting in to bring all of these people together to build an ecosystem where you have a preferential option for the public health sector too. So initially, Dr. Ghosh shared some of the challenges we're facing to achieve UHC, and Neeraj shared what needs to happen to scale these innovations to scale. But the most important factor over here is why we're all gathered here, is financing. So Archie, as a funder, how do you think about investing in these digital health solutions? Can you tell us a little bit more about LGT and what are some big bets that you're making?
Thank you, Khushi Baby, for having me here. I think I am the odd one out here, not the public health expert. So I have been a banker earlier, right? So and then transition to impact investing and now venture philanthropy. I have been like talking about returns my whole life, like not my whole life, like last 12, 13 years that I have spent. But here, after venturing into the venture philanthropy space, right, we do talk about returns, but these are social returns now. And we are always looking for impact unicorns, as we say. So unicorn is a very buzzword these days. So we are also looking for unicorns, but on the social side. At LGT, Venture Philanthropy, we have our roots from the private equity space, and we apply the similar lens while looking out for solutions which have the potential to scale and also sustainable at the same time. And like private equity, we also have an end game defined, like how we can reach to a particular stage, right? We have an end game defined for a solution that we invest in. So at LGT Venture Philanthropy, as far as healthcare strategy is concerned, we are invested primarily in the primary healthcare, as we believe primary healthcare is the gatekeeper. And if we were to, and we have to achieve the universal health coverage, it will go through primary healthcare route. At LGT, we primarily, like our investment thesis have been primarily built on the community health workers driven models. So the three enterprises that we have funded in India so far, the ARMMAN Foundation, Dr. Aparna Hegde was there today, Antra Foundation and Wish. So they have been built with the community health workers driven model. but we are currently in our journey to create the 5-year strategy. We are started to recognize that while the quality of healthcare services is important, but what more important is the health-seeking behavior of the communities and the individuals out there. So while community health workers will continue to be something we would like to focus for next 5 years, but how to improve the health-seeking behavior of the communities from the demand side is something we will look at. Apart from this, the system enablers like technology, health financing are some of the key areas that will be a part of. So our investment thesis at this point of time will be more like integrated models, something what Khushi Baby is working in, right? So they are trying to become an aggregator. We have not seen these kind of initiatives so far in the non-profit space particularly. And it's actually quite great to see Khushi Baby working in that direction.
Thank you.
Yeah, thank you, Archie. Yeah, we could be the 4th organization, Archie.
As we say, Delhi dur hai. So, but yeah, we would like to have Khushi Baby in our pipeline, for sure.
Yeah, thank you. Now, throughout the day, we have learned that digital health is a revolutionary tool for how we conduct global health at the last mile, to collect high-quality data that can enable data-driven decision-making at a very hyper-localized level. My next question is directed to Neeraj and Dr. Ghosh. What do you envision as the future of impact assessment in global health, especially as we navigate through a patchwork of data of varying quality?
Thanks, Shweta. That's a long question.
Sorry about that.
But I think, I think just delving a little bit on digital health and, the impact that it could have, it's tremendous. I mean, we're sitting talking about universal health coverage. Universal health coverage is all about a strong primary healthcare system. A strong primary healthcare system is all about screening and diagnostic, right? And there is no way we're going to be able to do that in 1.4 billion people without data, digital, just using technology. So if I just sort of focus on what the next 10 years is all going to be about, it is about screening, population level screening for some diseases, cervical cancer being one, for example, could be breast cancer, could be anemia, so that's one side of it, and then good diagnostic. And all that data actually coming together from a surveillance perspective, because if that data, if you're doing all of this across the country, and I'm sorry, but I keep thinking about 1.4 billion people. It just sort of grounds us when we start thinking, okay, this is not about one village, one city, one area. So when you think of this large scale of operation, if you're able to diagnose and screen, and that data comes into a system and you're able to start stratifying, analyzing that data, and bring it together, the next pandemic, I think Raj said there will be a pandemic. Raj, I hate you, because I hope there is no other pandemic. But yes, the possibility exists. I think the only thing is that if we're able to find out quickly, if we're able to respond, react, things will be hopefully very different from what we've just gone through in the last few years. I think one more important piece is transparency. I think transparency comes from good data, good digital solutions, which is actually bringing all of that together. So it's got to be, it's going to be critical for us to be able to sift through all the stuff that we are seeing and saying, okay, here it is. I don't know if you know, but currently, interoperability is a big buzzword, because there are individuals who are sitting on the TB database of India, and the same individual is again sitting on an HIV database, could be also sitting on an RMNCH database. So you could have one individual actually sitting on multiple databases. Kiran, is that still true? Yeah, okay. See, I'm constantly wondering, because when I come off stage, he's going to catch me. So, that's got to change. You can't have the same person across multiple databases, because all these diseases are linked, medical conditions are linked, We don't have electronic health records which are getting created, the ABA IDs, etc. I think also in terms of just being able to monitor real time and evaluate real time is going to be critical. Not just for the next pandemic, but even for things like malaria and dengue, and that's where the whole climate conversation comes in. With climate change, we're seeing, I was at COP last week on Health Day, and everybody is talking about malaria and dengue all of a sudden. I thought that was a poor people problem, but everybody in Dubai was talking about malaria and dengue because that's what's coming up everywhere. So, to me, digital health is not a revolutionary tool, it is a must-have. We cannot shift low and middle income countries without that. But I really hope, and this goes to Khushi Baby and the team here, to bring a lot of these solutions together to have a comprehensive primary healthcare solution. Think about everything. Think about the eyes, the ears. Think about the patient journey when the patient walks in and how the journey is. And also when they come back to the primary health center, because that's going to be critical.
Thank you. Dr. Raj, would you like to add?
Sure. I think Neeraj has covered all the points. But what I'll do is I'll a little bit personalize this answer so that I can give the right context to you. So I started my career about 35 years back in the deserts of Rajasthan in Churu with a small NGO, and moved on to West Bengal Health Services at a primary healthcare center. One of the biggest challenges that we used to have is understanding the supply chain of vaccines and various other goods that used to come. We never knew when the vaccine would come. We could never plan our sessions properly. And one of the things that all of us know is that in case of primary healthcare delivery, we generally call it a SAD affair. The SAD meaning supply, access, and demand. So in terms of supply, we were hugely handicapped. And look at today, with the electronic vaccine intelligence network, even at the remotest kind of cold chain point in India, they have a very clear understanding of the stock. The supplier, the persons who are accountable for delivering the vaccine, have a very clear idea about where there is sufficient vaccine, where there is a surplus vaccine, where there is deficient vaccine, and they can distribute it so well. And all of this because of the digital power. The second is access. Today I was seeing this graph of the map about the zero dose. In our days, we used to literally go house to understand. And even during the polio days, we used to go house to understand as to where they are hiding the babies, who have missed, where have we not been able to reach. And today, 2 months back, I was in a very remote corner of India in Udaipur District in Maharashtra, in a tribal village almost 40 kilometers away from the primary health center in a deep forest. And the health worker there had a tab. And she knew exactly at every household what services had been provided, what services had been accepted, what services had been denied. And this was the power of digital power. She could show me on a map of the village every household and tell me which of the households were resistant to vaccines, there were 2, and which of the households they could not supply the vaccine because the child was not there, and which had accepted the vaccine. And in terms of demand, I think, we have seen the power of CoWIN, the kind of empowerment that we have been able to do for the population to make a decision about where to get the vaccine, when to get the vaccine, which vaccine to take. This has been game-changing. And based on, the CoWIN's experience, all of you know probably, the Government of India is now introducing UWIN for the universal immunization program. With UWIN, just decide any mother with a child staying anywhere in India can plan her vaccination according to her choice. With this empowered community being at the center, all of this is because of the digital power that we are bringing into health. So across supply, access, and demand, digital solutions have been successful, have become very acceptable both to the program managers and to the community, and most importantly are economic. We can have multiple evidences today to show how digital power and digital tool into the health sector is bringing down the overall economic burden that the state has to face because of infectious diseases and other non-communicable diseases too.
Thank you, Dr. Ghosh. Again, moving on to the last section of our panel, focusing on what we called here the grim topics in global health, climate change and pandemics. The World Health Organization has designated climate change as the single biggest threat to humanity. Since moving to Mars is not an option, more than $1 billion was committed to fund work at the intersection of climate and health at COP28. Yet, the majority of the health community is relatively new to integrating climate considerations to their work, and we're yet to have a strong evidence base of what works and what doesn't. Climate change is also intensifying zoonotic disease emergence while the world is still recovering from COVID-19 in many parts. Global leaders have launched the Pandemic Fund with the goal to reach $10 billion a year. They're nowhere close. They're negotiating a new pandemic accord. They're nowhere close. Yet, we're not fully prepared to mitigate or adapt to both these twin crises of climate and pandemic emergence. So my next question is to all the panelists here is, what are some funding challenges that we face as a health sector? Since funding challenges are always a constraint, what innovative financing mechanisms or models can we adopt to address these emerging challenges that add additional burden to the challenges we already face as a sector together? Let's start with Archiesh.
Yeah, very good question. And in fact, you're right. People, like most of the funders are committing towards climate, right? But when it comes to say climate and health intersection, there is lack of evidence which is out there, right? And the funders are still like trying to understand what's the linkage, how it can be mitigated, right? So at LGT Venture Philanthropy, we have been funding both environment and health, but have not looked at the nexus of climate and health. And this is also one of our agenda for next 5 years. We want to understand what would be the impact of climate change on health by funding some of the solutions which are trying to identify that linkage and how that could be mitigated or adapted over a period of time. Now, coming to your question of innovative financing structures, so I got the chance to work on a blended finance facility in my last role at Samrit Healthcare Blended Finance Facility. This facility was created during COVID times to basically build the capacity of the local organizations, how they can prepare better in light of future waves. So some of the innovative financing approaches that I can think of is, I'm not sure if Gavi is there, but Gavi conceptualized this instrument called as advanced market commitments, which incentivizes the implementers or the service providers to have capacity in place, right? So for example, they did it for vaccines. Similar thing can be done for future pandemics. We all know that, like Dr. Ghosh mentioned, there will be a pandemic, right? So, but we have to prepare in advance this time. So instruments like advanced market commitments, the vaccines or the medicines which are required, right, can be manufactured well in time. The other instruments like impact bonds, which pay for outcomes. So many of the funders want to see impact on ground and then pay for it. But there are funders who are open to take that particular risk and provide upfront capital to such implementing organizations. So I can think of some of these instruments, but when it comes to say climate and health, I think we have to see the specific solution and accordingly create an instrument around it or innovative financing around it.
Rich?
Yeah, it's an interesting question, and coming out of COP and being there on the health day, it was an interesting conversation. I must say that for me, till a few months ago, it was like we are forcing this conversation because climate has all the money. So how do we get some of that climate money into health? That was probably, in my head, the starting point. But having really delved deep into this conversation, there is a strong link. And thanks to COVID, that link is also accepted by people who are bringing in the money. The whole idea of health equity, which, organizations like PATH work on health equity. That's what we do. We've been doing it for many decades now. But COVID actually brought that right up front because, we were all vulnerable. It didn't matter where you lived. In fact, my theory is that the rich got sicker than the poor. I don't know if some of you would agree with that. But you found a lot of people living in, expensive societies, big cities, were the ones who were more sort of affected by COVID than probably the poor, or we didn't have good data. So it could be either of the two. The challenge with this whole conversation is that there is a certain amount of do good that has to happen, the whole equity side of it. But there are also organizations who become very rich in a pandemic. A lot of the vaccine manufacturers actually had it really good for them. Anybody who cracked it had it good for them. Anybody who wasn't able to get their vaccine out of the door before the pandemic started subsiding is sitting with something which is a waste. But so it's got to be a combination. It's got to be a combination of grant funding, which is money which is not going to come back. It's got to be some money which is high risk capital, which is high risk, high return probably. It's got to be some which is equity. It's got to be some which is debt. It's got to be some which is public funded. Mechanisms like Gavi, like CEPI, these are public funded mechanisms, right? So these are all mechanisms where lots of organizations, countries are putting in money, and then they are used during crises or even to make sure that you're able to get health equity. So when I think about the climate threat and I think about zoonotic diseases, which you kind of mentioned in your opening, I think there's got to be a need for all of these people to come together. Now the challenge is the end goal is probably common, but the pathways are very, very different. There are some who are there to make money. So we should be okay with that. There are some who are saying, fine, I'm okay to just give this as a grant and forget about it. There are governments who have their own nationalist agenda probably. So you've got to deal with that. But for me, the beacon of hope is that the end goal, the end target is exactly the same. Everybody's trying to get to a certain goal which is common. I think we need somebody to sit there and say, okay, fine, let's bring all these people together. Let's collaborate. You bring in your equity, you bring in your debt, let's get some public money, let's get the NGOs to bring in grant from whoever is willing to fund it. And that's the only way it's going to happen. And it's got to come together to a certain goal. Otherwise, we'll all be constantly splintered. And, there's no way we can have high-level impact. I think impact measurement. So while you may say that climate and health, we don't have enough data, I don't know if you know, but in climate and health, the biggest conversation is on supply chains. Health supply chains. Are some of you aware of that? That's 60% of the problem of climate and health. So fairly simple, you can actually solve some of these things fairly simply. So there is enough data which is out there. More practitioners are needed who are going to actually run some of this stuff. Less conversation. I think there's a lot of noise. So, let's get down and do some real stuff, and I'm sure there is impact that's going to emerge. Thanks.
Thanks. I think both of you already covered most of the things. I just wanted to say that, because currently I'm focusing a lot on climate health, there are three aspects of climate health. We can't just keep it as a broad climate health and converse. One is about the disaster management due to climate issues. The second is about the day-to-day impact that we have because of climate. And the third issue is around some of the emerging challenges that we will have if we do not protect our climate and let it deteriorate as it is. So in terms of the disaster management, I think it is very straightforward that there needs to be an investment to predict, to protect, and to proceed in terms of when the disaster comes. How do we know when it comes, how do we manage it, and when it happens, after that, how do we take forward, like we did in case of COVID. So that's pretty straightforward. There's a huge amount of investment that needs to be made in order to see all these three Ps in action. In terms of the health, I think it will be a disaster if we continue to look at climate health as a vertical. Climate health will have to be considered as part of the One Health system that we have already agreed to work on. The whole globe has agreed to work on One Health. And climate becomes an integral part of the One Health dialogue that we are going to have. There is nothing that will happen in One Health if we exclude the impact of climate that is there on the health, both the mental, the physical, and the social well-being of human life. And the third thing that we must consider is that there are huge risks of diseases, both communicable and non-communicable, for the future if we do not control climate. So there are people who will be involved in addressing the climate issues, but we must invest in order to understand the scale, the magnitude, the type of disease that we might expect, and that calls for research. That calls for surveillance. So basically at our end, what we are doing at this point of time is we are following a strategy that we are calling the REACT strategy, that an action is happening in the climate, which we are not being able to prevent, so we are reacting. What do we do by REACT? The R stands for research, the E stands for education, education at every level, community level, at the service provider level. A stands for advocacy, advocacy with various kinds of stakeholders. The C stands for capacity building. We are kind of training the health workers, we are training physicians in the private and the public sector to ensure that the facilities that they are working in, they make it climate friendly. And you all are aware that one of the major issues today is e-waste management. And e-waste management needs to be practiced at every facility. That's where the capacity building comes. And the last T is for technical assistance. So across research, education, advocacy, capacity building, and technical assistance in order to ensure that their facilities become green facilities. And this is a NCDC, the National Center for Disease Control program that we are working with. It is pan-India that it is being done. So it is very, very important, the solarization and all of that. So investments, when we talk about, I think there are three ways of investment or three avenues of investment. One is across the prediction, the protection, and the proceed of disasters that happen. The second is around the One Health and ensuring how climate fits into the One Health dialogue. And the third is about the REACT strategy that we talked about, that every clinical facility across the country must become climate resilient in order to serve the population better.
Thank you. So we had our panelists share their insights into how the health sector has a role in both the mitigation section and the adaptation section. And for the mitigation section, supply chain and zero carbon emission supply from vaccine facilities to the arms of people. But when it comes to the adaptation side of things, it's the primary healthcare infrastructure that comes to play. And what Khushi Baby is doing with our multidimensional poverty index and our climate partnerships with JPAL that was introduced today is really important on that front. And I'd also like to plug in that We've been lucky to be partnering with Gavi since 2016, who also helped validate our model through an RCT, but also help us catch up with 10,000 zero-dose children that Ruchit spoke about. Also, thanks to the panelists for talking about the role of impact and impact evaluation, using the same model that venture or the private sector uses and bringing it into the public sector and thinking about how impact investing and how impact-based investments can be understood. We also pulled back the curtains on how the global health sector can break silos and work collaboratively, because the issues that affect us also affects everyone globally now, instead of the us versus them mentality that is traditionally seen in global health. So I would like to pass it off to Shweta for the closing of our panel.
Yeah, thanks, Pranav. We realized that just like our bios, our questions were very long too, but we couldn't help it. There was a lot to learn here. Thank you, everyone. Thank you, Neeraj, Arjish, and Dr. Raj, for your insightful contributions to this discussion and giving such detailed answers to every question. I would like to further connect our big picture strategy and perspectives to centering the work happening on the ground. As we started our day today, discussing the role of empowering the world's largest community health workforce, I would like to end our last panel by mentioning that nothing we do is possible without centering the crucial roles our ASHAs, ANMs, Anganwadi workers, and CHOs play at the grassroots level. So if you could have a round of applause for all the community health workers.
I would like to invite upon Vijendra from Khushi Baby to distribute mementos to our panelists.
So I know everyone is eager to go home and face the Delhi traffic, right? But if you want to stick around, we actually have about 20, 25 minutes of more very interesting content that we'd like to share with you. So we'll just wait for the photographs. Okay, all right, let's. Yeah, we'll not right now. So like I said, we have about 20 to 25 minutes of final content that we want to share. And what I want to talk about now, at the end of the day, is how this all comes together, okay? How this all comes together in a vision of the primary health center, which is one of the major units of health across India. Over 150,000 primary health centers are there. We'll have two presentations, one which will talk about heart disease and how we can screen heart disease in these primary health centers. And then we'll turn it over to Kiran sir to tell us a little bit about what Government of Karnataka is doing in partnership and what the vision of the primary health center looks like for the future, which we've already got a glimpse of so far during the day. So we'll start off with the video from Dr. Rohan Khera, who is director of Yale Cardiology Data Science Lab, to tell us a little bit about how we can be screening for non-communicable disease, specifically heart disease, and how we can change the paradigm for these important diseases, this emerging burden of disease at the primary health center level. If we can get the video, please.
Hi everyone, I'm Rohan Khera. I'm a general cardiologist and data scientist at the Yale School of Medicine. At Yale, I direct the Cardiovascular Data Science, or CARDS lab. I'm also an associate editor for JAMA, for Artificial Intelligence and Digital Health. Today I want to talk about precision care with a low-cost AI and digital health-enabled solution for care in India. A bit about our Cardiovascular Data Science lab. We're a lab that focuses on data-driven future of cardiovascular care, using early disease diagnosis, using applications of AI, identifying appropriate treatment pathways for individuals, using novel inference from clinical trials and electronic health record data. And finally, we have built tools that use natural language processing and other large language model-based approaches for measuring care quality for patients. One thing I want to specifically talk about is how do we go from precision medicine and care in a setting where care is currently suboptimal. Specifically, I want to discuss the case of hypertension in India. The prevalence of hypertension in India is about 1 in 3 individuals. It is substantially high even for young people, with 1 in 5 young people below the age of 45 with hypertension. A majority of people of these group have known that they have high blood pressure or had at least a blood pressure measurement, but a very small minority are actually receiving therapies. And so our biggest goal right now is achieving blood pressure control. But then this misses the opportunity of actually managing what also bothers them more, is the cardiovascular risk. How do we address that risk specifically? Currently, we would address this risk based on risk scores, and then maybe think about potential therapeutic options that just target their global risk. If you were suspecting something specific, you would do advanced testing, like cardiac imaging to assess for underlying left ventricular hypertrophy or LV systolic dysfunction, and then treat only those people who have known conditions. The alternative instead is actually using something that's more novel, accessible, and available in any practice, and can actually build a scalable strategy for identifying high-risk people. The example on the right is an AliveCore device that measures a 1-lead ECG. And this talk is not supported or sponsored by AliveCore. I'm choosing as an example. And why did we focus on an ECG-driven strategy for evaluating CV risk? Because it's low cost. It is available globally as images of ECGs. And increasingly with these portable and wearable devices, we have 1-lead ECG access in the most remote settings possible. And then AI application now allows us to identify hidden signatures of disease directly from ECG images and signals, which previously required advanced cardiac imaging. So how do we think about this paradigm? Is our goal to enhance screening of our disease from ECG images and wearables? And we start with one example. We pose this question. We know that 5% of adults actually have decreased cardiac function. And untreated, there is an 8-fold increased risk of developing heart failure and mortality. And a lot of people with hypertension I mentioned actually have an overrepresentation of this phenotype. But the diagnosis often requires advanced cardiac imaging. So those who have heart failure only manifest, when they have clinical heart failure, and the early stages, stage B heart failure, is never picked up. We thought of a solution, and can we use the electrocardiogram that you see on the top right more effectively? And increasing, could we use our portable ECGs that can be captured on by any person in any setting for assessing the risk of LV dysfunction that we see on the left? So we did that by building one of the most comprehensive repositories of diverse patients with their electrocardiographic data paired with echocardiographic data for over 2 million patients. We built custom deep learning models and identified cardiac imaging signatures that can be extracted from ECG signal data and image data specifically. So currently, our tool is able to take any photo of an ECG and identify those with LV systolic dysfunction with a high discrimination above 90% consistently. And we have validated multiple hospitals across the US, but also in centers in Brazil, suggesting that it works across settings. We also built a similar solution that I'm going to talk about that works with wearable device-acquired ECGs. One of the key findings from all of our work is that it not only identifies those that have LV systolic dysfunction, but it identifies those who are at risk for developing it. So the goal with this kind of work is that we can now have a digital biomarker that is both diagnostic and predictive of future risk of LV systolic dysfunction, and therefore represent a very high risk for urgent intervention. And blood pressure management with specific therapies can specifically ameliorate that risk. And I'm going to get to that in a second. If you're interested in reading more about our work, they have been published in Nature Communications and Circulation this past year. That specifically builds on the foundation of the work that I mentioned and mentions the methods we deployed and the quality controls in place for developing and validating the tools. I want to switch gears and say we're going to work on wearable and portable ECGs instead because they really allow us to democratize access. We don't need the 12-lead ECG device to be capturing and putting leads on somebody's chest. These can be, in the Western Hemisphere or the resource rich parts of the country, can be done on a smartwatch. But for those areas where individuals cannot afford, which represents a large population across the developing world, a single lead ECG device like on the live code device on the right is able to capture one lead ECG in 30 seconds. But there is no way to identify, the CV risk factors that I mentioned before. And the other challenge that with all these ECGs that they do a very noisy ECG acquisition. So all you find in these ECGs are these wavy waveforms that as a clinician, even I have challenges interpreting clinical features, let alone the hidden signatures of LV dysfunction and other CV risk factors. So what we did instead, we built this special algorithm that now enables the incorporation of noise across frequencies like tremors, muscle twitching, electrode contact, electrical interference, merge that with ECG data acquired from clinical settings to generate this noise-enhanced ECG signal data that now replicates the ECG that we captured on a device like the AliveCore. And then we have built these noise-adapted deep learning models that can detect a vast variety of CV risk markers directly from a one-lead ECG. And these two were published in some of our Nature's Digital Medicine journal, as well as we've built a platform that can now be used to actually integrate information in a secure manner to actually run this at scale across any number of centers, any number of participants, securely without sharing any other information, and is remarkably important for not only developing these tools, but for deploying them for research and eventually clinical use. And so we built this CLARDS plus ECG platform. This is a purely academic, non-commercial platform where we can take input from any wearable device or any portable ECG device that runs through our algorithm and either can give the clinician in the practice an access to this information, or can actually be run directly on a central server where each individual can be randomized to different therapeutic strategies based on a blinded adjudication of the information that occurs on the one lead ECG. So I'm going to propose in the last minute this Action LV study. This is a collaboration with Khushi Baby, which is, as you all have heard about today, is a major force for change and led largely by the vision of Ruchit and his team. And the idea here is to leverage the technology we have built with a platform for data collection that Khushi Baby has assembled to conduct large studies of precision care that do not require advanced diagnostic modalities or does not require new ways of defining research strategies. So what we're proposing is across three states where Khushi Baby has any presence, we would conduct a cluster randomized trial with an AI ECG intervention arm and a control arm. And the intervention arm would involve undergoing a portable ECG and identifying those who have a risk for LV systolic dysfunction or other heart failure risk, and then optimizing their selection of therapies based on the fact that they have the stage B heart failure based on established clinical guidelines. So to summarize this is important because we are not suggesting things that would not be past our guidelines. We already suggest that choose ACE inhibitor or beta blocker more effectively in individuals who have LV systolic dysfunction because they constitute stage B heart failure. We just want to use AI ECG as a platform that defines this risk. And the control arm would undergo AI ECG with this portable device in the practice, but that information will not be shared and not be used in clinical decision making. This is a control for technology and for inference and how clinicians use and treat patients differently if they have information from an AI-based strategy. Our primary outcome is simple. It's based on idea of tracking all-cause mortality and any heart failure or CV-related hospitalization. The secondary outcomes specifically will focus on medications they were initiated on, whether they have specific MACE events, whether they underwent specific diagnostic testing, and can be planned according to the resources we have access to. And the trial intervention, specifically, we do AI ECG recording on a device, and we have a discussion with the company about donating devices for the study itself. We can get a 30-second ECG recording while they are waiting for their clinical visit or as soon as they get into the clinic. So we know in the busy clinical practice of India, where I have also delivered care, that this would actually work. And then this acquisition is tied to their record using a record number, which we can link back to their other sheets as well. And then we do a noise-resilient AI ECG inference directly for LVST diagnosis with a very high sensitivity and discrimination. And this instant inference is available on the platform. And we will be able to randomize patients based on which arm they belong to and which arm their cluster belongs to. And it will lead to initiation of risk-reducing therapy for CV risk, including ACE inhibitors or angiotensin receptor blockers and beta blockers. And this is where Khushi Baby's effect becomes completely relevant, is that we can use the community health integrated platform or CHIP along with the network of our health system or community health workers that we have built over decades in India and use them for outcome monitoring in a more cost-effective manner and be able to, one, not only solve the problem of deploying a technology like this and solving the hypertension-related cardiovascular risk, but also become among the first few pilot studies that demonstrate that this can be done at scale and large-scale research can be done using a digital health platform. So what is my ask for today? Our goal today is to build an academic partnership or leadership. As somebody who is at Yale University but has strong ties to India, I understand the value of on-the-ground leadership to ensure we can deploy this at scale and actually do this rigorously and effectively for our people. Our goal is to now define together scope and funding needs so we can go back to funders both locally and nationally and internationally to identify those who would fund such an effort. And then to work towards an IRB approval that is, understands the rights of people but makes it low risk. And then we should conduct a pilot investigation testing the technology in a setting like this before we launch the full study that assesses an intervention. And if you...
That's what we are trying to get to, so that way doctors that are stationed there know which medicines to prescribe in a timely manner without the need of an echocardiogram of the heart, which is what will be the game changer. In India's context, we know that ultrasound is limited due to various concerns with sex determination of the fetus. But imagine how powerful this type of innovation can be when we can better understand who is at risk of early cardiovascular disease, get them on the right treatment, because every 30-year-old person who comes through the Health and Wellness Center will be screened for non-communicable disease. They will be screened for hypertension, for obesity, for diabetes. And what can we do to move that screening one step forward? It requires research, it requires partnership with the government, and it requires us to work together. So, I'm very thankful for Dr. Kara for sharing that. And I'd like to now invite our last speaker to the stage. We're very, very thankful to have Kiran sir here with us today. Kiran Anandam-Pillai is one of the founding members behind the vision of the Ayushman Bharat Digital Health Mission. He serves as the technology advisor to Government of Karnataka's Department of Medical Health and Family Welfare. He's the CEO and founder of IDRC as well, and a personal mentor as well to us in our work as we've been collaborating over the last 6 months. It is my distinct pleasure to welcome him to the stage to share with us about a future vision for what health and wellness centers can look like. Thank you.
Hey, good evening, everyone. I know I'm the last speaker standing between traffic and all of you, but I want to just take a few minutes to at least talk through what the thought process for technology at health and wellness centers should be. These are many ideas. I think I was very happy to see a lot of different technologies being actually presented on the stage, and it really looks like a very exciting future. I think we keep talking about 150,000 health and wellness centers and how there's one health and wellness center for every 5,000 people. I always start with the fact that we should remember that everybody who lives around that health and wellness center actually has a choice. They have a choice when they have a problem, whether they want to go to that health and wellness center or not. So usually when I'm talking to various people in the government, I start with the fact that, hey, you need to win back that trust that lets people choose your health and wellness center as the place where they want to go for care. And I think that is actually the big challenge. In my mind, government as a delivery entity for care has a huge challenge of winning back the trust that they will be the best. So they still do a great job in certain things like maternal care, vaccinations, but it's not necessarily the case for the whole wide range of problems that people have. And so the question that I think I started asking was, what would make that happen? You know, what would be the differentiators that could really make people choose a government health and wellness center as the place of choice for their care, right? And so came up with 4 key things that we may have to look at as we kind of look at this. The first, and it just says medicines, but the first and foremost, and I think somebody talked about how supply chain is actually one of the biggest problems. I mean, how do you expect a health and wellness center to deliver if they don't have the right medicines and the diagnostics available in there? And so that's a very, very key thing. As many of you might have learned, these health and wellness centers are not staffed with a doctor. And there's a huge perception that people have that, I need to see a doctor for my care. So the second question is, can we really make sure that somebody walking in gets the right diagnosis and gets the prescription, right? So what do we need to do to kind of make that happen? And the third, of course, we've talked a lot about vertical data in the context of treating the patient, and especially as we see AI and many things coming in, it's going to be very, very important that we are able to pull the right history and the data of the patient and use it in the context of care. So how do we actually get that to happen? And of course, many times somebody is going to go from the health and wellness center to a higher level, secondary or tertiary care center, and come back. So how do we actually make that continuum of care kind of possible? So these were the 4 core areas I felt that technology could actually help make a difference. So some of the ideas I'm going to talk about here may be a little early in thinking, but that's the direction that I think we are trying to push. So one of the things that we think should happen with public health is that there should be an enrollment. So every health and wellness center ideally needs to know what's the population it is serving. And so one of the first things we think that should happen is an enrollment. I'll talk a bit about some of the things that we think we should capture in an enrollment. But imagine as things go digital, it's actually possible for us to get prescriptions of everybody in that population to say, and especially those that require recurring refills. So why is it not possible for a health and wellness center to actually get a list of what are the recurring prescriptions in my area? And B, if you look at and talk to most governments, they do not have the logistics to get from their central procurement medicines actually all the way to the health and wellness center. Many times it goes up to the district hospital, the taluka hospitals, sometimes to the PHCs depending on the state, but not always to the health and wellness center. So one of the things that we may actually have to think about is new logistics and ways by which maybe a central packing and a distribution through the postal department, because the quantum of drugs is much, much smaller in this case. So that's one of the key areas that we believe that technology should work on. The second thing that I think technology should work on is actually accountability for the medication and pieces that are actually being distributed in tests. So line item, today we don't really have line item capture of who actually got what medicine, was it actually dispensed. So one of the things, in fact, I was very happy that the Khushi Baby team did some work with facial technology, because if you go sit in the health and wellness center, you'll see that most patients come in, they don't bring any form of ID, which actually says who they are. And so one of the trials that we're trying to do is if it's only 5,000 people, face rec is at a point where you can actually identify that person just by using a little camera. So can we actually use such technology to find and fast dispense medicine, but also bring tracking and accountability into it? So these are some of the kind of ideas that we are working in terms of what tech we want to bring in. I should also add that we have, and it will come, I think will come in. The second thing I think we talked a lot about, and just in the previous presentation we saw that there's going to be lots and lots of new point of care devices that's actually going to enable telemedicine, right? So I have actually worked extensively with telemedicine for ENT, for Ophthal, for Dharma, all of them, everything requires good devices and a certain set of devices. We saw small devices in the case of cardiac. Now, if you think from the government's perspective, which devices are they going to procure? Which ones are they going to deploy? How do they keep, just with the one device, which is the most important device to get the whole thing going, the government has a policy that they'll give a tablet to A&Ms and they'll give a tablet to CHOs. Most states are struggling with procurement. Most states don't have a good policy for once the tablet goes out and let's say a tablet doesn't work, or just because somebody intentionally breaks it doesn't work, how do they actually get that cycle going? So in my view, the key thing is in terms of coming up with an approach for how this should happen. So this is just an idea for how that needs to happen. My thesis is that the government's role should actually be to think about what are the kind of tests. So for example, if it wants to do an ECG, like in the previous thing, the focus of the government should be, hey, I should be able to work with any device as long as the device provides a standard output. This is exactly what we did in UIDAI when the whole Aadhaar program started. Every vendor used to generate a biometric output from their thumb machine, which was different and proprietary. And what UIDAI did said, hey, if you want to participate in this biometric project of ours, I will work with any device as long as it provides one standard output, but it can come from any manufacturer, and you have to go through a certification process. So I think India is going to need something like that for health and wellness centers, where it says, okay, these are the IoT devices that we might ultimately require, but what we would want to look for is to standardize the inputs and how it actually plugs in into the technology, but allow innovation to happen in the actual device cycle. That's one part of it. The second part of it is to actually not procure the devices, but probably consider using them on an empanelment on a service model. I think it's going to be more interesting saying, pay per ECG rather than pay for the device from a capital perspective. So these are innovations or ways in which we can make sure that the devices get there, are actually maintained, and there are no major service issues from a government perspective. The last thing I think, and this is a big problem because most pieces that we see today are still very vertically focused. As many of you might know, healthcare workers in India tend to use about 4 to 5 apps across each of them, and in almost all cases, they usually don't see data across this. One of the problems that we tried to solve this was through ABDM, but I can tell you that on the ground, it's still a struggle. So this is something that we are trying to solve with one of the pilots that Khushi Baby is participating in Karnataka. So the key idea here is, and the idea with ABDM was actually quite simple, right? We said, hey, can we make sure we identify the patient, the same way across all of our applications? So that led to the creation of ABHA. We wanted the RCH app, the NCD app, the Nikshay app, all of them to identify the beneficiary by the same way. And then we said, can each of these applications decide what is the information that's important for the continuum of care and link that to the ABHA so that it's available to other parties, right? So these are the two key ideas, that is identifying the beneficiary and linking the data. But the core thing that we are seeing is that as we kind of go into it, most applications on the ground have the ability for you to link an or create an ABHA, but the actual health worker does not do it. So the very first step and the idea that you'll identify the beneficiary by ABHA is kind of being lost. And if you don't actually add the ABHA in, there is no way you can link the data. So here's an idea that we are trying out in Karnataka. So what we said is, can we actually create a simple application? And that's what our Health and Wellness Center application does. And that will take responsibility for identifying the beneficiary, making sure there is an ABHA, and then when we need to do an interaction with an NHM app, we will actually transfer that information. So in the case of eSanjeevani, what happens today with the Health and Wellness Center app in Karnataka is that the health worker or the CHO basically logs into the app, registers the beneficiary with ABHA, and then when they want to do a teleconsult, they can click on the eSanjeevani icon. We first automatically log them in with credentials that's been issued by eSanjeevani. So you don't need to actually remember that login. And then we pass the ABHA to it. And we now, because eSanjeevani has the ABHA, the doctor on the remote end, whenever they write a prescription, the idea is that they can now link that to the ABHA, and the Health and Wellness Center app can actually get that prescription back through eSanjeevani, through ABDM. And so this is the idea that we are trying to do, but we wanted to really do this across all of the apps. So the Health and Wellness Center app in the phase 1 is going to take responsibilities for, and we want this as a single app that will actually be used by all healthcare workers. So that's the list of healthcare workers on the bottom: ASHAs, A&M, CHOs, MOs, staff nurse, and so on. So it's pretty much everybody in the primary care pipeline. The second responsibility we want to take care of is to make sure that all of the beneficiaries in that catchment of the health and wellness center have a way to be quickly identified, have ABA for all of them, and B, we can actually capture treatments that happened either at the health and wellness center or at the PHC, but also we can integrate seamlessly with existing NHM apps. And I know Chip had a thing of replacing some of these apps. This strategy actually tries to collaborate with the apps in a slightly different way, but also tries to get the data back, but also pushing things out in terms of reducing the workload of these health workers, in terms of automating reporting for things. For example, every time they do a lab test, they have to file that into an IHIP. So can we actually push the data directly into IHIP? Can we actually manage those inventories and so on? So this is an initial idea that we're working on, still some distance away, but not very far away, and it'll take some time to have it. But another interesting that has to go hand in hand with that is policy. If this has to happen, all of these frontline workers need to have digital devices to be able to operate. And so the next question is going to be, okay, where's the money for doing all of that? We still don't yet have money to give tablets to ASHA workers in many states. I think there are only 2 or 3 states that have actually managed to get there. So in Karnataka, we are also working on a bring your own device policy. So just about starting, which has got some good traction. And the idea is, when we did a small survey, we found that almost 60 to 70% of these existing people already have a smartphone. And the question is, can we pay them a small incentive and get them to bring that and use the same smartphone for work? So the government's working on one that at least eliminates the procurement problem, but also encourages all of these health workers to bring technology. And if they don't, and the first step in my mind for a lot of the ideas that I saw today is to make sure that every one of these people have a good smartphone. And the idea is they would get a smartphone, they would install the Health and Wellness Center app, and that app would tell them that it's actually compatible and capable for all the things that we want. And if yes, then the government would then start paying you a monthly money incentive. At this point, we computed that to be about 250 rupees a month for you to bring your device to work. So let's see how that plays out. But these are all a bunch of ideas that we are hoping will come into play. And we are pushing for making sure that all of this development is done in open source, so that it's available for any state if the pilots succeed to then take it forward. Thank you.
So some really interesting points, I think. One is on direct benefit transfers to the health workers. Completely agree. That is something that can be automated. We have UPI nowadays, right? Why do ASHA workers have to wait 2 to 3 months to receive their benefit? It can be done the same day after verified by the A&M supervisor, and it can go directly into their digital bank account. Same thing applies for data plans. In Rajasthan, actually, 50,000 ASHAs are using their own phone already. And we estimate around 1/4 of them to 1/5 of them became first-time smartphone owners because of these digital health programs. Before, it was their spouse who was holding the family phone. So really, we do, digital health has a huge potential to empower these frontline health workers, but we have to push it along the way. One thing is that we need to get rid of the paper. So we have a 3I strategy. Make things ink-free, so get rid of the paper. Second, incentivize. So have these automated mechanisms for incentivizing the work. And 3, the most important thing, I would say, is integrate. So that's why we're all here today, to have a way for all these different solutions, all these different platforms, all of these different AI, IoT applications to be in one place, one integrated, one-stop solution that the health worker can go to and not have to juggle. So those are the 3 I's, and I think we need to work together to accomplish those. It really will take a collaborative effort. And the one other thing I just want to mention, building off of the panel for innovative financing, I will encourage all of the people that are looking into this to think about how you can pay community health workers on a per care delivery basis. So what the government is already doing, how can other funders beyond the government also get involved in basically incentivizing high performance care at the last mile? That's also something that the technology is available for, that we can work to facilitate. So, and finally, we have to work together in an open source and collaborative way. Thank you, Kiran sir, for mentioning that. That's also part of our ethos, and we're very lucky to be working with you in partnership in Karnataka on our pilot. I'd now like to bring to the stage my partner in crime, Mr. Mohammed Shahnawaz, who has been by my side for the last 9 years, Khushi Baby's Chief Operating Officer, and the person behind the scenes who really, while I'm in the US, is making sure that things are running smoothly here. I would not be able to be here without my better half. And also, I'd like to welcome back Neeraj Jain back to the stage to give a little bit of good news about our new partnership. So, in short, we're going to be working together in Maharashtra, and we're happy to be in collaboration. So, the point of the summit is to collaborate, and we're eager in the first quarter of 2024 to be bringing CHIP to the Satara district of Maharashtra. So now we are actually at the end. Finally, we've made it. Congratulations. However, please save your round of applause for the team that has actually put in an incredible amount of work over the last 6 months to make this event possible. I'd like to actually invite our HR and admin lead, Mr. Ajay Sharma, who has been working behind the scenes tirelessly to give the final vote of thanks before we all will leave.
Thank you, Ruchit. As we all know, that an event cannot end without the vote of thanks, and I have privilege to take this opportunity. Thank you for that. First of all, good evening, everyone, all the delegates, panelists, esteemed panelists, speakers, and my fellow colleagues who are present here and who has joined virtually. On behalf of Khushi Baby, it is my honor and privilege to extend heartfelt gratitude for your gracious presence here in the Khushi Baby Stakeholder Summit 2023. Today we stand united in the sprint of collaboration, innovation, and shared commitment toward advancing healthcare and technology for the greater good. Firstly, my sincere thanks go out to our esteemed panelists who are present here and who also joined virtually. Your insights and expertise has enriched our discussions and inspired forward-thinking solutions. We extend our deepest appreciation to the representatives from different development partners, funders, and research collaborators who have played a crucial role in shaping Khushi Baby's impactful initiatives. I would like to extend deepest gratitude to the Department of Health and Family Welfare of Central Government of India, Government of Rajasthan, as well as Government of Karnataka, and National Health Authority for their constant guidance and support in taking our shared vision and goal of strengthening the community health services on the path of success. Your commitment to advancing healthcare infrastructure is instrumental in driving positive change, and we are honored to collaborate with all of these agencies. I feel privileged to extend my sincere thanks on behalf of Khushi Baby to all the national and international funders and donors for their ongoing support. Their commitments has provided Khushi Baby with the strength of continuing succeeding. मैं विशेष रूप से धन्यवाद देना चाहूँगा जो ज़मीनी स्तर पर हमारे स्वास्थ्य कार्यकर्ता काम कर रहे हैं, जिनके सहयोग से हम अंतिम छोर पर बेहतर एवं सुगम स्वास्थ्य सेवाएं पहुंचाने के अपने सपने को साकार करने में सक्षम हो पा रहे हैं, जिनमें से विशेषकर मैं नाम लेना चाहूँगा हमारी आशा एवं ANM बहनों का, जो आज हमारे बीच मौजूद थी लेकिन उनको जाना पड़ा क्योंकि कल को उन्हें वापस अपने काम पर जाना था, इसलिए। इसके अलावा मैं लास्ट में आई वुड लाइक टू एक्सटेंड माय थैंक्स टू द खुशी बेबी टीम for their tireless efforts in ensuring success of this event. Acknowledgement goes to the team led by Ruchit, Shanwas, Arul Srinivaasan, Hemant, Pranav, Rajiv, Hamid, Vijendra, Pavan, Sarfraj, Huzefa and Jagannathan. These are some names of our leads. At the same time, I would like to not to lose opportunity to acknowledge contribution of our organizing team and logistic team, who have been working day and night since more than 1 month to consolidate their efforts to make this event successful. To name, I would like to name Richa, Shweta, Urvashi, Nabi, Arjun and Rabindra and Anwar, who are also present here. They can stand. Last but not least, I would like to a big shout out to the AV team of Tarun Grover, who has consolidated all his efforts in making this event successful, and everything you are seeing, the setup has been created by Tarun Grover's team. I think he is not here. Oh, thank you. In closing, I would like to say, let us carry forward the momentum generated in this summit to work together for betterment of community health, which is also our aim and goal. Your presence and input made this event a success, and we are excited to keep working together for healthier commitment ahead. Our team is here. Ruchit, I would like you to also join. Shanwas. Ruchit, can we call everyone?
Sorry?
Can we call everyone, all the team members?
Yeah, so, I mean, first let's recognize the organizing team that, they've literally not slept for a month. Honestly. Not literally, but figuratively, they've been working very hard on this event. And, it wouldn't have been possible without them. So really, truly, thanks to them for all their hard work. And thank you all, actually, for being here, for staying with us for 8-9 hours, I don't even know. We will have one group photo on the main staircase outside. So we'll walk together as you are all leaving. Bring your stuff with you. And we'll take one group photo before you face the Delhi traffic. So again, if you want tea, we have tea, but let's make sure we get the group photo first. Hemant, yeah, please, come on. Yeah, you're on the team as well. Yeah, okay. I mean, honestly, again, Khushi Baby team, please stand up. We can't have you all on the stage, it'll probably break. We have 75-member team. Again, if you look around, this is the team that has been working day and night, going to the last mile to make things possible. And really, I cannot recognize everybody. I don't have time to say everybody's name on the stage, but really it's a team effort. So if you should leave with one thing, you should know that Khushi Baby is nothing without its team, and our superpower or our special sauce is our team, the unique team of individuals that have dedicated themselves to this valuable mission. So thank you all again. We'll have a photo at the grand staircase outside. The Spocks will lead you there, and then you can come back for tea and networking as you wish. Thank you all. And after the group photo outside, the Khushi Baby team will reorganize on the stage for one team photo.